Is it audible now? Can you respond? Can we go ahead? Yes, yes. So Kuldeep, it is audible, na? Okay, thank you. Thank you so much. Thank you. Thank you so much. And let me start the session. A very good morning to all of you. I welcome you all for today's session. And I am Dr. Priyanka Sachdev here. Those who don't know me, who are listening the lecture for the first time. So I will start the systemic pathology today. So in today's session, in non-stop marathon of 7 to 8 hours, we are going to complete entire systemic pathology in the super simplified manner. Okay, so entire systemic pathology I am going to cover today. So basically in the entire systemic pathology, I will cover all these systems one by one, the most important topics from these systems. So I will start with blood vessels, followed by CVS, followed by CNS, then breast, then I guess endocrine, then GIT, then renal, then respiratory, liver, male and female, genital will be in the end. So I will cover all these systems one by one. Okay, so without wasting any further time, let's start with the first system. I will take all these 12 systems today. Okay, but the important topics, not all the topics, which are most important, ultra important, repeatedly asked topics. Because in the 6 to 8 hours, we can cover the important topics only. Okay, so the high yielding topics, let's start with the blood vessel. In the blood vessel, I'm going to teach you aneurysm and aortic dissection. So let's start with aneurysm. Okay, what is aneurysm? What is aneurysm? Can you tell me what is aneurysm? So you know the wall of the blood vessel have 3 layers: intima, media, externa. This is the wall of a blood vessel. The arteries or the blood vessels have 3 walls: tunica intima, tunica media and tunica externa. If there is focal weakness at any point in the wall of the blood vessel, there is protrusion, outpouching or protrusion is produced. This is outpouching or protrusion. Outpouching or protrusion is produced at focal one point because of weakness of the wall at that particular point, and this is known as aneurysm. So what is aneurysm? Can you tell me what is aneurysm? Aneurysm is abnormal dilatation of the wall of the blood vessel because of focal weakening. The weakening can be congenital, can be acquired. So because of the weakness of the wall, focal weakness, there is a outpouching, and that outpouching is known as aneurysm. So you all can see here we have drawn an aneurysm because of focal weakness of the wall of the blood vessel at one particular point. It can be congenital, it can be acquired, the weakness, right? Now what are the clinical features? If someone is having this outpouching, is it bothersome? Does it produces any symptom? Now when the blood is flowing through this blood vessel, you can imagine the blood will have stasis here. Normally blood keep on flowing, keep on flowing, keep on flowing, but here the blood will have stasis because it is the outpouching. Now stasis, yesterday I taught you general pathology. In Virchow triad, stasis was one of the risk factor and it will lead to thrombus formation. So it will lead to thrombosis. It will lead to thrombosis. Okay, thrombosis. Till it is attached to the wall, it is thrombus. Once it gets detached, it is embolism. Yesterday I taught you that also. So thrombosis is the clinical feature. Embolism is the clinical feature. Okay, you can see here the blood is showing the stasis. That's why it is showing thrombus formation. Once the thrombus get detached, it is embolism. Right, sometimes it can get ruptured. It is a medical emergency. The aneurysm can rupture at any of the blood vessel. The major blood vessel start bleeding, internal bleeding. It's a very emergency condition, and sometimes it can cause compression of the surrounding neighboring structure. Can you see there is an aneurysm here? See the aneurysm, and can you appreciate this is a nerve? If you can appreciate, the aneurysm is compressing the nerve. So the patient will have neuropathological symptoms. So these can be the clinical features. Yes, the PDF will be available after the session. Yesterday also I put the PDF on the Prosium Telegram channel. Today also Dr. Bhanu Prakash Prosium Telegram channel, I will put the PDF just after the session. So please concentrate on the session, and if you don't write, it's okay. I will provide the PDF, the exact PDF. Can we go ahead now? Can we go ahead? So this is the clinical feature. You understood what is aneurysm. You understood the 4 clinical feature. Number 1, thrombus formation. Number 2, embolism. Number 3, rupture. Number 4, compression of the surrounding structure. These are the 4 clinical features of the aneurysm. Now let me tell you 3 type of classification of aneurysm. How to classify it? The first classification based on the composition of the wall. It is of 2 types. What are the 2 types? True aneurysm and false. False aneurysm, also known as pseudo-aneurysm. The false one also known as pseudo-aneurysm. What do you mean by true and false? Okay, I told you the wall of the blood vessel have 3 layers: tunica intima, media and externa. Okay, so tunica intima, media, externa. If all 3 are protruding out, intima, media and externa, if all three protruding out, so the wall of the blood vessel is made up of all three layers, it is a true aneurysm. You can see the wall. Please appreciate the wall. Here you can see the wall contain all three layers, tunica intima, tunica media, tunica externa. It is a true aneurysm. True means real aneurysm. This is the meaning of the true. The true contain all the three layers, intima, media, externa. Can you see a normal blood vessel here? See the tunica intima, this is media, this is externa. Here also intima, media, externa. See, all three are protruding out. Intima, media, externa. All three are protruding out. This one is a true aneurysm. You all can appreciate, I guess. Okay, see the second possibility. There is a defect here. There is a hole or defect, or there is an injury in the wall of the blood vessel. So what will happen? The person will start bleeding. This is the bleeding. To concise the bleeding, body have a protective mechanism. The body will form a connective tissue covering. I am using the word connective tissue covering. A connective tissue covering to concise the bleeding. Now it is looking like aneurysm, but it is not aneurysm. Actually, it is a hematoma. You can see it's a hematoma. Now the wall is made up of connective tissue. The wall is not made up of the three layers, tunica intima, media, externa. No, the wall is made up of connective tissue. It is looking like aneurysm but not aneurysm. That's why it is known as pseudo aneurysm or false aneurysm. Give me a thumbs up now. Please give me a thumbs up. Got it? Got it? So this is the two type of the aneurysm we have learned. The true aneurysm, the false or pseudo aneurysm. You can understand. So based on the composition of the wall, if the wall of the aneurysm contain all three layers, it's true. If the wall contains fibrous thickening and connective tissue, it is a hematoma. It is known as false aneurysm. This is the first classification. The second classification based on the shape. There are 5 type of aneurysm. See, the first one is the secular. Secular means unilateral protrusion, unilateral in one of the side, unilateral, that is secular. The second is the fusiform. Fusiform is completely circular all around. Protrusion is all around, not in one direction, it is all around. So this one is fusiform, you can say it's like this, but this one is the first one is the secular and this one is the fusiform. I hope you can understand the difference between secular and fusiform. The third is the cylindrical, in which a long parallel, you can see the parallel aneurysm is formed. The two walls are parallel to each other, like cylindrical. The next is the serpentine, in which multiple small aneurysms are formed in continuity. It's serpentine. And last one is the racemose, in which multiple blood vessels are interconnected with each other, forming a racemose or a sarcoid. So these are the 5 types based on the shape. Fusiform, secular, cylindrical, serpentine and racemose. Please see. Okay. The third classification based on the pathological mechanism, who is causing the weakness. I told you this is the blood vessel. In the wall of the blood vessel, there is a focal weakness at one point. At that point, the wall of the blood vessel protrude out. So you should ask me a question, ma'am, who is causing this weakness? What is the cause of the weakness that is leading to the protrusion? So cause of weakness can be 3, based on which 3 type of aneurysm are there. The first reason for the cause of the weakness can be atherosclerosis, most important. 90% time the cause is atherosclerosis. So focally there is a atherosclerosis, because of which the wall got weakened and there is focal protrusion of the wall producing the aneurysm. Number 1. Number 2, there can be syphilis. You know syphilis, there are 3 types of syphilis, primary, secondary, tertiary. In tertiary syphilis, the wall of the blood vessels can be involved, producing and arthritis in the wall of the blood vessel. That is producing this weakness and that is causing the focal protrusion. So such an aneurysm which is caused by syphilis, the weakness is caused by syphilis, it is known as lutic aneurysm. Lutic aneurysm is due to weakness produced by syphilis. It's very important PYQ. And atherosclerosis, the aneurysm also known as atherosclerotic aneurysm. Atherosclerotic aneurysm is due to atherosclerosis. Lutic aneurysm is due to syphilis. And third cause is infection. Imagine if any infection occurs. It can be bacterial, viral, fungal, parasitic. Any infection is caused in the wall of the blood vessel producing vasculitis. Any infection that causes weakness and that is producing the aneurysm. So such an aneurysm which is caused by the infection, any infection, it is known as mycotic aneurysm. So there are 3 types of aneurysm: atherosclerotic aneurysm due to atherosclerosis, lutic aneurysm due to syphilis, and mycotic aneurysm due to infection. So basically, who is producing the weakness? There are 3 types of aneurysm. Give me a thumbs up. Got it? You can read the 3 names. The 3 type of aneurysm. Atherosclerotic, as the name clarify, it is due to atherosclerosis. 90% is this type only. The second is lutic. Lutic is due to syphilis. It's very important PYQ. And third is mycotic. Mycotic is due to microbial infection. Now it's a misnomer. Looking at the word mycotic, you may think it's fungus only. It is not only fungus. It can be bacteria, virus, parasite or fungus, anything. You got it? Can we go ahead? Say yes. So let me describe the atherosclerotic and syphilis a little bit detailed. Atherosclerotic is the most common, as I told you. Okay, as I told you, it is the most common one. Let me tell you, okay. Let me tell you the location of atherosclerotic and syphilitic aneurysm. They mostly occur in aorta. Do you know what are the parts of the aorta? This is a rough diagram of the heart. This is the right side of the heart. This is the left side of the heart. From the left ventricle, the aorta comes out like this. This is the aorta. We all know that from the left ventricle, this is the aorta. So aorta, what parts aorta have? This is ascending aorta. This is arch of aorta. And this one is descending aorta completely, right? Now descending aorta is divided into two portions by the diaphragm. So above the diaphragm, it's thoracic aorta. The descending aorta is known as thoracic aorta, and below the diaphragm, it is known as abdominal aorta. We all know that, just revising. Okay, now the abdominal aorta again divided into two portions. Above the renal artery, so you can see from the aorta the renal arteries are coming out. These are the two renal arteries supplying the two kidney. So suprarenal and infrarenal. You can see this portion is suprarenal and this portion is infrarenal. So tell me the two aneurysm. I told you three important causes of the aneurysm. Atherosclerotic aneurysm, lutic aneurysm is due to syphilis, and mycotic. So tell me their most common site in the aorta, right? Most important PYQ. Let me draw atherosclerotic. The atherosclerotic one is in the infrarenal portion, to be very specific. It is not in ascending aorta, it is not in arch of aorta, it is in descending. In descending, it is not in thoracic, it is in abdominal. In the abdominal, it is not in suprarenal, it is infrarenal. To be specific, this is the most common site of atherosclerotic aneurysm. Please pay attention. Okay, in the lutic, the most common site is the thoracic aorta. The thoracic aorta followed by ascending aorta. Sometimes it can occur in ascending aorta also. So you can see I have marked the location of the atherosclerotic aneurysm as well as lutic aneurysm. Let me highlight. Atherosclerotic aneurysm occurs in infrarenal portion of the abdominal aorta, descending aorta. And let me highlight the position of lutic aneurysm. Lutic aneurysm occurs in the thoracic followed by ascending. Everyone give me a thumbs up. Please learn that. It's a very important, confusing questions are there. So let's go ahead. Atherosclerotic aneurysm is the most common type. It occurs in infrarenal portion of the abdominal aorta. You can see these are the renal arteries. So it is infrarenal. Appreciate infrarenal location. It is fusiform. And lutic one, it occurs in tertiary stage of syphilis. It occurs in thoracic aorta. You can see it occurs in either thoracic aorta or ascending aorta. Okay, and it is secular in nature. Okay, yeah, two more things I would like to tell you here regarding the lutic one. Whenever lutic one, let me draw it. Okay, let me draw the heart once again. From the left ventricle, let me draw the aorta. This is the aorta. So I am interested in lutic one now, syphilitic one. So I told you sometime it occurs here in the ascending aorta, here. So just what is there, the structure? This is the aortic wall. So because of the aneurysm, the two walls, the semilunar walls get opened up, you know, and it will lead to aortic regurgitation because of the aneurysm. Because of the syphilitic aneurysm, you can see this is syphilitic aneurysm producing the dilatation here in the ascending aorta just near the aortic wall. So because of which this aortic wall get aortic regurgitation, because of which there is more and more blood in the left ventricle, because of which to compensate, what it will do, to compensate, the wall of the left ventricle go on thickening. It will produce left ventricular hypertrophy, because of which the heart size is very big. And it is known as cor bovium. What does it known as? Cor bovium. What do you mean by cor? Cor matlab, I'm sorry, cor means big size. And what do you mean by bovium? Bovium matlab cow. Cow ka heart. It is looking like heart of a cow. It's human heart looking like a big cow heart. The cow heart is big in size. That's why it is looking like that. That is known as cor bovium. Okay, so you should learn the word cor bovium for lutic aneurysm, number one. Number two, if you cut and open it, inside there is a wrinkling and calcification. The wrinkling is looking like the tree bark. Can you see the bark of a tree? This is the bark of the tree. Appreciate the aneurysm inside. It is wrinkled. The wrinkling is looking like tree bark appearance. I'm talking about syphilitic aneurysm. And it is having calcification also. So learn 3 points. 3 important points regarding syphilitic aneurysm. Tree bark appearance, calcification, cor bovium. Everyone give me a thumbs up. Everyone give me a thumbs up. Everyone. You got it? Learn the 3. All 3 are PYQs. Okay. So we are done with aneurysm. Do you have any doubt in that? Shall I move to the next topic? The next topic is the aortic dissection. You have to be interactive, huh? If I'm asking something, please respond. If you have any doubt, please write down. So let's start aortic dissection. We are done with aortic aneurysm. Now coming on aortic dissection. What is aortic dissection? As I told you, in the wall of the blood vessel, there are three vessels. There are three layers: intima, media, externa. Imagine in the intima, if there is a tear. If there is a tear, can you see there is a tear? A small tear. So what will happen? Only in intima. So blood from the main lumen, it will go in the intima. It will go in the tear of the intima, and blood is dissecting the media. The media is very thick. Intima is very small. The adventitia is also very thin, but media is a thick layer. You know. So blood is entering from the intimal tear and dissecting. I'm using the word dissection. Dissecting the layers of the media into various fragments and forming a channel in the media. So you can see two blood channels. This is true blood channel. This is false blood channel. True and false run parallel. True lumen is true lumen. Okay. And from the true lumen, blood is going in the media and forming one more channel parallel to the main lumen. So pseudo lumen can be there. So this is the cross section of the same diagram. If you cut it from here and look from above, it looks like this. Can you see here? It looks like this. So please appreciate the tear in the intima. The blood is entering from the intima and dissecting the media. So it is very painful condition. The patient say inside the chest, it usually occurs in aorta. Inside the chest, in the aorta, patient is feeling like a stabbing pain. Stabbing, someone is dissecting with the knife. Someone is cutting with the knife. It is that painful condition. Because who's doing the dissection? The blood is doing the dissection. That's why it is known as aortic dissection. Dissection like with a knife. With a scalpel, someone is cutting the aorta. The pain is that excruciating pain. Severe pain. Say yes, you got it. Okay. So when blood separates the planes of the media to form one more blood-filled channel which is parallel to the main channel. So this is aortic dissection. So you should ask me, ma'am, why there is a tear? Why there is a tear? You are seeing from this tear the blood is entering now. So what is the reason for this tear? The reason for this tear, 90% time, the reason for this tear is hypertension. If someone is having high BP, more than 120/80, long time, and the person is not taking treatment, because of that high blood pressure, there is a tear. There is a tear and the blood is going in the media and dissecting it. Because of that, this is hypertension, 90%. But non-hypertensive causes are also there. 90% it is hypertension, but among the non-hypertensive causes, it is Marfan syndrome. The most common cause is Marfan syndrome, in which cystic medial degeneration is seen, because of which there is a tear in the intima. Say yes if you got it. Say yes, got it. So this is the thing. You can see morphologically, can you appreciate a tear here? Everyone say yes. Can you appreciate a tear here? So from this tear, the blood is entering and dissecting the media. Dissecting. You can see two channels. One is main channel, main lumen, and one is pseudo. Sometimes what happens now? From this point, the blood is entering, and you can see this is the tear. The blood is entering from here, and after traveling inside the media, after certain distance, there is one more tear and blood is coming out. So a small channel is formed. From here to here, blood is entering from one point and exiting from other point. I must say the blood is entering from the proximal tear and blood is exiting from the distal tear. So two tears. This is known as double barrel aorta. What is it known as? Double barrel aorta. If you cut it from here, you can see the two lumen. This is the true lumen and this is the false lumen. True lumen, false lumen. Double barrel aorta. Learn this term. Double barrel aorta having two lumens. Okay, everyone got it? Can we go ahead? This is double barrel. It's very important PYQ. What is double barrel aorta? So double barrel aorta is the aorta in which two lumens are seen. One is true lumen, one is false lumen, and it is seen in aortic dissection. The most common cause of aortic dissection is a tear. The tear is caused by the hypertension, most commonly 90%, and among the non-hypertensive causes, the most common cause is the cystic Marfan syndrome, cystic medial degeneration. Am I fast or is it good to go? You got it? Can we go ahead? Let me do the classification of aortic dissection. How to classify aortic dissection? There are two schemes for classification. Stanford classification, D. Baker classification. Let me explain you both. Okay, can you see this diagram? In this diagram only, I will do both the classification, that's DBK as well as Stanford. Okay, please everyone have a look on this diagram. Let's do DBK classification. DBK classified the aortic dissection in three categories: DBK category 1, DBK category 2, DBK category 3. If the dissection involves complete aorta, you can see the dissection is involving complete aorta, the ascending also, arch also, descending also, it is known as type 1. If only ascending aorta is involved, it's type 2, and if only descending aorta is involved, it's type 3. It's very easy to learn. Complete, ascending, descending. Type 1, type 2, type 3. DBK is very easy to learn. Let's come on Stanford classification. So please everyone here, listen. Stanford classification. DBK type 1 and 2 is Stanford A. Stanford A include both. Stanford A include complete also, ascending also, and Stanford B is only descending. Say yes if you got it. Say yes. So DBK type 1, type 2, type 3. This is DBK. DBK classification. Okay, in type 1 it's the complete aorta involvement. In type 2 only ascending is involved, and in type 3 only descending is involved. And what about the Stanford classification? DBK type 1 and 2 Stanford type A, and DBK type 3 is Stanford type B. So in Stanford classification we have only type A and B, not C. Say yes, this is Stanford. Stanford. So this is important although in surgery, but I have covered the classification here so that any MCQ coming you can solve. So that is all about the Stanford classification and DBK classification. You can read the theory. We have done the classification also. We are done with 2 topics till now. In blood vessel I have covered aneurysm and I have covered aortic dissection. Does anyone have any doubt till now? Can we solve some MCQs on that and move on the next system? We are done with blood vessel. After that, I am immediately moving on cardiovascular system after doing the MCQ, and I will start with ischemic heart disease and MI. Okay, so this is the first question in front of you. I want each one of you to answer it. Can you tell me the most common cause of abdominal aortic aneurysm? Abdominal aortic aneurysm, the most common cause. Is it atherosclerosis? Is it syphilis? Is it trauma? Is it congenital? I told you 90% time what is the cause. Can you please tell me the answer? Yes, can you please tell me the answer? I am waiting for it. Let's see who is giving the answer. I am waiting. Yes, yes, absolutely right. Absolutely right. So what is the correct answer here? Yes, yes, Vishnu. So correct answer here is the atherosclerosis. So I told you 3 causes of the weakness: atherosclerosis, syphilis, infection. Sometimes it can be trauma also, congenital also. But most common cause, 90% time, it is atherosclerosis. So, and I told you the location also, it's infrarenal. So correct answer here is A. The next question is in front of you. Most common site of atherosclerotic aneurysm. Can you tell me the site? Now don't go on these years. These are for the university exam years, but it is a recent question also, right? Don't go on these years. Can you tell me the answer? Most common site of atherosclerotic aneurysm. Most common site of atherosclerotic aneurysm. Is it coronary artery, renal artery, arch of aorta, or abdominal aorta? Yes, you all are right. Very good. The most common site of atherosclerotic aneurysm is the abdominal aorta. To be specific, in abdominal aorta also it's infrarenal. Infrarenal. Better was the question if 2 options were from the abdominal aorta, suprarenal, infrarenal, right? So better was the question, but correct answer, you know, it's infrarenal only. It's infrarenal. It's not B, it's not renal artery. The correct answer is D. Okay, you got it? Abdominal aorta. The next question is in front of you. Tree bark like calcification is seen in which aneurysm? Syphilitic aneurysm, atherosclerotic aneurysm, Barry aneurysm, or traumatic aneurysm? Tree bark like calcification. So the question is very easy. I guess you all can answer it. So tree bark like aneurysm. I told you 3 important features for syphilitic aneurysm. Yes, the answer is syphilitic aneurysm. I told you 3 important points on which MCQ is there. Number 1, if you cut open it, it is wrinkled from inside. That's why it is known as tree bark like appearance. Number 2, it is having calcification, linear calcification. Number 3, because of which there is aortic regurgitation leading to left ventricular hypertrophy. The heart size is big. It is known as corbovium. All 3 are PYQs for syphilitic aneurysm, also known as lutic aneurysm. So if you know the concept, you can answer any question. Okay, so the correct answer here is A. Can I go ahead? Okay, let's start the next system, CVS. We are done with blood vessel. Let's start the next system, CVS. In CVS, I am going to teach you 4-5 topics. I will start with ischemic heart disease, in which I will first teach you what is angina. Then I will teach you MI, everything about MI, very important topic. Then I will start with endocarditis. I will teach you rheumatic heart disease. I will teach you Libman-Sack endocarditis, non-bacterial thrombotic endocarditis, infective endocarditis. So these are the important, ultra important, high yielding topic we are going to cover in CVS. So in the next, I will give 5 minutes to each topic, not much. So maybe next 30, 35, 40 minutes we are going to cover the system. So in this way, one by one, today we are going to cover 12 systems. Okay, so let's start with CVS. Let's start with ischemic heart disease. Okay, so for understanding ischemic heart disease, you have to understand the blood supply of the heart. You can see here there is a sketch diagram of the heart in front of you. You all have to concentrate here on the left ventricle. Can you all see the left ventricle? I guess all of you can see the left ventricle here. Okay, now when the left ventricle is pumping, what happens? We all know, of course, when the left ventricle pumps, the blood is ejected in the aorta, and via aorta, the pure blood is distributed to all the organs of the body. The left ventricle is doing the systole, it is pumping. Whenever it is pumping, whenever it is doing the systole, the blood is ejected in the aorta and distributed to all the organs of the body. But who is giving blood to heart? Heart is giving blood to everyone, to all the organs of the body. But who is giving blood to the heart? So from the aorta, for pumping, heart also require oxygen. Now, heart also require energy. Energy means ATP. ATP is synthesized or generated from oxygen, and oxygen is present in blood. That's why, like every organ, heart also require blood, because heart also want to generate ATP, okay, from oxygen. So from where heart, the walls of the heart, the walls of the left ventricle, from where they get the blood? So answer is coronary artery. So you can see from the aorta, let me highlight, from the aorta, you can see this purple color artery I am highlighting. It is coming out of the aorta. So this is a coronary artery. This is a big coronary artery. It is known as conductance vessel. From which small coronary arteries are coming out. These are known as resistance vessel. And these are penetrating in the wall of the left ventricle and supplying the blood to the wall of the left ventricle. So in the wall of the left ventricle, the cells are cardiocytes. Cardiomyocyte cells are present. They all get the blood, they all will synthesize the ATP, and they do the contraction. When they do the contraction, systole goes on. So it's a give and take relationship, not only in heart. In this world, we have give and take relationship. Whatever we give, it's come back. It's nature, it's universe. Okay, it is not a spiritual lecture. Let me concise to the point. Okay, so whatever blood you are going to the heart via aorta, the same blood heart will give via aorta. Okay, whatever blood you give to the heart via coronary, the heart will give blood to the aorta. It is known as demand and supply. Whatever you are supplying to the heart, proportion to that only you should demand. So there is a demand supply relationship. Whatever you are supplying, that same you should demand. So you are supplying more blood in the coronary, the heart will give more blood in the aorta. Because if you give more blood in the coronary, the heart will contract more. When the heart will contract more blood will ejected in the aorta. If you give less blood to the coronary, heart will contract less. If the heart will contract less blood will come in the aorta. So it is a give and take, demand and supply, balance relationship. Okay, so normally we all have a balance. So we give blood to the heart via coronary, we ask the heart to contract, and we receive the blood. I mean, all the organs receive the blood via aorta, right? This is normal till now. But imagine if coronary is obstructed, what will happen? If any of the coronary, right or left, whatever coronary get obstructed, what will happen? The heart will not receive much blood. But so in that case, the heart will contract less. The heart will not contract vigorously. The heart will contract less because you are giving less blood to the wall of the heart, right? Heart will contract less, or heart will stop contracting. So aorta will not receive the blood and all organs will compromise. So that is related, that is known as ischemic heart disease. So the wall of the heart is suffering from ischemia. You know, so if you don't supply the blood via coronary, the cardiomyocytes present in the wall, the left ventricular wall, they start dying because they are not receiving the blood. They will have coagulative necrosis. So it is ischemia. That is known as ischemic heart disease. So you understand what is ischemic heart disease? IHD, ischemic heart disease. Ischemia is occurring in the wall of the left ventricle because of less blood supply via the coronary. It is also known as coronary artery disease because ischemia is always due to coronary obstruction. So I can say IHD is equal to CAD, one and the same thing. Ischemic heart disease, also known as coronary artery disease, because ischemia occurs because of coronary obstruction only. The reason. Okay, you got it. So what is the reason for that? The reason is imbalance between demand and supply. I told you the relationship between the demand and supply. You are giving less, asking for more. It is not a way. Whatever you should give, you should ask for the same. In the universe also, whatever you give, ask for the same. If you give less, ask for the more, it will not work. Okay, here also it is not working. Can we go ahead? Can we go ahead? Are you? Yes, everyone. Okay. So for that you have to understand the coronaries now. I will obstruct the coronaries. So you have to understand. Now this is anatomy portion, but I will cover it here. So there are two types of coronary present in human body. From the aorta, two types of coronary are coming out from the arch of the aorta. The left coronary artery, the right coronary artery. The main coronary artery have two branches, left and right. Right coronary artery is known as RCA. It doesn't have any further branch. RCA is the final artery, but LCA, left coronary artery, have two branches. The first is left anterior descending LAD and second is left circumflex LCX. So LAD and LCX are the branches of LCA. LCA is divided into two branches. So finally we are having three coronary. One is RCA, right coronary artery, and two are the branches of the left. What are the two branches of the left? Left anterior descending the first branch, left circumflex the second branch. Now we are having three branches. Let me show you the heart. Okay, can you see this diagram of the heart? Everyone on the screen, please concentrate. If I cut the heart from here and look from above, can I see this section? Let me draw the section. I can see I'm cutting from the ventricular level. So I can see two lumens. This is right ventricle, this is left ventricle, the lumen of the ventricle. I am interested in left ventricle, the walls of the left ventricle. So in between the two ventricles, there is interventricular septum. I can see the interventricular septum also. So basically I am having four walls. This is anterior wall, this is posterior wall, this is lateral wall, and the medial wall is interventricular septum itself, right? So we are having four walls to supply. They all should get the blood because they all have the cardiomyocytes in them. Cardiomyocytes are present everywhere. These are the cells present everywhere. So all the cells, when they receive the blood, they contract, and in this way the contraction takes place, systole takes place. So all the four walls should receive the blood. So we are having three coronaries. We are having three coronaries and four walls. So tell me which coronary supply which wall. Let's start with LAD. Okay, LAD supply anterior wall. Please learn that. LAD supply anterior wall. LCX supply lateral wall. Okay. RCA, right coronary, supply posterior wall. Please learn that. LAD is the main artery, okay, left anterior descending. It is supplying anterior wall and the apex. Lateral wall is supplied by left circumflex, this branch of the left, and RCA is only one. It is supplying posterior. You will say, ma'am, what about the medial wall? You should ask me, ma'am, what about the medial wall? Who is supplying medial wall? We have only three coronaries, not the fourth one. So the fourth wall, the medial wall, is supplied partially, upper 1/3, I mean posterior 1/3 by RCA and anterior 2/3 by LAD. So LAD supply the anterior 2/3 and posterior 1/3 is supplied by RCA. Say yes. This is the blood supply. In short, I told you. Say yes. Everyone, give me a thumbs up if you got it. So please understand the blood supply of the heart. Now this portion is from anatomy, but here for understanding MI and ischemic heart disease, angina, you must know the blood supply of the heart. Then only you will have a better understanding. Okay. So these are the types of the coronary. Now imagine which coronary is obstructed. What is the most common cause of obstruction of coronary? Again, the most common cause of obstruction of coronary is atherosclerosis. 90% of the time there can be atherosclerosis in any of the coronary. Sometimes atherosclerosis most commonly occurs in LAD. So LAD is the most common coronary artery in which atherosclerosis occurs. Just a second. Most common coronary is LAD, followed by RCA and followed by LCX, right? So whatever coronary is obstructed, the patient will have ischemia in that corresponding wall. Ischemia in that corresponding wall. It is not necessarily ischemia occurs in all wall. If all the three coronary get obstructed, ischemia will be there in all the wall. So the type of the MI is ischemia, depends which coronary is obstructed. If LAD is obstructed, ischemia in the anterior wall. If RCA is obstructed, ischemia in the posterior wall. And if LCX is obstructed, so ischemia in lateral wall. So you must ask me the next question, ma'am, what is the sequence? Most common. So most common, I told you, it's LAD followed by RCA followed by LCX. The two left are at the extremes and right is in the middle. Please learn like that. So you tell me the sequence of the wall involvement. LAD supply anterior. So anterior most commonly undergo ischemia or MI. Followed by posterior. Lateral is least common. Right? So please learn the basic concepts. If you know the basic concepts, understanding the disease is fun for you. Can we go ahead? Please interact, right? Please interact. Give me a thumbs up in between that you are getting it. Okay. So this is the blood supply. The same diagram is shown to you. So we are cutting the heart at this level and we are looking from above and you can see the two lumens. You can see the lumen of the right ventricle. This is the lumen of the left ventricle. We are interested in left ventricle walls. So please appreciate the anterior wall is supplied by LAD, posterior wall is supplied by RCA, lateral wall is supplied by LCX. Appreciate the medial wall, the interventricular septum. The upper half I'm sorry, the posterior half is supplied by RCA and the anterior 2/3 is supplied by LED. So give me a thumbs up, everyone. You got it? Can we go ahead? Let's come on the disease. If you understood it, let's come on the disease. So I am teaching you coronary artery disease. There can be 4 presentation. Either the patient have angina because of coronary obstruction, or the patient have MI, or the patient have chronic ischemic heart disease, CIHD, or the patient have sudden cardiac death. One of the 4 things can occur. All 4 will not occur together. One of the 4 things will occur because of obstruction of coronary. If coronary got obstructed, the patient can have one of the 4 presentation. So out of the 4, I will be discussing 2 in detail, angina and MI. Let's start with angina. What is angina? The angina is angina pectoralis. What is it? It is a chest pain. The patient will come to you with substernal discomfort. I use the word substernal. Sternum ke niche, substernal discomfort. It is not actual pain, it is only discomfort. The patient will say, I'm not having pain, doctor, on the little bit left side. Substernally, just below the sternum, a little bit left side, I'm having heaviness, I'm having squeezing feeling, I'm having pressure or choking feeling. It can be pain, it is not pain, but heaviness is there. So I will use the word discomfort. So use the word substernal discomfort. So what is angina? What is angina? Angina is not continuous. The patient have the pain. Between 2 episodes, patient is absolutely normal, like asthma. So between the episodes, patient is absolutely normal. When the patient have the episode, the attack of the angina, at that time the patient have substernal discomfort. And between 2 episodes, patient is absolutely normal. So it is not a continuous disease. It comes in attacks. This disease, angina, comes in attacks. And between 2 attacks, patient is normal. Anything coming in attack in pathology is known as paroxysmal. What it is known as? What it is known as? Come on. What it is known as? Use the word paroxysmal. So please understand, the pathology is not a subject. More of a subject, it is a language. If you understand the language of the pathology, pathology is a very beautiful subject. Okay. So it is paroxysmal. Paroxysmal means the disease is coming in the attack. It is recurrent. Again and again the attack comes. And it is, what is the disease? It's substernal discomfort. It is not pain. It is discomfort. And it is transient MI. The ischemia is transient. The word transient is very important here. I will tell you the meaning of the transient. Okay, the patient comes to you, doctor, I am having substernal pain or discomfort. It comes, it goes. It comes, it goes. Okay, so what is the main problem? The main problem is demand versus supply. There is an imbalance between them. What is the supply? Whatever you are supplying the heart is your supply. You supply the heart via coronary. You supply the heart via coronary artery, you give blood to the heart. So you are supplying the heart. Whatever you are demanding from the heart is from aorta. You want the heart to pump and give you blood via aorta so that all the organs should receive the blood. There should be a balance, right? I'm not saying exact equal. Equal is not the word. Balance is the word. So whatever blood you are supplying via coronary, the proportionate blood you should get in the aorta. If you supply less, if you ask for more, there is an imbalance leading to this. So the reason for the angina is this. You got my point? Okay. Okay, so can we go ahead? So give me a minute, one more minute. Okay. There are 3 types of angina. They are in front of you. Stable, unstable, Prinzmantle. Learn their other name. Stable also known as classical. Okay. Unstable also known as crescendo. And Prinzmantle also known as variant. There are 3 types of angina. Please learn their two names. So I will let you know the meaning. Why it is important to know the 3 types of angina. If you say, ma'am, if the patient is coming to me with a chest discomfort, it's angina. Why we have to divide it in 3 types? Because the treatment of all 3 is different. The prognosis of all 3 is different. Okay, you cannot say it's angina, treat it same. You have to find out the type of the angina and treat it accordingly. Let me explain you the reason for all 3. Let me come on the first angina, the classical angina or stable angina. Among the 3, this one is the most common. The stable and the classical, it's the most common among the 3. This is the most common. Now, what is the reason? I have not drawn the diagram. Okay, let me show you all 3 in this diagram. Please have a look. Everyone, can you zoom it out? Please see here. The 3 types of angina I'm showing you in this diagram. Okay, let me highlight the coronary. Where is the coronary? This is the coronary. This is the coronary artery supplying the blood to the left ventricular wall. Okay, I will do 3 things one by one. First, I am producing atherosclerosis in this coronary. Because of this atherosclerosis, the blood reduction will be there. The blood supply will be reduced in the coronary. And because of which the angina occur, it is known as stable angina. Stable or classical. So stable or classical is due to atherosclerosis. But atherosclerosis never completely obstruct the coronary. It only partially obstruct. So it is not the left ventricular wall is getting 0 blood. No, it's not that. It is getting partial blood. You know, so if someone is having atherosclerosis in one of the coronary artery and the atherosclerotic plague is partially obstructing the lumen, partially partially obstructing the lumen of the coronary. So heart wall is still getting the blood, and that blood is sufficient for basal metabolism. You are giving less blood by coronary, heart will say, okay, you give me less blood, I will also give you less blood, give and take. You give me less partially, I will also contract partially and eject less blood to the aorta. But that less blood is sufficient to all the organs for basal metabolism. If I do nothing, just sitting down, that blood is sufficient for my body. But if I start running, jogging, doing any physical activity, my demand of the blood is increased. You know, at that time, my organs are asking for more blood to the aorta. Aorta will say, okay, let me ask more blood to the heart. So heart is saying, no, you are giving me less blood, I will give you less blood. So basically, the patient have pain only at the time of exertion. Whenever the patient is running, jogging, patient have chest pain. Whenever the patient sit down, the pain disappear. This is a classical angina, the stable angina. And I hope you got the reason. The blood supply is sufficient for the basal metabolism, but it is not sufficient for the exertion or increased physical activity. So at the time of the physical activity, patient have chest discomfort. At rest, it disappear. Give me a thumbs up. You got it. This is classical angina. Classical angina, also known as stable angina. You got it. This is the first type of angina. Let me come on the second type. In the second type, the obstruction of the coronary is still there, but it is not the atherosclerosis. It is some non-atherosclerotic cause. It can be thrombus, it can be calcification, it can be plaque, it can be something else. But it is a non-atherosclerotic cause, and it usually, sometimes it can cause complete obstruction of the coronary. The complete obstruction can be there. So patient can have pain every time, at the exertion also and at rest also. So this differentiates the unstable angina from stable angina. In stable angina, patient have pain or discomfort only at the time of exertion, but at rest it disappears. But in unstable angina or crescendo angina, patient have pain all the time. At rest also, it doesn't disappear. At rest also, at activity also. You got it? Kindly say yes if you got it. Okay. So that is the thing. Okay, so coming on the third type of angina, the variant angina, the Prinzmantle angina. The cause of the obstruction is not atherosclerosis. The cause of the obstruction is not thrombosis. The cause of the atherosclerosis is vasospasm. The third type of angina, the cause of the obstruction is vasospasm in the wall of the coronary. And vasospasm is sudden. Anytime it can come, anytime it can go. So these are the three types of the angina. What are the three types of angina? What is the reason for stable angina? It's atherosclerosis. What is the reason for unstable angina? It's non-atherosclerotic obstruction like thrombosis. And what is the reason for Prinzmantle or variant angina? It's vasospasm. So tell me the treatment of all three. Can you tell me, common sense, treatment of all three? For stable angina, there is atherosclerosis. Now, you will give statins or you will do the stenting. There is no drug which can dissolve the already formed atherosclerosis. For that, you have to dislodge it and do the stenting. For thrombosis, you have to give antithrombotic drugs. And for vasospasm, you have to give vasodilator, arteriodilator especially, because coronary is the artery. So treatment of all of them, here we give statins, here we give antithrombotic drug, and here we give the vasodilators. Here statins is for prevention, but for treatment, we have to do the stenting, the surgery, the stenting. Say yes if you got it. Can we go ahead? Can we go ahead? Yes, yes, very good. Okay, so that is the three type of angina. Now read theory. I have already explained you. The classical angina, stable angina, it is the most common type of angina. Here reduction in coronary due to atherosclerosis is there. So atherosclerosis is the main reason. Patient have chest discomfort, not the pain. Please mind, it's not pain. It's chest discomfort. Patient will say, I'm having heaviness in the chest. I'm having pressure feeling, choking feeling, squeezing feeling, smoothing feeling in the chest. Someone is compressing my chest. It is feeling like that. A heaviness is there. It's not pain. Patient have this feeling only at exertion. This feeling disappear at rest. Okay. If you ask the patient to localize where it is, so patient will put the hand on the chest like this, and you know, the fist. The patient will hold the fist like this. I'm having like this pain. It is known as Levine sign. The pain lasts only for 2 to 5 minutes. That's it. The unstable angina, the reason is not atherosclerosis, it's thrombosis. Here patient have discomfort at rest also, at exertion also. Right? And the third one is the Prinzmantle. Here the reason is the vasospasm. Here also patient have pain at the rest also. So that is the three type of angina. We are done. Are you people awakened or sleeping? Who are you awakened? Are you people still there? Okay. Can we go ahead? Can we go ahead? So let's come on MI. The next topic is MI. The next topic, atherosclerosis and thrombosis are entirely different things, Siri. Atherosclerosis is a plague made up of cholesterol. Thrombus is the clot without injury. If you have watched my yesterday's lecture, you may know what is thrombus. You can watch it. It's available on the YouTube. Yesterday in general pathology, I taught you what is thrombosis. Atherosclerosis, I will later come on. Okay, let's start the next topic, that is MI. Can I come on the MI? The next topic is myocardial infarction. So let's start myocardial infarction. Here also the reason is same. Here also the same three reasons are there. It can be atherosclerotic plague, it can be thrombosis, it can be vasospasm. So basically there is obstruction in the coronary. Whatever is the reason. Let's say atherosclerosis, let's say thrombosis, let's say vasospasm. Whatever is the reason, the point is that, the ultimate point is that the coronary is obstructed. Either partially or completely, the coronary is obstructed. If the coronary is obstructed, there is less blood supply to the heart. What is the difference then? You must ask me, ma'am, ये तो angina में भी हो रहा था ना? It was occurring in angina also. Here in MI, what is different? In angina, it was occurring and going. It was partial, right? So it was coming at the time of exertion and going at the time of rest. Or else vasospasm was coming and going spontaneously. For few seconds, it is coming and going. So there, the ischemia was transient. Here, once it is occurring, it is not going back. Here, it is persistent, and that is leading to permanent ischemia, not transient. So ischemia occurs in both. In angina, the ischemia is transient. Here the ischemia is persistent. The persistent ischemia will lead to necrosis. Necrosis is irreversible. Necrosis is cell death. Yesterday I taught you 5 types of necrosis. If you remember my yesterday's lecture, the most common cause of necrosis is coagulative necrosis. So ischemia of all organ except brain. Yesterday I taught you. Ischemia of all organ except brain have coagulative necrosis. So here also in heart, there is coagulative necrosis. So in MI, there is coagulative necrosis. You can see, let me draw. You can see the cells. I am drawing the cells in the left ventricle. Can you see? I am drawing the cells in the left ventricle. These all cells receive blood from the coronary. Now imagine the coronary is obstructed. You are saying, ma'am, the coronary is obstructed by atherosclerosis or whatever. So there is less blood supply to all these cells. All these cells will not receive blood, no? Will not receive blood. So they will start dying. They will start dying, and the death of the cell is necrosis. It's coagulative necrosis. It's the infarcted area. So that is MI. That is MI. It's the infarction or coagulative necrosis of the myocardium of the left ventricle due to decreased blood supply because there is an obstruction in the coronary. The reason for obstruction can be atherosclerosis, can be thrombosis, can be vasospasm. Doesn't matter, but it is persistent. It will not come and go like angina. It is not transient. It's persistent. The same 3 reasons: atherosclerosis, thrombosis, vasospasm. The same 3 reasons. Now let me come on the type of MI. There are 2 types of MI. Do you know what are the 2 types of MI? Can anyone tell me what are the 2 types of MI? Let me explain you the 2 types of the MI. Okay, I'm zooming out this portion. Can you see? Here, I'm zooming out the wall of the left ventricle. Please see. So let me zoom the wall of the left ventricle like this. This is the thickness of the wall of the left ventricle. This is lumen of left ventricle. Left ventricular lumen, and you can see the thickness. Can you tell me where is the coronary? This is the bigger coronary, the conductance vessel, and this is the smaller coronary coming inside, supplying the wall of the left ventricle like this. Everyone give me a thumbs up if you got this diagram. Let me explain you 2 types of MI here. Everyone give me a thumbs up. You got it? You got it? This is the bigger coronary from which small coronaries are coming out and they are going inside. Can you see the coronaries are coming from outer to inner? The coronary, see the direction. The coronary is coming from outer portion to inner portion. This is inner. This is inner portion having the lumen, and this is outer portion of the lumen. Right? Okay, the wall of the left ventricle, I mean. So you can see the blood supply via coronary. Now imagine here is the atherosclerosis. So no blood is coming here. So all these coronaries which were normally receiving the blood, they are receiving less blood. These all coronary. So you tell me, apply your common sense and tell me that ischemia or necrosis occurs at which portion? Let me give you 2 options. Ischemia or necrosis occurs in inner half or outer half. First, where it occurs? Is it occurring inner half of the myocardium or outer half of the myocardium? It starts from what point? Common sense. Can you apply your common sense and tell me the answer? If the blood supply is obstructed, in all these small coronaries, they have less blood or no blood. All these small coronaries have no blood. Imagine it's complete obstruction. None of the smaller coronary have the blood. So ischemia start from the inner half or outer half? I'm asking you. So Babli, Ramdas, everyone, I cannot read your names. Come on. Can you please answer it? Outer. Why outer? Randoms. Why outer? Osama is saying inner. Debajan is saying outer. Some are saying outer, some are inner. Okay, 50-50 audience. Let me tell you, inner is the correct answer. It starts from inner. You can see now. Listen. So there is no blood supply in the smaller coronary. So pehle, whenever we are going inside, these are the end arteries. So here the inner portion is already having compromised blood. Because it is having less blood, these are the end arteries, you know. So the inner half is already having compromised blood. The outer half, now when the blood go from outer to inner side, the outer have more supply, and as we go deeper, inner, the blood supply go on reducing, right? So inner already have less supply, and on that, उस पे सोने पे सुहागा, on the top of that, you are obstructing the coronary, so inner will have zero supply. So always remember, the ischemia start from the inner half. The ischemia start from the inner half like this, and it go on progressing, and in 24 hours, it involves throughout the thickness. So this is the two type of MI in front of you. The two type of the MI. So this MI is known as subendocardial. Only inner half is involved. It is known as subendocardial MI, and this MI is known as transmural. Transmural means full thickness. Trans means full thickness is involved. So these are the two type of MI. Everyone give me a thumbs up. What are the two type of MI? It is subendocardial and transmural. Yes, based on the ECG, it is STMI and non-STMI. But that portion will be dealt in medicine, I guess, not in pathology. Pathological point of view, the MI is of two type. You know, you got it? Can we go ahead? Say yes. Okay, so inner half is involved, it's subendocardial. Outer half is involved, it's trans. Why it is known as subendocardial? Heart have three layers: endocardium, myocardium, pericardium. Where is the endocardium? I guess here is the endocardium. This is endocardial layer. After that myocardium I have drawn the thick layer, and there is pericardium outside. So this, the inner half is near the endocardium, just below the endocardium. That's why it is known as subendocardial. I hope everything is clear. So what are the two type of MI? Can you please tell me the two type of the MI now? The two type of the MI is subendocardial, in which only inner half is involved, and second is transmural, in which entire thickness is involved. I hope everyone got it. The same you can appreciate here. I guess everyone can see here. This is the right ventricular lumen, this is left ventricle. This is right ventricle, this is left ventricle. I am interested in left ventricle. In the left ventricle, see here. See the MI. Where is the MI? Where is the infarct? I mean, here only inner half is involved. Here the full thickness is involved. You yourself decide. Here it is subendocardial. It progress, and subendocardial converts into transmural. Okay. Can we go ahead? Okay. So here also you can see the diagram. Let me explain you this beautiful diagram. Everyone here on the screen. Can you see the three diagrams in front of you? These three I am talking. Okay, see the three diagrams. The three diagrams have the wall of the left ventricle. See the coronary. Appreciate the coronary. Currently it's not obstructed. Just obstruction have occurred. It's 0 hour. It's 0 hour means the obstruction have started. Till now there is no infarct. Now within the 2 hours, the infarct is starting from inner side. So it's subendocardial. And within 24 hours, it progress, and full thickness. It converted into full thickness infarct. So everyone appreciate this diagram if you got it. So subendocardial convert into full thickness within 24 hours. It start from the inner side. I hope you got it. So what is the location of the infarct? It depends on the type of the coronary. I told you there are three coronaries. LAD supplying anterior wall, LCX supplying lateral wall, and RCA supplying posterior wall. I told you already, right? Now please again see this beautiful diagram from the Robbins. Let me explain or decode this diagram. It's very easy. See everyone, the central diagram is the normal. You have to give me 1 minute. There is power cut off, so the sound is there of the inverter. Let me switch off this inverter. I mean the sound of this inverter. Give me 1 minute. Otherwise it will distract us. Still it's coming, I guess. Let me wait. I guess it's gone. Okay. No, it's still coming. Give me a minute. I'm sorry. So can you see the central diagram? It's normal. The central diagram is normal. You can see the right ventricle. You can see the left ventricle. You can see this is anterior wall. So this artery is LAD. You can see this is posterior wall. So this artery is RCA. You can see this is lateral wall. So this artery is LCX. You can see the three coronaries supplying the three wall. Right. Now on this side, we are obstructing the three coronaries one by one. You can see here LAD is completely obstructed. Here LCX is completely obstructed. And here RCA is completely obstructed. I guess RCA is completely obstructed. You can see the corresponding, please appreciate the corresponding infarct. So when LAD is obstructed, you can see the anterior wall is showing transmural infarct. If LCX is obstructed, the lateral wall is showing that. RC is obstructed, the posterior wall is showing that. You can see it is completely obstructed. The full thickness obstruction is there. Whenever the corresponding coronary is obstructed, the full thickness obstruction is there. Now the same you can see if partially they are obstructed. Now see the coronary. It is partially obstructed. This one is partially obstructed, this one. So it is transmural infarct. So when the coronary is partially obstructed, it's transmural infarct, and when the coronary is completely obstructed, when it is partially obstructed, it is subendocardial infarct, and when it is completely obstructed, it is transmural infarct. I hope you got it. So there are 6 types of infarct. The 3 are transmural, the 3 are subendocardial. Now depending which wall is obstructed, is it anterior, is it lateral, is it posterior, depending on the coronary. Which coronary is it? So the 6 types of infarcts are there. So can we go ahead? Now the most important thing I would like to explain here is the gross and microscopy of the infarct. Imagine there is a person. This person is dead. Okay, there is a person, all of a sudden this person is dead. He was healthy, he was normal, and all of a sudden he is dead. He is having chest pain and they are dead. So police is suspecting some foul play. So the dead body came for the postmortem, for the autopsy. So I am the doctor, just imagine I am performing postmortem on this dead body. So what I should do, what I am supposed to do, I am supposed to take the heart out of this patient and look for the infarct, whether the patient have MI, yes or no, and what is the timing of the MI. You know, the timing of the MI is the age of MI. If the timing of the MI is correlating with the death of the patient, I will say that the cause of the death is MI. If it is the same time, and maybe this patient have MI 10 years back, but now the cause of death is something else. So the first thing, MI present or absent, and if it is present, what is the age of the MI? So in postmortem, I want to answer 2 questions to the police in my postmortem report, in my autopsy report. It's a medical legal case. Okay, so if I say MI present or absent, if it is present, what is the age of the MI? What is the timing of the MI, age of the MI? Is it 4 hour old? Is it 24 hour old? It is 5 days, 7 days, 1 month, or more than 1 month old? So I will write that in the my postmortem report, and police will correlate that with the timing of the death, right? So that is the thing. We want to do that. So for that, first we will take the heart out and look for the gross. So just suppose this is the heart of the patient, not patient, the dead body. We have taken it out. Now what I will do, I will cut in slices, multiple slices. Each slice I will cut at 0.5 centimeter or 0.1 centimeter. I am having hundreds of slides with me. I will take all the slides in this container, all the slides. Now I will take each of the slide. Each of the slide have 2 lumen. Each of the slides have 2 lumen. The right ventricle, the left ventricle. In the wall of the left ventricle, I will look for infarct. In all the slices, you will say, ma'am, it's a tedious exercise. You have hundreds of slides. You will take each of them and with a magnifying glass, you search for the infarct. It can be a very small area, a small yellowish area you can see. So you can say, ma'am, you can miss it. Sometimes, yes, if it is very small, sometimes we can miss it. Of course, it can happen with us. So we can give a false report in the postmortem. We do not want that. So for that, there is a dye. There is a dye. The name of that dye, the red color dye, is TTC. What is the full form of TTC? It's triphenyl tetrazolium chloride. Triphenyl tetrazolium chloride, TTC. Please imagine this is a container. Fill this container with TTC. Tetraphenyl tetrazolium chloride. Fill it with TTC. Take your all slices of the heart. I'm taking only one, but you take all of them. Put all the slices here. Right ventricle, left ventricle. All the slices in this container. Okay. Now there is a rule. The rule is that TTC give red color to the viable area, and TTC give no color. I mean yellow color, no color or pale color to the dead area, the non-viable area. So this is a rule. TTC. So all these slices become red color except the infarcted area, which will be yellow. So one of the slices will be like this, having the infarct, right? Few slices will be like this. You can see the complete slice is red. It is viable, but you can see this portion is yellow, this portion is yellow. So this is infarcted area. So this is how you can highlight the infarcted area on the viable area. This is TTC. Say yes. You got my point? Okay, you got my point. This is TTC. Very good. Okay, everyone give me a thumbs up. So please learn TTC is very important. So you should ask me, ma'am, why the viable area is red and non-viable area is white? You know, so whenever there is ischemia, the cell burst. This is a cardiac cell. This is the nucleus of the cardiac cell. The cytoplasm of the cardiac cell have an enzyme dehydrogenase. Dehydrogenase enzyme is present, and during ischemia it bursts. So dehydrogenase enzyme is lost in the blood. So the dead cell do not have dehydrogenase. The viable cell have dehydrogenase, and TTC bind with the dehydrogenase. This is the principle. TTC bind with dehydrogenase. So it will bind only on the viable area, not on the dead area. Viable area have dehydrogenase, they become red in color. Dead area do not have dehydrogenase, they are burst. Dehydrogenase is lost, so they will remain pale, they will not take the dye. Say yes if you are getting all the concepts. Am I too fast or you are getting the concepts? Kindly appreciate, come on. Say yes. So this is the diagram. Can you see here? Here also you can see this is the dead area which is pale and complete other slice is red. So it is having the dehydrogenase. Okay. Now coming on the microscopy. So you will say, ma'am, you come to know. With the help of TTC, you come to know its MI, make your postmortem report and submit it to the police. So it is having MI. No, half job is done. MI is present, I came to know. I can see the MI. This is the MI, this is the MI. But I don't know the age of this MI. Is this MI 4 hours ago? Or is it 8 hours ago? Is it 20 hours ago? Is it 1 day ago? 3 days ago? I want to know that also. For knowing the age, you have to make a slide. You have to make a slide. The histopathological slide, you have to do the microscopy. On gross, we can say MI present or absent. But if you want to know the exact age of the MI, you have to do the microscopy. Say yes if you got it. Say yes if you got it. Can we go ahead? Yes. Okay. So in the microscopy, I divide it in 10 time zones. This is the ultra important topic. Please mind my words. And this is the most difficult topic of entire pathology, I must say, as per my opinion. It's very difficult, right? I'm trying to super duper simplifying it. Okay. So please pay attention. So I'm dividing in 10 time zones. Okay, now make a slide of this area. Cut this area, make a slide. Look the slide. In the slide, what you are seeing, based on that, decide your time zone. So I will show you 10 diagrams right now. 10 diagrams, okay, for 10 time zones. First learn the time zones. 0 to half hour, half to 4 hour, 4 to 12 hour. So it was hour. Okay, and 12 to 24 hour, I'm sorry. So 4 times it is hour. 0 to half to 4, 4 to 12, 12 to 24. 24 hours means 1 day. So 1 to 3 days, 3 to 7 days, 7 to 10 days, 10 to 14 days. So 4 times it's days. Okay. Now 14 days is 2 weeks. So 2 to 8 weeks, more than 2 months. So 1 week, 1 month. So learn like this. How I learn? Let me tell you. So it's hour. Then it is day. Then it's a week, and then it is month. Now let me fill. I will try. So it's 0 to half hour, half to 4 hour, 4 to 12 hour, 12 to 24 hour. 24 hour is 1 day. So 1 to 3 day, 3 to 7 day, 7 to 10 day, and 10 to 14 day. 14 days 2 week. So 2 to 8 week, and 8 week is 2 months. So more than 2 months, everything is same. Now I am going to give you 10 diagrams. If you learn the time zone, the first thing was to learn the time zone. If you know the 10 time zones, I told you a trick. 4 are the hour, 4 are the days, 1 is week, 1 is month. In this way, they are 10. They are 10 in number. Now let me tell you the 10 diagrams. During 0 to half hour, no changes seen. The heart will be normal. If you make a slide of this area now, within 0 to half hour, it's normal. Practically 0 to half hour making slide is not possible. The person is dead, you are shifting the dead body to the hospital, or if the death is occurring in the hospital itself, you are shifting the dead body in the postmortem room, and you are cutting it, you are opening it, you are taking the heart out, you are cutting it, you are doing the TTC dye, and you are making a slide. Within half hour, it's not practically possible. But if at all you are doing it, you will get nothing. So during first 30 minutes, it's reversible and you cannot find anything microscopically. You can miss it. After 30 minutes, you will see the waviness. Let me show you the waviness. Normally, the heart fibers are straight. They are straight. But here I can see they are wavy. They are normal, but they are wavy. So first thing is waviness. They are like wavy. Normally, they are not wavy. They are straight. But in MI, they become wavy. So between 0 to half hour, only thing you find is the waviness. Waviness is the earliest feature. It's a PYQ. Say yes. You can see the nucleus is normal. These cells have the nucleus. You can see the striations. You know the striations, the dark and light bands are there. It's normal. Everything else is normal apart from waviness. Waviness is the first thing, right? From 4 to 12 hour, you will get coagulative necrosis. See the upper half of this diagram. Can you see? Can you compare the upper half with the lower half? Now in the upper half, see the cardiac fibers. Again, you can see only pink color strands are there. I cannot see the nucleus, I cannot see the striation. So it is, you know, yesterday I told you only shape is maintained, but the cytoplasmic and nuclear details are lost. The tombstone, the ghost appearance. Now compare the lower half with upper half. So only shape is maintained, but the cytoplasmic detail and nuclear details are lost. It is coagulative necrosis. So coagulative necrosis occurs, only coagulative necrosis. Between 12 to 24 hours, along with coagulative necrosis, few neutrophils will also come. See the upper half only. Yes, can you see all these cells? See the nucleus of all these cells, these are multilobated, they all are neutrophil. They all are neutrophils. So the word is few, right? Now during 1 to 3 days, along with coagulative necrosis, abundant neutrophils will come. See the next diagram. Now here also there is coagulative necrosis, you can see along with the coagulative necrosis, but see the number of the neutrophils. Appreciate the number here, they are few, and appreciate the number here, they are abundant. So abundant neutrophils are there. Okay, now 3 to 7 days, neutrophil will decrease and macrophage will come. Can you see in this diagram only? Let me highlight this cell, this cell, this cell, this one and this one. Okay, you can see these cells have one nucleus. These are macrophages and rest all are neutrophil. So neutrophil will start decreasing and macrophage will start increasing. What are macrophages? What does they do? What does the macrophage? Macrophage eat the dead muscle. It engulfs the dead muscle. So now whatever dead muscle is there, macrophage start eating it. So dead muscle will disappear. The dead muscle will disappear. You can see यहाँ से उसने dead को खाना शुरू कर दिया है. So macrophage start eating the dead muscle. So instead of dead muscle, there is granulation tissue. So now the granulation tissue will form. Granulation tissue will mature. You can see this is granulation tissue. Can you see dead muscles are present in the lower half, but they are absent in the upper half. In the upper half, macrophages have already eaten it, and instead of it, granulation tissue is formed, right? And finally, the scar is formed. Collagen and scar is formed. Let me draw the diagrams for you. Let me highlight it. Everyone, can you please help me? So say R. Say day. Say weeks, say month. Okay, let me try to write. So 0 to half hour, half to 4 hour, 4 to 12 hour, 12 to 24 hour. 24 hour means 1 day. So say 1 to 3 day, 3 to 7 day, 7 to 10 day, 10 to 14 day. 14 day means 2 week, 2 to 8 week, 8 week means 2 months, so more than 2 months. So these are the 10 time zones. We all know that. Let me tell you the findings. Can you please tell me the findings in sequence? See, 0 to half hour normal. I will miss it. Please learn. Half to 4 hour, it's waviness. I shown you the diagram of waviness. So here the fibers will be like this. They are wavy. They are normal, but they are wavy. After that, we find only coagulative necrosis. So these fibers, the shape is same, but the cytoplasmic and nuclear details are lost. So it's tombstone appearance. Now, along with the coagulative necrosis, I will use the word few neutrophil. So coagulative necrosis is there, but along with that, I am getting few neutrophils. Few. After that, along with the coagulative necrosis, I am getting brisk neutrophils, abundant neutrophils. So the same diagram, coagulative necrosis is there, but I am getting abundant neutrophils. Abundant. These are the rough diagrams just for the sake of learning I am drawing. Okay. Now, the next, the neutrophils decreases and macrophages start appearing. Okay. So some of the neutrophils will decrease, and instead of that, most of the cells are still neutrophil. They are still neutrophil, but some of them are macrophages. Let me draw few macrophages. Some of them. Macrophages start eating the dead muscle. Now the granulation tissue will form. First it is formed and then it is established. First it is formed, then it is established, the granulation tissue. Finally, collagen and scar is there. Collagen and scar. This is the thing how you have to learn. Everyone give me a thumbs up if you got it. I have put my many efforts in making this table the simplified for you. If you read it from Robinson, it will be a bouncer for you. But I have super simplified it for you. So you got it. So this is the 10 time frames and you can see all the diagrams. This is finally scar. Everything will disappear and scar will form. Finally, scar is formed. You got it? You got it? So this is the microscopy. Now let me come on the diagnosis. How you do the diagnosis of MI? Can you tell me how you diagnose MI? There are two things. You can do the ECG or you can take the blood sample in a test tube and look for the cardiac markers. Look for the cardiac markers. In the ECG, you will find 3 changes. Yes, very good, Osama. Absolutely right. Great efforts. I appreciate it. Listen, in the ECG, there are 3 findings. You can see normal ECG have 5 waves PQRST. You can appreciate this is P, this is Q, this is R, this is S and this is T. You can appreciate the 5 waves. Now this is ST elevation. Can you see the ST elevation? This is T inversion. Appreciate the T inversion, and this is deep Q. So the most common it is ST elevation. So these are the 3 ECG changes. The details will be taught to you in medicine, but this is the basics you can understand here. So these are the 3 ECG changes. Based on ST elevation, we divide the MI in 2 categories, ST MI and non-ST MI. We know that. So ST elevation, T wave inversion, and deep Q. One of these findings will be seen in the ECG. That is a spotter that it is a case of MI. Number 2, you can take the blood sample. Imagine this is the patient. It is having MI. A rough sketch diagram I am drawing. The patient is having MI. So this is the heart of the patient and this is the blood vessel of the patient. Okay, these are the cells of the left ventricle. Imagine these are the cells of the left ventricular wall. These are the cells. These are the cells of the left ventricular wall. So basically what is happening in MI? They are bursting. They are dead. They are bursting. So a group of cell is dead. They are bursting. So they will release 5 enzymes in the blood. And if you take the blood sample in a test tube, look for the 5 enzymes. These are known as cardiac markers. So whenever the patient have MI, these 5 enzymes are released in blood and their level in the blood is more. So these are known as cardiac markers. You should understand the basic hota kya hai cardiac marker. So basically these are the enzymes that leak out from the dead cells, dead myocardial cells. Okay, now what are these? These are 5 in number. So learn their name first. Myoglobin, CPK. CPK-MB, troponin T or I, the most specific, troponin T or I. SGOT also known as AST and LDH, right? Lactate dehydrogenase, right? Myoglobin is the earliest. It is the first marker which leaks out and come in the blood. Within 2 hours it comes. It is the earliest, right? And last to remain till 10 days is LDH. LDH comes late but goes late. The last to go is 10 days is the LDH. And among them, the most specific and sensitive marker is troponin. So there are 3 questions. There are 3 questions in front of you. The first to appear is myoglobin, last to go is LDH, and most sensitive and specific is troponin. You got my point? Okay. So let's solve some question. Okay, you can telegram me if you want some books. If I will be having the soft copy, I can send you the hard copy on the telegram. Okay, anyways, so let's solve some questions. We are done with MI. We are done with angina. We are done with MI. Everyone on the screen, tell me the answer of this question. During autopsy of a patient, of course, we do the autopsy on the dead person. There is a patient who is dead and we are doing the autopsy. What is the cause of the death? The suspected cause of the death is MI. So you put the heart in TTC, tetraphenyl tetrazolium tetrachloride, TTC. So what will be the color? What will be the color of the viable myocardium? Tell me the answer. Is it blue? Is it white? Is it red? Is it dark brown? Who will tell me the answer? Who will tell me the answer? Yes, what is the correct answer? Yes, what is the correct answer? Very good. So correct answer is red. So red is the viable. Viable is red because it is having dehydrogenase enzyme and dehydrogenase enzyme pick up the stain. Instead of viable, if I ask in the same question non-viable, answer will be pale or yellow, but it is not given in the option. But I am telling you it will be pale or yellow. So the next question is in front of you. You all are right. Yes, the next question is in front of you. Earliest change in MI. I told you the changes now. What is the earliest change in MI? Is it macrophage infiltration, neutrophil infiltration, or waviness, or coagulated necrosis? So yes, you all are right, absolutely right. The correct answer here is, what is the correct answer here? Yes, you all are right. The correct answer here is waviness. Waviness is the earliest histological change you seen in MI in half to 4 hour. 0 to half hour we see nothing, in half to 4 hour. Now in the same question, I am asking you one more question. Arrange them in sequence, in ascending order from earliest to latest. Can you arrange them in a sequence? Is it ABCD, BCAD, CDAB, like that? Please arrange a sequence from earlier event to later event. Who will arrange it for me? Let me see who is the first. Fastest finger first, KBC. So let me see who is the first. You know the events, now? You know the sequence of the events time wise. So kindly let me know. Yes, kindly let me know the sequence. I am waiting for your answer. I want to know the sequence, right? In ascending order, the earlier event till later event. Yes. So first 0 to half hour is normal, then half to 4 hour is yes. So Shubhashri is first to answer, and you are saying CDBA. Let me check. What about others? Some students are saying CABD. Let me check. Okay. So what is the correct sequence? So first is the waviness, of course. So C is the first. After that there is coagulated necrosis. So D is next. After that neutrophils come. then B, and last में macrophage comes, so A. Yes, you are absolutely right. The correct answer is CDBA. In this sequence, you have to learn. Those who are wrong, please correct yourself. So this is the sequence. First waviness, then coagulative necrosis. I told you the entire sequence. The next question is in front of you. In MI, microscopic picture of coagulative necrosis with neutrophilic infiltration is seen at what? It's a tricky question. So I'm asking coagulative necrosis with neutrophil. It is seen at which time zone? Is it seen at 4 to 12 hour, 12 to 24 hour, 1 to 3 day, or 3 to 7 day? You want to see the chart? Shall I show you the chart, the complete chart? What is the correct answer here? Can you tell me what is the correct answer? What is the correct answer here? In which time zone coagulative necrosis with neutrophils is seen? So I guess you can get confused. Here because I have not mentioned the word few or brisk. If I use the word few, answer is 12 to 24 hours. If I use the word brisk, answer will be 1 to 3 day. You got my point? So both are correct, but I'm going with the brisk. I guess both answers are correct, but if you go with the brisk, answer will be C. So it is a clinch in the question. B and C both are correct. Okay. The next question, the cells which are seen at 48 hours. Can you tell me the answer? 48 hours is how many days? It's 2 days. 48 hours is 2 days. Yes, 48 hours is 2 days. So divide the time zone, 0 to half, half to 4, 4 to 12, 12 to 24, 1 to 3 day. So in this time zone, which cells are coming? First time which cells are present? In this time zone, 1 to 3 day. What is the correct answer? In 1 to 3 day, which cells are present? In 1 to 3 day, neutrophils are present. Right? And if I change the time zone to 72 hours, 3 to 7 days, answer will be macrophages. You got my point? So depending on the time zone, we have to answer this. So can you tell me the first enzyme to be raised in MI? The first enzyme to be raised in MI. Is it CPK, LDH, myoglobin, or troponin? What is the correct answer? Can you tell me what is the correct answer? The earliest enzyme which comes in the blood. Within 2 hours. You all are right. The correct answer here is the myoglobin. So basically we are done with this topic. The next topic to be covered here is endocarditis. The next topic to be covered here is the endocarditis. Can we go ahead with the endocarditis? Yes, you all are right. Yes. So can we go with the next topic, endocarditis? Here I have to teach you 4 types of endocarditis. I will be covering all 4 endocarditis one by one. So what is endocarditis? Before coming on the topic, you must understand what is endocarditis. In the heart, there are 3 layers. Can you see the 3 layers? You should appreciate the 3 layers of the heart. The innermost layer is the endocardium, seen by the red color. The middle layer is the myocardium, seen by the black color. And outermost layer is the pericardium, seen by the blue color. You can see the 3 layers in the heart. Endocardium, myocardium, pericardium. The heart is having 3 layers like the blood vessel. Okay, now endocardium is of 2 types. Listen here, the heart walls. What about the walls of the heart? Walls of the heart have walls, na? Mitral wall, bicuspid wall, tricuspid wall, semilunar walls. The walls are made up of which endocardium? The heart walls are also made up of endocardium. It is having only endocardium. So the endocardium which is present on the walls of the heart is valvular endocardium, and the endocardium which is present on rest of the heart is mural endocardium. So basically endocardium is of 2 types. The endocardium which is present on the walls is valvular endocardium. The endocardium which is present on rest of the heart is mural endocardium. Apart from that, myocardium and pericardium is there. What is endocarditis? Itis in pathology is inflammation of that particular portion, that particular tissue. Endocarditis is inflammation of the endocardium. So as I told you, endocardium is present on the walls. Walls are inflamed. When the walls of the heart are inflamed, on the walls of the heart, vegetations are formed. So basically in all types of endocarditis, we have vegetations on the heart walls because of endocarditis. You got it? Can we go ahead? So how many types of endocarditis are there? Inflammation of the endocardium is endocarditis. Heart walls are always involved, and that's why vegetations are always there. There are 4 types of endocarditis in our syllabus. I will be teaching you all 4 right now. So you have to do a comparative analysis between all 4, between the vegetations of all 4. So first I will let you know rheumatic fever, then non-bacterial thrombotic endocarditis, then Libman-Sec endocarditis, then infective endocarditis. These all are 4 types of endocarditis. Let's start with rheumatic fever. The most important is the first and the last. So first is rheumatic fever. Let's start with rheumatic fever. Shall I start with rheumatic fever? Are you people there? Can we start with rheumatic fever? What is rheumatic fever? Please see this diagram. What is rheumatic fever is explained here. It's like a story. Can you see it is a child? Rheumatic fever occurs in child usually. So this is a sketch diagram of a child. Imagine this child have tonsillitis. These are the tonsils of the child, and the child is having tonsillitis by a bacteria. The name of the bacteria is group A, Streptococcus, gas bacteria. Group A streptococcus bacteria, gas bacteria. So this child is having tonsillitis by group A streptococcal gas bacteria. You will say, ma'am, it's very common. This is the bacteria most commonly causing tonsillitis. Maybe I have, you have, many times we have tonsillitis. It's very common. What is the problem in that? The problem is not the tonsillitis. It is not the bacteria. Body is forming antibodies, can you see, against the bacteria. Whenever we have bacterial infection, the body form antibodies for that. The body is forming antibodies for that, right? No, there is no problem in that. The antibodies will react with the antigen, kill the antigen. Antigen antibody reaction takes place and the bacteria is killed. Bacteria is not the problem. The problem is that the antigen present on the bacteria, the epitope present on the bacteria, the same epitope present on human 5 organs. The same epitope, the same antigen present on human 5 organs. So I will tell you the name of the organs. Basically, these antibodies will get confused. Actually, they are formed against bacteria, but they think this is also bacteria. So they will cross-react with the 5 organ. So antibodies, can you see the antibodies are coming and reacting with the 5 organ, producing 5 diseases. So it is an autoimmune disease. The antibodies are formed against the cell tissue. It is known as cross-reactivity. Actually, the antibodies are not formed against the cell tissue. The antibodies are formed against the bacteria, but since bacteria have mimicry, the similar antigen with the 5 tissue, the antibodies will get confused and they cross-react with the human 5 tissue. Name the 5 tissue. Number 1, brain and heart, the 2 vitals, heart and brain. One is heart, one is brain. Then there is skin. Just below the skin, we have subcutaneous tissue, and just below that, we have joints. So heart, brain, skin, subcutaneous tissue and joints. These are the 5 organs. Now name the 5 diseases. So in the heart, there is rheumatic heart disease. In the brain, it's syndrome chorea. In the skin, it's erythema marginatum. In the subcutaneous tissue, it's subcutaneous nodules. And in the joints, it's migratory polyarthritis. So these are the 5 diseases. Rheumatic fever is a collection of all 5. What is rheumatic fever? It's not one disease. It's a multi-system disease involving 5 different systems, 5 different organs. That is rheumatic fever. So you got it. What is rheumatic fever? Rheumatic fever is a multi-organ involvement, multi-system involvement. This is known as rheumatic fever. It is multi-system involvement. It is involving five systems in human body: the heart, the brain, the skin, the subcutaneous tissue, and the joints. So these 5, that is rheumatic fever. So among them, heart is most important. I will explain heart in detail, but rest of them I will tell you 2-3 lines on them. I will start with the heart. So that is rheumatic fever. You got it? Shall I say rheumatic fever is a multi-system involvement? Yes. Is always post-streptococcal, involving 5 organs. So that is rheumatic fever. It's an autoimmune disease. Please mind my words, it is not caused by bacteria. It is caused by autoantibodies. So this mechanism is known as molecular mimicry and cross-reactivity. What is it known as? Molecular mimicry and cross-reactivity. What do you mean by that? So basically, the bacteria is doing mimicry with the 5 organs. That is known as molecular mimicry. So the antibodies will get confused. They are formed against bacteria and they are cross-reacting. So molecular mimicry and cross-reactivity is there. So there is a child. The child is having tonsillitis by gas bacteria, group A streptococcal bacteria. The antibodies are formed. These are autoantibodies and they cross-react with human 5 organs. You can see, and the patient have rheumatic fever. So this is rheumatic fever. In the rheumatic fever, we have Jones criteria. Jones criteria. What are Jones criteria? The 5 major and 5 minor. The 5 major criteria is the 5 diseases only. The 5 diseases and 5 organ is the Jones 5 major criteria, right? Minor criteria are also there. In the minor criteria, let me tell you, there is, you want me to write it? Okay. Fever, arthralgia. Okay. I will write it. So let me tell you the Jones criteria. Jones criteria or revised Jones criteria. There are 3 types of criteria. The major criteria, which are 5 in number. The minor criteria, which are 4 in number. And there is supportive criteria, which are 3 in number. So there are 5 major, 4 minor and 3 supportive. What are the 5 major? The 5 diseases. So in the heart, it's endocarditis, that is rheumatic heart disease. In the brain, it's syndrome chorea. In the skin, it's erythema marginatum. On the skin, it's erythema marginatum. In the subcutaneous tissue, it's nodules. And in the joints, it's polyarthritis, migratory polyarthritis. Okay, so these are the 5 major criteria. Among the minor criteria, here there is arthritis. In the joints, there is arthritis. But here in the minor, I will take arthralgia. Arthralgia. There is a difference between arthritis and arthralgia. Arthritis is the inflammation and arthralgia is the pain. Along with that, the child will have fever. Fever is a minor criteria. Arthralgia is a minor criteria, and increased PR interval on PQRST ECG. it is a minor criteria, and increase ESR, it's a minor criteria. So learn the 4 minor criteria. In the supportive criteria, listen, these all things are happening after tonsillitis. If these are occurring without tonsillitis, I will not consider it as rheumatic fever. If they are occurring after tonsillitis, then only I will consider as rheumatic fever. So there should be a proof, there should be a evidence that the child is having tonsillitis few weeks back before this episode. You got my point? So there are 3 ways. Number 1, you can take the history from the mother. The mother and the child are coming to your clinic. The mother is saying, my child is having multi-system involvement, his skin involved, joint involved, heart involved. So you are having a suspicion the child is having rheumatic fever. Ask the mother, does the child have tonsillitis few weeks back? The mother will say yes. Or sometimes it is very mild or subtle, it is not came in notice. So you should take a throat swab from the tonsil and culture it. Number 1, you should get the gas bacteria. Number 2, you should take the blood sample of that child and look for the autoantibodies. Look for ASO titer, anti-streptolysin O autoantibodies, and look for anti-DNAs. Right? These are the autoantibodies you are looking in the blood. So these are the 3 supportive criteria. You got it? So in the revised zone criteria, 2 minor should be present, or 2 major should be present, or 1 major or 2 minor should be present along with the supportive. That is the revised zone criteria. Okay. Now let me come on the heart. In the heart, there are 3 layers, endocardium, myocardium, pericardium. In rheumatic heart disease, all 3 layers are involved. The patient have endocarditis, myocarditis, pericarditis, all 3 layers of the heart are involved. The patient have pancarditis. Again, I repeat, the patient have pancarditis, all 3 layers are involved. Endocardium, myocardium, pericardium. So this is pancarditis. Okay, this is in rheumatic heart disease, the patient have pancarditis. So we will see the endocardium first, then myocardium, then pericardium. In the endocardium, there are 2 things. The valvular endocardium and mural endocardium. I guess you know what is valvular endocardium. The endocardium present on the walls. So because of the valvular endocardium involvement, the vegetations are formed. Can you see? Vegetations are small, multiple, sterile. So small, multiple, sterile vegetations are formed. Okay. So you can see, I will teach you 4 type of endocarditis. Now this is first I am teaching right now. I will teach you 3 more. In all of them, vegetations are formed. Here the vegetations are small. They are multiple. They are sterile. Compare with others. Okay, number 1, see the real diagram. These are the vegetations present on the heart wall. Which heart wall is most commonly involved? There are four heart walls. No? So on the left side we have 2 walls. On the right side we have 2 walls. Okay, what are the walls on the left side? Mitral wall, aortic wall. And here right side we have tricuspid wall, pulmonary wall. Okay, so what is the sequence of involvement? They all have vegetations. So the sequence is mutup. It is mitral, followed by aortic, followed by tricuspid, followed by pulmonary. So first left side walls are involved, then right side walls are involved. The mnemonic is mutup, please learn that. So M-A-T-P. Most common is mitral, second most common is aortic, third most common is tricuspid, last is pulmonary. It's very important, say mutup. Yes, absolutely right Osama, absolutely right Shalini, Devjan, it's mutup. What is the location of the vegetation? Listen, most commonly you said it's on mitral. Now this is right side, this is left side. Where is mitral wall? Here is the mitral wall. This one, this is the mitral wall. So here we have left auricle, here we have left ventricle, and these are the 2 cusps of the mitral wall. Mitral wall is a bicuspid wall, right? So imagine these are the 2 cusps. Above it there is left auricle and below it there is left ventricle. Imagine. So when the 2 cusps open, blood is coming from auricle to ventricle, then they close. They open, they close. They open, they close. Blood is coming from auricle to ventricle every time. Where is the vegetation formed? Yes, Osama, absolutely right. Where is the vegetation formed? On the upper surface? No. On the lower surface? No. Both surface? No. It is formed at the line of the junction. The line of the junction of the cusp. It is formed at the line of the junction of the cusp. I mean not on upper like this, not on lower. It is formed at the line of the junction like this, right? Like this. I hope you are getting it like this. So it is formed at the line of the junction of the 2 cusps. It is known as line of closure. So let me draw the vegetations. I will draw the vegetations here on the line of the junction of the cusp. It's very important to understand the concept here. Got it? See the vegetation at the line of the closure at the junction, right? Because of which the wall will look like fish mouth. Have you seen a fish? Let me draw a fish for you. The fish. I draw it for my kid. So let me draw a fish for you. So the fish, the mouth of the fish is like this. Can you see it's spouting out? right? So the wall will look like this. It's known as fish mouth or buttonhole appearance. Fish mouth or buttonhole appearance. Okay, so can you see here? It is looking like a fish mouth. See the two cusp? Appreciate the nodules on the two cusp, the vegetations. It is looking like a fish mouth. Here also appreciate the two cusp. Appreciate the nodularity. Appreciate the vegetations at the line of the closure looking like a fish mouth. Appreciate my efforts. You got it? This is fish mouth appearance. So we are done with endocarditis, valvular endocarditis. Now coming on mural endocarditis. What happened in rest of the endocardium? I told you there are two types of endocardium. The endocardium present on the walls. You can see it here. It is having vegetations. Vegetations are present in valvular endocarditis. You know everything about vegetation. The vegetations are small, they are multiple, they are sterile, they are present in all heart walls. The mnemonic is muttap. In all of them, they are present on the line of closure or line of junction, and they produce a deformity which is known as fish mouth or buttonhole deformity. Everything regarding the vegetations I explained you completely. Okay, now coming on rest of the endocardium. In rest of the endocardium which is present in left auricle, out of that 4 chamber I am selecting left auricle. The endocardium which is present in the left auricle on the posterior wall, it's a 3-dimensional structure. Now on the posterior wall of the left auricle, the endocardium become wrinkled. Wrinkling is there and a patch is formed. This is known as McCallum patch. The McCallum patch. So in the endocardium, two things are there. Both are in front of you. Everyone here, please say yes. You got it? So two things in the endocardium. Valvular endocardium have vegetation. Mural endocardium have McCallum patch. You should know both. What are vegetation? What are the details of the vegetation I have written? What is McCallum patch? It is a wrinkled area present in posterior wall of the left auricle. Everyone say yes. You got it. Kindly interact. Yes, you got it. So shall I move ahead? What is McCallum patch? The McCallum patch is present on the posterior wall of the left auricle. It's a wrinkled area. So this is known as McCallum patch. Okay. So we are done with endocardium. Now coming on myocardium. What happens in myocardium? In the myocardium, Ashkoff bodies are formed. The Ashkoff bodies are the pathognomonic feature of rheumatic heart disease. Can you see the myocardium? Don't see endocardium now. In the endocardium, two things are over. Vegetations we have seen, McCallum patch we have seen. Now come on the myocardium. In the myocardium also nodules are formed. Can you see the nodularity? The nodularity in the myocardium. It is known as Ashkoff nodules. These are not vegetation. These are Ashkoff nodule. What is the Ashkoff nodule? What is the Ashkoff nodule? If you see and zoom it out, Ashkoff nodule. This is the Ashkoff nodule. It's a granuloma. The Ashkoff nodule is a granuloma, right? What is a granuloma? In the granuloma, in the center, you can see in the center there is fibrinoid necrosis. Yesterday I taught you 5 types of necrosis. Now the 5th one, fibrinoid necrosis. It occurs at the center. It is surrounded by 5 types of cells. So let me draw the fibrinoid necrosis in the center and let me surround it with 5 types of cells. The first type of cells are giant cells. The giant cells are known as Ashkoff cells. The giant cells are known as Ashkoff cells. The second type of cells are anti-Ashkoff cell. These are uninuclear. So the nucleus is either, if you see from front, it's caterpillar-like. The nucleus is like caterpillar. And if you cut it from here and see the cross section, the same cell, the nucleus is like owl eye. The same cell, the nucleus is like owl eye. So caterpillar and owl eye is the same. These are anti-Ashkoff cell. So we have Ashkoff cell. These are the red one. These one are Ashkoff cell and the blue one are anti-Ashkoff cell. Okay, both are modified macrophages. Apart from that, we have lymphocytes, we all know. We have plasma cells, we all know. We have fibroblasts, we all know. There is no neutrophil. So it's a circular body, Ashkoff body. Everyone give me a thumbs up. You got it? This is Ashkoff body. The Ashkoff bodies are formed. The Ashkoff nodules are formed. You all can see in the center there is fibrinoid necrosis. Okay, it is surrounded by, can you see this cell? It is a multinucleated cell. So it's a Ashkoff cell. Can you see these two cells? These are anti-Ashkoff. Here the nucleus is caterpillar type. Here the nucleus, the same nucleus is owl eye. It is the same cell. We are seeing the front view, the cross-sectional view. So both are same. Okay, you can see here a multinucleated giant cell. It's Ashkoff cell. And these are anti-Ashkoff cell, the caterpillar and the owl eye. It's a Ashkoff body. It's a Ashkoff body. Last is pericarditis. We are done with endo. We are done with myo. And now coming on pericarditis. In the what is pericardium? Do you know what is pericardium? The heart is surrounded by a space known as pericardial space. We all have this space, right? Now this space contains a small amount of fluid known as pericardial fluid. A very small amount of watery fluid. serous watery thin fluid. We all have it. A small amount of fluid is present in the pericardium, but a small amount. Now what happens in rheumatic heart disease? In the pericardium, this fluid, the pericardial fluid become thready in consistency. It become thready. Hindi mein kahun to dhage ke jaisa. It become thready in consistency. It is known as fibrinous pericarditis. The word to be picked here is fibrinous. Fibrinous ka matlab hota hai thready. Fibrinous pericarditis. This one is fibrinous pericarditis. It is thready in appearance, right? So can you see this person is dead? I am doing the autopsy. I am opening the heart. Imagine there is a child who is dead of rheumatic heart disease. This is the heart of that child. So I am doing the autopsy. I am taking the heart out. So what I will do? I will use a scissor, and with the scissor I will cut the pericardium and separate it from the myocardium. So can you see here a scissor? I am cutting the pericardium. I am cutting the pericardium and separating it from the myocardium. This is all myocardium behind. This is all myocardium. I am cutting the pericardium, separating it from the myocardium. Now you can see bread and butter appearance. Now you can see bread and butter. What do you mean by bread? Have you ever eaten bread and butter sandwich? Yes. In the breakfast we sometimes eat it. No, bread. So in bread and butter sandwich, the two bread slices are there and there is a butter in between. This is bread and butter sandwich. Have you ever tried separating the two slices away from each other? Have you ever tried? If you have not tried, try it next time. So if you separate the two pieces of the bread away from each other in a bread butter sandwich, you can see the threads of the butter in between. You can see the threads. You can see the threads of the butter in between. So whenever you are separating the pericardium from the myocardium, please appreciate the thread. This is looking like butter. And the two slices, one is myocardium, one is pericardium. I hope you got it. The two bread slices are myo and peri, and in between them the butter is the fibrinous pericarditis. It is looking a bread and butter appearance. Please say this word. This is the summary. We are done. This is the summary. The summary is in front of you. Endocardium, myocardium, pericardium, pancardium. Pancarditis. All three layers are involved. In the endocardium, there are two types of endocardium. Valvular endocardium, vegetations are there. Describe vegetation. Say, ma'am, they are small, they are multiple, they are sterile, they are present on all four walls, the mnemonic is mutt up, they are present on the line of closure, and they produce fish mouth deformity. Vegetation done. Come on the mural endocardium. There is a McCallum patch. Describe it. It is present on the left auricle. It is a wrinkled patch on the posterior wall. Come on myocardium. In the myocardium, there are Ashkoff body. These are granuloma. In the center, there is fibrinoid necrosis surrounded by 5 types of cell. Ashkoff cell, anti-Ashkoff cell, you know that. And in the pericardium, there is fibrinous pericarditis giving bread and butter appearance. I cannot simplify more than this. These are the limits and heights, I guess. Say yes. This is rheumatic heart disease. Everyone appreciate rheumatic heart disease. All pancarditis is shown here. You see endocarditis, you see myocarditis, you see pericarditis. You see endocarditis, these two things are there. You see myocarditis, this is there. You see pericarditis, this is there. So basically this is pancarditis. Everyone give me a thumbs up. Yes, very good, Amisha, very good. Can we go ahead? You see. So can you see the three things? Endocarditis, myocarditis, pericarditis. All the three layers are involved and it is known as pancarditis. Pan means all three layers are involved. Now please learn the important findings in each of the layer. Okay, so we are done with pancarditis. So as I told you, in rheumatic heart disease, in rheumatic fever, it's the umbrella term having 5 diseases. We are done with the heart. What 5 organs are involved? I told you heart, then brain, then skin, then subcutaneous tissue, and then joints. So we are done with the heart. In the heart there is pericarditis, but what about the remaining 4? What about the remaining 4? Remaining 4. So these are known as extracardiac lesion. I will tell you 2-3 lines on each of them. Let's start with joints. What happens in the joints? It's migratory polyarthritis. So child will come to you, you are a pediatrician, child will come to you, doctor, and with the mother. The mother will complain, my child is having pain in the joints. So you will ask which joints? So the child will say, the mother will say it's the large joints. In the knee, ankle, wrist, elbow, these all are large joints, not the small finger joints. First, the large joints are involved, right? Number 1. Number 2, the joints are hot, red, swollen, very swollen, and there is extreme pain. If you touch the joint, the child will shout. There is extreme pain, and the pain is migratory. Today, child is saying, I'm having pain in the shoulder. The next day, child is saying, I'm having pain in the elbow, and now I'm having in the wrist. So it is migratory in nature. So large joints are involved. The joint is having the pain which is disproportional as compared to the finding. It is red hot joint. The pain is migratory. Several joints are involved one after the another. This is polyarthritis. That's why it is the earliest manifestation out of the 5 and it is the most common. Even more than heart, it is the most common manifestation, right? So that is the joints. Coming on brain. In the brain, it's chorea. It's chorea known as Sandam's chorea. It is also known as St. Vitus dance. Because the first patient in which it was discovered, it was a girl. The name of the girl is St. Vitus. That's why it is known as St. Vitus. Okay, St. Vitus, but why it is known as dance? It is looking the girl is dancing. Is the girl is dancing? No. The girl is having brain involvement in the rheumatic fever because of molecular mimicry antigen-antibody reaction. So basically the caudate nucleus is damaged in the brain. When the caudate nucleus in the brain is damaged, there is involuntary spontaneous movement in the air. It is looking like the girl is dancing, but these are not dancing. It is chorea. It is chorea. What is chorea? Involuntary jerky movements in the air, right? So this is chorea. Okay, so there is damage to the caudate nucleus. So patient have neuropsychiatric symptoms here. Okay, the third is the erythema marginatum in the skin. You can see in the skin the person have multiple lesions. The lesions are circular, sometimes they are serpentine like a snake, they are circular, they are red with a yellow center, okay, and they are present on the trunk, on the limbs, but never on the face. They are never present on the face. So this distribution is known as bathing suit distribution. Bathing suit, when the swimming suit or bathing suit. So bathing suit or swimming suit is not worn on the face, right? So on face they never occur. So this distribution is known as skin bathing suit distribution. They occur on the trunk, on extremity, but never on the face. There is no itching. No itching. Please mind my words, the negative finding, no itching. No itching means non-pruritic. These are non-pruritic. These are red. These are serpentiginous. They have pale center. No itching, no pruritus, bathing suit distribution, and they will disappear by their own. There is no scarring in the end. There is no scarring in the end. The next is the subcutaneous nodules. Just below the skin, there are subcutaneous nodules. So multiple subcutaneous nodules are formed like this, like this. They are near joints. They are near joints. These are 1 centimeter, small subcutaneous nodules are formed. They are non-painful, non-tender. No pain, no tenderness. So no pain, no tenderness, right? They disappear spontaneously. They are 1 centimeter near the bony prominences on the extensor surface. Okay, that is the thing, right? We are done. I guess we are done with all 5. So in the rheumatic fever, most importantly, I told you the rheumatic heart disease, pancarditis in the heart. I told you endocarditis, myocarditis, pericarditis. Then I told you the brain, chorea. I told you the joints. I told you the skin, erythema marginatum, and I told you the subcutaneous nodules also. So I told you all 5 findings. I mean to say these extracardiac lesion, I told you 2-3 important lines. Don't go in the detail. But heart, I told you the detail. What happens in endo, what happens in myo, what happens in peri. So basically pancarditis. We are done with rheumatic fever. Everyone appreciate my efforts. No one will explain you rheumatic fever with such a simplicity. Now you will never forget. The 5 features, the 5 system involvement in rheumatic fever. Now you should know the important findings in each of them. Most important among them is heart. The pancarditis and heart. Okay, pancarditis. Say yes. Yes, it is more than sufficient for FMG. Definitely, definitely. You just watch my two videos, the general and hemat yesterday I covered and systemic I am covering today. It is more than sufficient. All questions will be from this only. Okay. So let's solve some questions on rheumatic heart disease and move on the next endocarditis. You please read the question. There is a 10-year-old boy, Pappu, dead of rheumatic fever. Okay. So there is a 10-year-old boy who's dead of rheumatic fever. We are doing the autopsy. In the autopsy, we find all of the following except what is not present in the autopsy. So what is not a feature? What is not a feature of rheumatic fever? Tell me that. Tell me that. What is not present? Yes? Tell me. So is it Eshkoff nodule? Yes or no? Rupture of chorda tendini? Yes or no? McCallum patch? Yes or no? Fibrinous pericarditis? Yes or no? So Eshkoff nodules are present. They are present in myocardium. McCallum patch present in mural endocardium. Fibrinous pericarditis present in pericardium. But we have not read there is anything rupture of chordae tendineae taking place. So I will go with B. It is not A, Debajan. The correct answer is B. A will happen, na? Eshkoff nodule to pathognomatic feature. The most important among them is the pathognomatic is the Eshkoff nodule, which is present in the myocardium. Yes, rupture of chorda tendineae is not a feature of rheumatic fever. Maybe some other disease, but not a feature of rheumatic fever. The correct answer here is B. Coming on the next question, anti-Eshkoff cells are what? I told you two type of cells. Ashkoff cells are giant cells and anti-Ashkoff cells are uninuclear cells having two type of nucleus, either the caterpillar or owl eye. So it is the same cell. From front it's caterpillar, from side view it's like owl eye. So what are these two cells? These are modified macrophage or neutrophil or modified B lymphocyte or modified RBC. Can you please answer? Yes. What is the correct? Yes, Osama. These both are modified macrophages. Please learn. Both of them are modified macrophages. You all are right. Can we go ahead now? Okay. Okay. Most common wall involved in rheumatic fever. Can you tell me what is the most common wall involved? Is it mitral, aortic, pulmonary or tricuspid? Which is the most common wall? I told you the mnemonic. Can you please apply the mnemonic and tell me the correct answer? Most common wall involved in rheumatic fever. The mnemonic is mattab. Yes, you all are right. The correct answer here is the mitral wall. Very good. Mitral wall. If I change the question, instead of most common, the same question, I'm asking least common. What is your answer now? So P, pulmonary will be the least common, right? So based on the question, you should answer it correctly. You know the mnemonic mattab, you can answer it. Coming on the next question. The next question is in front of you. The most characteristic histological finding of rheumatic carditis. Characteristic finding. Is it fibrinous pericarditis? Is it pathognomonic vegetations? Is it pathognomonic Ashkoff nodules? Is it pathognomonic or increased vascularity? I'm not asking what is happening. They all will happen. They all will happen in rheumatic fever, in rheumatic heart disease. I'm asking the characteristic feature. I mean the pathognomonic feature. What is the correct answer now? The pathognomonic feature. What is the correct answer now? Yes? The correct answer here is the Ashkoff nodules. Ashkoff nodules is the pathognomonic feature. You all are right. The next question is in front of you. McCallum patch are seen in which auricle? There are four chambers in heart, no? Right auricle, left auricle, right ventricle, left ventricle. So among them, the McCallum patch is present in which chamber? Which chamber? I have drawn the diagram and shown it to you where it is present. So what is McCallum patch? It is a wrinkled area which is present in one of the chamber. So yes, you all are right. It is present in left auricle. So correct answer here is B. It is present in the left auricle on the posterior wall. Okay. The next question is in front of you. All are true about erythema marginatum except. The question includes except. Don't miss it. About erythema marginatum which is occurring in the skin. Remember the diagram I have shown you, bathing suit distribution, right? So bathing suit distribution, yes or no? Early manifestation, yes or no? Pruritus means itching take place, yes or no? And seen rarely. So what is not seen? Tell me the except. Tell me the except. Who will tell me the answer? Yes, you all are right. You all are right. The correct answer is pruritic. It is never pruritic. I told you these are non-pruritic lesion. These are non-pruritic, right? So I guess we are done. We are done with the rheumatic fever till now. Till now we are done with rheumatic fever. Now let's come on the next two together. So let's say first we will say Libman-Sec. First we will take, yes, Libman-Sec endocarditis. Libman-Sec endocarditis occurs in SLE. You know what is SLE? Systemic lupus erythematosus. It's an autoimmune disease. So here also vegetations are formed, but the reason for the vegetations is SLE. The reason for the vegetation is SLE. Here also vegetations are formed. Here vegetations are medium size. वहाँ पे small size थे in rheumatic fever. Here they are medium size. वहाँ भी multiple, यहाँ भी multiple. Here they are flat. That's why known as verrucous. Verrucous का मतलब है flat. So more or less the vegetations are flat. They are like flat. Like, right, they are granular. They are also sterile. They don't have bacteria. Okay. What is the location? What is the location? So can you see this is left auricle, this is left ventricle, and these are the two cusp. These are the two cusp. So they are present on the upper surface as well as lower surface, not at the junction. They are present on upper and lower both surface. You see, I have drawn the vegetation both ways. Upper surface also, lower surface also. They are flat and present on both surface. Not only on both surface, they continue on the adjoining auricle and adjoining ventricle along with the pockets. Pockets is the corners. So they are present on upper surface, lower surface, on the corners, and the continuing with the auricle and ventricle. So this is the location, please appreciate, right? On which wall they are present? The mnemonic is same, mattab. Present most commonly on mitral. Location on both surface along with adjoining auricle and ventricle, and they do not produce fish mouth deformity. So please compare rheumatic heart disease with Libman-Sec. Till now we have covered two. Rheumatic heart disease, they are small, present at the junction line of closure. In Libman-Sec, they are medium size. यहाँ पे small हैं, यहाँ पे medium size हैं. Please learn. Right, here they are present on line of closure. Here see, intentionally I have shown you the diagram below surface. They are present on lower also, upper as well as lower, both surface, upper plus lower, along with the adjoining auricular and ventricular surface, right? So they are present on both the surface, right? So we are done with SLE also, Libman sac. Here we will see a small detail. So rheumatic fever is done, SLE is done. Coming on the next one, NBTE, non-bacterial thrombotic endocarditis. Non-bacterial thrombotic endocarditis. Here also vegetations are formed on the surface of the heart. But the reason for this vegetation is hypercoagulability. Actually, these are not vegetation, these are thrombus. Multiple small thrombi are formed. You know what is thrombus? Small clots which are formed without injury. With clot, it's hemostasis. Yesterday I taught you. And without injury, if the clotting is there, it's thrombus. So when the blood is hypercoagulable, multiple thrombi are formed on the heart walls. They are looking like vegetations. So that is the reason for vegetations. It's hypercoagulable blood. These are also sterile. Bacteria is not present in them. But these are small or medium. And these are small or medium. And where they are present? Where they are present? Let me see the location. They are present again on the line of the closure. Like rheumatic heart disease, they are present at the junctions. They are present at the junctions, right? So compare, and they are present on the same wall. Mattup is same for all of them. The mnemonic is mattup. Okay. So here also the mnemonic is mattup. You can see, and that's it. So you can see 3 till now. Please see this one, and this one. Yes. So here I told you the vegetations are small. Here I told you it's medium. Here also it's medium. Here they are present at line of closure. Here they are present on upper and lower surface. Here again on line of closure. Here the cause is rheumatic fever. Here the cause is SLE. Here the cause is hypercoagulability. Say yes, I am trying very hard to explain you. Let's solve some MCQs and coming on the last one, infective endocarditis. Okay, so after that CVS is also done. So let me come on some MCQs. See, this is the question. Can you tell me the answer, please? Can you please tell me the answer? What is the correct answer? The flat vegetations present in the pockets. 2 clues are given to you. The vegetations are flat only in one of them, and they are present in pockets means corners only in one of them. Is it rheumatic heart disease? No. Here the vegetations are present at the line of closure. Is it NBTE? No. Here the vegetations are present again at the line of the closure. Is it infective endocarditis? I have not taught you till now, but I will tell you here vegetation is present only on upper surface. But in Libman sac, they are present on both surface. They are flat also, along with the both surface present in the pocket also, and they are present on adjoining auricle ventricle also. So correct answer is Libman sac endocarditis. Is everyone agree with me? So correct answer here is B. You all are right. The next question is in front of you. Which type of endocarditis have vegetations on both surface? I told you one of the endocarditis having vegetation on both surface. Learn their location. Their location is very typical. In rheumatic fever, they are present on line of closure. In infective endocarditis, it is present only on upper surface. I will tell you in the next one. Only on upper surface. But in Libman sac, it is present on upper plus lower both surface. So correct answer here is B. It's Libman sac endocarditis. Yes, read is enough for NEET PG, FMGE, all exam. I am doing you a complete coverage. I mean to say I am covering the most important high yielding topics. So your 90% paper will hit from these topics only. Otherwise, I cannot take the guarantee. No one can take the guarantee of all questions. Nah? But I can challenge 90% of the questions will be from these topics. These are highly repeated topics. You know, you cannot miss them. So yes, the correct answer here is B, and you all are right. The next question is in front of you. Vegetations in Libman sac are. Can you describe? Okay, we can leave it. We have already done. So coming on the last type of endocarditis, infective or bacterial endocarditis. Infective. Here also vegetations are formed on the surface of the heart. Here also vegetations are formed. Can you see vegetations are forming in all 4? So here also vegetations are formed. But here the vegetations are formed only on upper surface. You can see on all 4 walls only on upper, not lower. Not at the line of junction. It is present on the upper surface. Number 1. The reason for vegetation is infection. Infection by the bacteria. So here the reason is not SLE. It is not rheumatic fever. It is not thrombi or hypercoagulability. Here the reason is the infection by the bacteria. I will tell you the name of the bacteria also. So it is infective endocarditis. It is due to microorganism, the bacteria. It is of 2 types, Abe, Sabe. Acute bacterial endocarditis, subacute bacterial endocarditis. It is of 2 types, Abe and Sabe. Acute bacterial, subacute bacterial. What do you mean by that? Imagine 2 hearts in front of you. Can you see the 2 heart diagrams in front of you? Imagine the first and the second. In the first heart, see the mitral wall. This is a healthy wall. In the second heart, this is the mitral wall. It is diseased. it is having either MR or it is having MS or it is a prosthetic wall. It is not a healthy wall, it is a weak wall, it is a diseased wall. So here, if some bacteria want to cause the vegetation or infection of this healthy heart wall, the bacteria should be very virulent, very powerful, very virulent bacteria is required to damage the healthy wall. And the name of that bacteria is Staph aureus. Okay, here, since the wall is already diseased, already weak, so even a bacteria with low virulence, low power can cause the vegetation, can cause the disease. So here the name of the bacteria is Streptococcus viridans. Streptococcus viridans. Here, since the bacteria is very powerful, in less than 6 weeks it's done. It is known as acute bacterial endocarditis. And here, since the bacteria is very weak, low potent, low virulence, it is more than 6 weeks are required. It is known as subacute. So tell me the meaning of acute and subacute bacterial endocarditis. I mean to say Abe and Sabe. What is the difference? Here the heart walls are healthy, here they are diseased. Okay, here the heart walls are healthy, so a high virulent bacteria like Staph aureus is required for causing the damage, and it will do in less than 6 weeks because it is very virulent. Here, since the heart walls are diseased, even a bacteria with low virulence will work, and the name of that bacteria is Streptococcus viridans, and it requires more than 6 weeks. Everyone say yes. You got it? Can we go ahead? So Abe and Sabe, you can see the same thing is written, right? Here the vegetations are large. सबसे बड़े vegetation है. Compare all four. Who is the biggest one? I guess everyone can see it is the large. Here vegetations are small. In this it's small. Here it's medium. Here it's medium. Here it's large. ये सबसे बड़े हैं and most fragile. You know the meaning of the fragile? You know the meaning of the fragile? They can dissociate and go away. They will form the ambuli. They are not very fragile, the others one. But this one is large, this one is fragile. It is present only on upper surface, right? So here the vegetation present on line of closure, here on upper surface, here it is present, again line of closure, here on both surface, upper surface plus lower surface. Okay, here vegetations are flat in Libman sac. In others, it's not flat. The reason is different. Here reason is rheumatic fever. Here reason is bacteria. The two bacteria I taught you, Staph aureus in Abe and Streptococcus viridans in Sabe. Here the reason is thrombi or hypercoagulability, and here the reason is SLE, right? So learn the location of the vegetation, learn the size of the vegetation, learn the reason. So this is the most important thing. Okay, yes, Osama, you can say the najuk, fragile is najuk. You can say that. So, okay. So these are the vegetations. They are very fragile, very fragile. Don't miss this word. They are very large and that's why they are fragile. क्योंकि बड़े बड़े हैं ना तो easily टूट जाते हैं. So they are large and fragile. You can see. So on which wall they are formed? In all of them it's mud up only. But they are formed only on upper surface, not on lower surface. Right? So you can compare. They can form abscess. You know, since they are bacteria, na, bacteria form pus. So inside the vegetation, they go in the myocardium and they can form abscess. Can you see here? They can form abscess. They have complications also. Listen, this is the abscess. Most common complication in the heart, see the pus. See the yellow pus. They form abscess. Only one of them form abscess, this one. And the extracardiac complications, see here. Where are the vegetations? So these are the heart walls. Where are the vegetations? You will say, ma'am, vegetations are present on upper surface. They are large. They are big. They are present on upper surface, okay, not on lower surface. I told you these vegetations are very fragile. Imagine from the left side, these vegetations get detached. So where they go? They will go in the left ventricle after detaching. From the left ventricle, they will go in aorta. And from the aorta, they will go in various organs and obstruct various organs, causing ischemia in various organs. Agree or not agree? Yes. So they will obstruct. Most commonly, they will go in the nail beds. They will go in the fingers and arteries. Right, and they can cause two type of complications because of the ambuli which is traveling in the aorta after fragile dissociating from the left ventricle. They are reaching here in the hands, the blood supply of the hands. They can cause two things. What two things? Osler's node and Janeway spots. These are Osler node and these are Janeway. These are Janeway spots. Osler nodes are present at the tip of the finger. They are painful, and Janeway are present on the palm. They are non-painful, right? Again, Osler present at the tip, they are painful. They are painful, pain present, tenderness present. Janeway present on the palm, the pulp of the palm, pain absent, tenderness absent. Please learn. All these are your MCQs. Say yes. For rheumatic fever, we have Jones criteria, rheumatic endocarditis. For infective endocarditis, we have Duke's criteria. वहाँ पे modified Jones था, यहाँ पे modified Duke है. So here also we have 3 major criteria, 6 minor criteria, and 2 pathological, but don't go in the detail, just learn the Duke's criteria. We are done with the 4 type of endocarditis. Everyone give me a thumbs up. The 4 type of endocarditis is in front of you, everyone here. The rheumatic fever, NBTE, non-bacterial thrombotic endocarditis, Libman-Sack endocarditis, SLE, and infective endocarditis. Most important is their location. The first 3 are sterile. They are not caused by bacteria. The rheumatic fever caused by one is caused by rheumatic fever. The non-bacterial one is caused by hypercoagulability. Libman-Sack is caused by SLE. That's why they are sterile. But the last one is seen due to bacteria, infection, abscess. That's why this one is non-sterile. See their location. Please see their location. So this one is at line of closure. This one also at line of closure. This one only on upper surface. This one on upper surface plus lower surface. Please appreciate it. Now, any question on endocarditis you can crack like this. With this master table, with this orientation. Any image-based question, conceptual question, clinical question. Doesn't matter. You are prepared. I guess you are prepared. Give me a thumbs up. Yes? Can we go ahead? Only few people interact with me. What about others? What about others? Why don't you interact? Why don't you talk? Why don't you say something? If you have doubt, you can ask. If you don't have doubt, you should appreciate that you got it. Okay? Anyways, we will solve some MCQs. Please have a look on the question and tell me the answer. Bacterial endocarditis most commonly caused by. I forgot to tell you, most commonly Staph aureus is the cause. That is Abe. Okay? So correct answer here is Staph aureus. The bacterial endocarditis, the most common cause is Staph aureus. Okay? Okay, one more question. Non-sterile vegetations are seen in which endocarditis? Only one of them have non-sterile vegetation. What is the correct answer? Is it rheumatic fever, infective endocarditis, NBTE, or Libman-Sack endocarditis? Non-sterile. Non-sterile means bacteria is present. In which of them the bacteria is present? Can you tell me the answer? What is the correct answer? Then infective. Of course, common sense. In infective one, it is non-sterile because bacteria is present. Okay, the next question. Very commonly asked question, important question. In which of the following vegetations are friable, very friable, easily detachable? One of them, the vegetation is very friable, easily detachable. They are very nazuk. So is it rheumatic fever, rheumatoid heart, SLE, or infective endocarditis? So what is the correct answer? I guess everyone knows the correct answer is the infective endocarditis because here the vegetations are very large. That's why they are very friable and fragile. Friable, fragile is one and the same thing. Okay, so is it done? Can I come on the next question? Tell me firm watery vegetation along the line of opposition, the line of closure. It is present in which one? Line of closure, do mein tha. It was present in 2. It was present in, okay, rheumatic heart disease also, NBTE also. So you can go with both. Because in both of them, line here only C I have written, A and C both is the correct answer. In both of them, it is at the line of closure. We are done. We are done till now. Can we go ahead? Can we go ahead? Say yes. If we can go ahead, say yes. Can we move to the next topic? Till now, we have covered 2 systems. We have covered blood vessels. We have covered CVS. It's a non-stop marathon. Huh? So I'm starting the third system, CNS. In CNS, I will be teaching you meningitis. So let's start meningitis. You always get a question on meningitis, especially in FMGE. You every year get a question on meningitis. You cannot skip that. It's a very important topic. Can we start CNS, the meningitis? Are you people there? Yes? So let's start meningitis. Okay. So let's start meningitis. First, you should understand what is meningitis. Then only you should have an understanding what is meningitis. Okay. Now, what is meningitis? For understanding meningitis, you should understand central nervous system. In central nervous system, we have 2 things, the parenchyma and the coverings. The meninges are the coverings. Can you see? Central nervous system made up of 2 things, the brain and the spinal cord. You can appreciate this is brain, you can appreciate this is spinal cord, this is central nervous system. Now, the cells which are present inside the brain and the spinal cord, that is forming the parenchyma, right? So, for parenchyma, 3 types of cells are present. So, the neurons are the most important cell which are present. We all know neurons are present. The neurons are the most important cells which are present here. Along with the neuron, the 3 supportive cells are present which are known as neuroglia. And the macrophages are present which are known as microglia. The 3 supportive cells, that is neuroglia, are astrocytes, oligodendrocytes, ependymal cells. These are the neuroglia. These are the supportive cells, right? And neurons are the main cell and microglia are the macrophages of the brain. Like the macrophages in the liver are known as Kupffer cell. In the same way, the macrophages in the brain are known as microglial cell. Can we go ahead? So this is the parenchyma. Now what about the coverings? There are 3 coverings, the 3 meninges. The meninges are the coverings. You know, the innermost is the pyometer, the middle one is the arachnoid and the outermost is the dura. See, This is the innermost pia meter. I have shown you with red color. This is innermost. It is adhered with the brain and the spinal cord. The middle one is the arachnoid. You can appreciate the arachnoid. It is just above the pia meter. And the outermost is the dura meter. You can see the dura meter is adhered to the skull and the vertebra. So innermost, middle, outermost, right? So you can see what are the spaces. Let me draw the brain. Here I am drawing the brain. This is brain and this is skull. This is skull bone and this is brain inside that. This is the brain parenchyma. These are the cells. This is brain parenchyma and this is skull bone. So what are the three meninges? I mean to say the pia meter is adhered here. So let me use the highlighter. Let me use the different colors. So this is the pia meter. It is the innermost. It is closely adhered with the brain and spinal cord. There is no space. So this one is pia meter. Okay. The middle one is the arachnoid. This one is arachnoid. And the outermost one is the dura meter. So how many spaces you can see? How many spaces you can see? I have drawn this diagram to show you the spaces. So there is a space between pia and arachnoid. Can you see the space? It is known as subarachnoid because it is present below arachnoid. This is known as subarachnoid space. And there are two spaces. One, this is dura, no? This is dura. One above dura, one below dura. So above dura is epidural and below dura is subdural. Very easy. Epidural and subdural. Your concept should be strong. Okay. And there is subarachnoid. This one is subarachnoid. So you can see the three spaces. Epidural, subdural, subarachnoid. The subarachnoid one is filled with CSF. So CSF is present here. Imagine, just a second, the CSF is present in the subarachnoid space. This is CSF. The CSF is present here. You got my point? Now let me come on the disease meningitis. What is meningitis? As I told you, meningitis is inflammation of the meninges. The meninges get inflamed. That is known as meningitis. So for diagnosis, we do the CSF tapping and take the CSF out in a test tube and look for that. So CSF is taken out in case of meningitis. You got my point? So this is the same diagram. You can see this is brain, this is skull bone, and the meninges are shown to you in between. So let's come on the topic meningitis. Let's come on the topic meningitis. Meningitis is the inflammation of the meninges. It is the inflammation of the meninges, the three meninges, right? Now there are three types of meningitis. One is caused by the bacteria known as bacterial meningitis. It is acute. It is acute in nature. That's why acute bacterial or pyogenic meningitis, because bacteria produce pus. So bacterial meningitis or acute pyogenic meningitis, one and the same thing. The second is caused by the virus. It is known as viral meningitis. Here the lymphocytes are raised. That's why it is known as acute lymphocytic meningitis, right? It is also acute. This one is acute, this one is acute. The third one is the chronic meningitis. The third one is the chronic meningitis. You got my point? Chronic meningitis, the third one. The chronic meningitis is caused by one bacteria, that is TB, and one fungus, that is Cryptococcus. So that is the cause. Here all bacteria producing pus, here some viruses, and here TB and Cryptococcus is the cause. So basically out of the three types of meningitis, two of them are acute, one is chronic. So what are the three types of meningitis, please? Acute, chronic. Acute bacterial, acute viral, and in the chronic, one causes TB and the second causes the Cryptococcus fungus, right? So that is the three type of the meningitis: acute bacterial, acute viral, and chronic. Chronic is due to TB. The bacterial one also known as pyogenic, the viral one also known as lymphocytic. I told you the other name. Okay, now which type of meningitis is it? If it is bacterial, the treatment is antibacterial drug, antibiotic I mean. If it is viral, the treatment will be antiviral drug, and if it is due to TB, the treatment will be DOTS. If it is due to Cryptococcus, the treatment will be antifungal drug. So knowing the cause is very important. All of them are meningitis, but the knowing is the cause is very important. For diagnosis, you take the CSF out. How to take the CSF out? How to take the CSF out? The CSF is taken by the lumbar puncture. So in the vertebra, between L3 and L4 vertebra, we put a needle. I don't have diagram. We put a needle there and we just take the plunger out, the lumbar puncture needle, and we take the CSF and transfer in a test tube. So this is the CSF collection, and looking in the CSF we can decide the type of the meningitis. So before looking at the abnormal CSF, you should know the normal CSF. What are the findings of the normal CSF? The normal CSF is clear and colorless like water. Clear, colorless like water in a test tube. The normal CSF pressure is 60 to 150 mm of water. It's up to 150 mm of water. Normal CSF have cell. If you take out any healthy human being CSF, does it have cell? It never have neutrophil. Normal CSF have never, even a single neutrophil is abnormal. Even a single neutrophil in CSF is abnormal. So normal CSF have lymphocytes up to 0 to 4 per microliter, not more than 4. More than 4 is abnormal. right? Normal CSF have glucose as well as protein. Learn the normal value. Protein is 15 से 45, 15 to 45, and glucose is 50 to 80 milligram per deciliter. Both of them are milligram per deciliter. And normal CSF don't have any bacteria, virus, fungus, parasite. It's sterile. Of course, we know the normal finding. Now, what are the symptoms of meningitis? All the three meningitis, whether acute, bacterial, acute, viral, or chronic, all of them have these symptoms. The patient have fever, especially the fever is high grade if it is pyogenic one, bacterial one. The patient have headache and the patient have neck stiffness, especially on forward bending. It's very typical finding. Whenever in your question you get a clue the patient is having neck stiffness, it's very typical finding, right? And the changes have altered mentation. Altered mentation can be there, right? So these are the symptoms which are seen in meningitis. Now let's talk about three meningitis one by one. Let's take the first meningitis, bacterial one. Now compare with normal. What will happen? Here the CSF become pus-like cloudy. See, can you see? It is looking like pus is filled in the test tube. Normal CSF is clear water. So here the CSF is cloudy, purulent like pus. Number one. See the pressure. Normal pressure is 150. Here it's 180. If you see the pressure is up to 180. A little bit rise. See the cells. Here neutrophils are present. Normal CSF never have neutrophils. Normal CSF have lymphocytes. Here, if you make a slide of this, you can see only neutrophils. Abundant of neutrophils. See, all the cells are multilobated. All of them are neutrophils. Abundant. Even a single neutrophil in CSF is abnormal. Here, 100 to 10,000 neutrophils are present. See, the glucose is reduced and the protein is raised as compared to normal. You will say, ma'am, what is the reason of both of them? I will tell you the reason. Now, this test tube contains bacteria. Imagine this test tube contains bacteria. We are talking about bacterial one, na? So CSF contains the bacteria. So whatever glucose present in the CSF, it is eaten by the bacteria as a nutrition. So that's why if you check the glucose, it is reduced because it is consumed by the bacteria. This is the reason why glucose fall. It is consumed by the bacteria. You will not forget now. And all the bacteria have cell wall. Agree? So all the bacteria have cell wall. Cell wall is made up of protein. So if you check the protein, the total protein is more because the bacterial cell wall is also contributing in the protein. So glucose is reduced and protein is increased. I told you the reason. And if you make a culture, you will get positive growth of the bacteria. Say yes, everyone got it. This is the bacterial one. Compare it with the normal. Coming on the next one, the viral one. Please, everyone on the screen, compare the viral one, the viral meningitis with the normal now. Compare it. Normal is clear colorless. This one is also clear colorless. It's clear and colorless, right? Here the pressure is up to 250. Normal is 150. Here up to 250. Here cells are still lymphocyte. You will say, ma'am, normal also have lymphocyte, but see the count. Normal have 0 to 4. This one is having 10 to 100. Please learn. It matters. Here virus don't take glucose. Virus don't have cell wall. So protein is normal and make it normal. Glucose is also normal. Here in bacterial, the glucose was falling, the protein is elevated, but here both are normal because viruses present in the test tube, they don't consume glucose and they don't have cell wall. So glucose is still normal, protein is still normal. That may differentiate it from the bacterial. And if you culture it, you will not get the growth. Viruses don't grow on culture plates. Okay, so we are done with the bacterial, we are done with viral. Coming on the last one, TB. I mean the chronic one. TB and cryptococcus are the two causes. The chronic one. Can I come on the chronic one? Right? Here, if you see the gross, it is having cobweb formation. At the bottom, you can see the cobweb is formed. At the bottom, this is the cobweb formation, like this, right? A web is formed. Normally, it is clear colorless. Here, a cobweb appearance is there. Cobweb is formed, right? Here, the pressure is up to 300. Pressure is up to 300. Normal pressure is up to 150. It's highest pressure. Here, the cells are again lymphocyte. You will say, मैं viral में भी तो lymphocyte थे और normal भी तो lymphocyte होते हैं. Yeah. So compare the count. Normally it's 0 to 4 lymphocyte. Here it's 10 to 100, but here it 100 to 1000. Number matters. Neutrophils present only in bacterial. Here also glucose will fall, protein will rise, the same reason, and you will find TB and cryptococcus here. For special stain for TB, do the ZN stain. For cryptococcus, you do India ink, the negative stain. India ink negative stain. So these are the special stain. Everyone give me a thumbs up. So basically what does matter to find out the three type of the meningitis, the bacterial, the viral and the chronic. You have to see the cells. Which cells are there? The cells matters. Here it's neutrophil and in the remaining two it's lymphocyte. See the number. Normally also lymphocyte. See the number. See the number. Number matters. This is meningitis, the approach to a case of meningitis. Let's solve two questions on that. We are done with meningitis. Let's solve 2-3 questions on that. Can we solve the questions, please? Are you people there? Can we solve the questions on meningitis? Are you people there? Say yes. Okay. So see, have a look on this diagram. There is a patient brought to the hospital with fever, with headache and with neck stiffness. The patient have three things: the fever, the headache. Whenever neck stiffness is given to you, they are talking about meningitis. Please take this clue. Whenever neck stiffness is given to you, they are talking about meningitis. CSF tapping is done. So gross is given to you, microscopy is given to you. The protein is increased and the glucose is less. Protein is more, glucose is less, and the cells are lymphocyte. When the cells are lymphocyte, it cannot be pyogenic. Rule out pyogenic. Okay, when the cells are lymphocyte, it can be aseptic. Aseptic means viral. It can be TB. It can be chronic, but it cannot be pyogenic. In pyogenic, neutrophils are raised. So by reading this, I rule out. What is the correct answer? See, appreciate the cobweb. And what is this diagram given to you? It is Zeden stain. So on Zeden stain, you can see the TB bacilli with the blue background. So correct answer is TB. You all are right. It is a recent PYQ. Correct answer is A. Coming on the next question, what is the most common cause of viral? I forgot to tell you the most common cause of viral is enterovirus. So let's move ahead. We are done with meningitis also. Let's take a small break. After that, we will continue. We will continue the systemic pathology. Till now, we have covered CNS, we have covered CVS, we have covered blood vessels, right? Many more to go. So I have to cover endo, respi, MGT, FGT, GIT, liver. I guess these are the important one which we have to go more. The breast also. Okay, so I will be taking them one by one. Don't worry, we will cover all today. But I will try to concise the session till 3 p.m. and it will be continuity with a small breaks in between. So let's take a small break of, let's say, 20 minutes. Hello everyone, am I visible? Am I audible? Am I back? Kindly you people confirm. If I'm back, I will start the session ahead. Let me see. If I'm clearly visible, audible, I will start the session ahead. I can see your chat, I guess. You can write in the chat box. I guess I can see your chat. Okay, just a second. Yes, yes. Okay. Is it clearly visible, audible? Siri, can we go ahead? Others, kindly someone respond in the chat box. If I'm clearly visible, audible, I will continue ahead. Give me a minute. Just a second. Okay, thank you. Thank you for confirming. Thank you so much. So coming on the next topic, coming on the next system, I guess. Just a second. Let me start the next system, breast. Let me start the next system, breast. So in breast, I want to teach you only one topic, breast carcinoma, the ultra important topic on which many frequently asked PYQs are there. So let's start breast carcinoma quickly, right? So breast carcinoma, you know, it is one of the most common cancer in females. Rather, in world, it is most common cancer in females only. So cancer of the female is one of the most common cancer in the world. Cancer of the male breast is very rare. You can see the ratio 1:150. So every 150 females, there is one male who can have breast cancer. Most common age in which it occurs is perimenopausal age. Menopause is considered at 50 years approx. So 45 to 55 years. So 5 years before that, 5 years after that. This is the age group in which breast cancer this is the age group in which breast cancer is most common. Okay, clinical features. What are the clinical features? Can you see a female? The female will come to you with 3 clinical features. There is a solitary, single, painless, palpable lump, which is usually palpated by the self-examination in the breast. The most important thing to see here, it's painless. You know, that's why there is a delay in diagnosis. You know, whenever there is something painless which is not giving trouble, so females usually they don't go to the doctors, to the physician for checkup. So because it is painless. But consider if it was painful, it can be diagnosed early. But unfortunately, it is single, solitary, painless, palpable lump. These are the clinical features usually diagnosed by the self-examination. Now for diagnosis, we do triple technique. What is triple technique? In triple technique, the first thing is the self-palpation. The self-palpation or palpation by the physician. Number 1, that is palpation. Number 2, mammography. Can you see inside the mammography? You can see the breast cancer in the mammography. Number 2. Number 3, FNAC. So we perform FNAC. We fix the lesion with one hand. With other hand, we put a very fine needle inside the lesion. You know what is FNAC? Fine needle aspiration cytology. So we put very small thin needle inside the lesion like this, and we do to and fro motion like this. We perform to and fro motion like this. So all the tumor cells present inside the lesion, they dissociate from each other, and then we suck the plunger. We take the plunger out. So here whatever fluid is formed, a small amount of fluid will come in the syringe, and we will make a smear out of that. We make a smear out of that fluid on the slide, and we look for the tumor cell. So it is a non-invasive or minimally invasive procedure. It is a quick procedure. It is a very cheap procedure. It is known as FNAC, fine needle aspiration cytology. Okay, can we go ahead? This is known as triple technique, the triple technique of diagnosis of the breast cancer. The most important thing which I want to tell you in this session is the histopathology, the various types of the breast cancer and histopathology of all of them. So before going on that, you should understand the structure of a female breast. So I forgot to put the diagram. I will draw it for you. So I'm drawing the diagram of a female breast. So this is the nipple area. You can see I'm drawing a female breast. This is the pectoralis major muscle. On the pectoralis muscle, the female breast is there. Now in the female breast, small ductules are present. I'm calling them, either you say ductules, or you say glands, or you say acini, one and the same thing. So these circular structures I'm talking, these are either ductules or glands or acini. So multiple small ductules, acini are present throughout the glands. So they all open in terminal duct. This is terminal duct. They all are opening in terminal duct. So multiple ductules opening in one terminal duct, they form one lobule. So this is one lobule. This is one lobule. You can see these are the lobules in the breast. Please understand the difference between ductule and lobule. Ductule is one, lobule is multiple ductule forming one lobule. So all the ductules opening in one terminal duct. Can you see this is a terminal duct? This is a terminal duct. This is a terminal duct. So all the ductules opening in one terminal duct frame one lobules. Now multiple terminal duct combined together and they open in lacticiferous duct. So this is lacticiferous duct. You can see lacticiferous duct go in the nipple and open in the nipple. Just before opening, there is a dilatation in the lacticiferous duct, which is known as lacticiferous sinus. You got my point? Now what is the function? Can you tell me what is the function of female breast? What is the function? So male breast is rudimentary. Female breast is functional or only during the lactation, during the breastfeeding to the baby. After pregnancy, during breastfeeding, during lactational, it is functional. So main function of the female breast is milk synthesis and milk ejection for the baby, right? So milk synthesis takes place inside the ductules. Inside all these ductules, the cells synthesize the milk. The milk will be going in the terminal ductules. From terminal ductule, the milk will come in the lacticiferous duct. From lacticiferous duct, the milk will come in the lacticiferous sinus and get accumulate there. Now whenever the baby will suck the nipple of the mother during breastfeeding, whenever the baby suck the nipple of the mother, all the milk will be going in the mouth of the baby. So this is the normal function and normal structure of the breast. Have you got it? Can we go ahead? This is the normal structure. Okay, now I hope you got what is ductule. This is a ductule, this is a ductule, this is a ductule. All these yellow structures are ductule because I'm going to teach you two types of breast cancer now. So this is a ductule and multiple ductule combined together, they open in one terminal duct. This is forming a lobule. So I hope you got the difference between ductule and lobule. The yellow ones are the ductules, the green one are the lobules. You got it? Give me a thumbs up if you got it. The ductule and the lobule. So I told you two things here. The ductule and multiple ductule opening in one lobule. Okay, so there are two types of breast cancer. If the breast cancer involves the ductule only, it is a ductal carcinoma. And if the breast cancer involving one lobule completely, it is a lobular carcinoma. So there are two types of breast cancer, the ductular and the lobular, ductal and lobular. I hope you understood the difference. If you understood, give me a thumbs up. If you understood what is ductule, what is lobule, then only you can understand the various types of the breast cancer. The ductal and the lobular. What is a duct? You can see these yellow structures are the duct. Can you see this one, the small circular structures? These are ductules, glands, acini, one and the same thing. Multiple ductules combined together and they open in one terminal duct. This is forming a lobule. So a lobule is having multiple ducts. You have to learn that. Come on, appreciate, you got it. Now see the classification of the breast cancer. How many types of breast cancers you have? You have two types of breast cancer, non-invasive and invasive. The non-invasive is also known as carcinoma in situ. It is non-invasive. Let me explain you the meaning of the non-invasive. Let me draw one. These are the ductules, imagine. And multiple ductules combining together and forming a lobule. So this is one lobule, you can say, having multiple ductules. Okay, now if the tumor cells are present inside the ductules only, it is in situ, it is non-invasive. Tumor cells are there, but they are present inside the ductule or inside the lobule. It is not coming out, right? It is known as non-invasive cancer. Till now, it is non-invasive. It is not coming out. It is non-invasive, also known as carcinoma in situ, right? What does the background contain? Let me show you the background. Let me mark the background. The background contains the fat. The female breast, the background contains the fat. It is all fat. It is known as stroma. It is known as stroma, right? So it is known as stroma. Once the tumor cell breach the basement membrane and they come out of the ductule and they come out of the lobule and they infiltrate the stroma, it is invasive one. It is invasive now. Now appreciate, you got it. What is non-invasive, what is invasive? I tried hard to explain you. So this is the same thing I tried to show you here. Can you see here multiple small ductules are there, and this is one lobule. Here one lobule is shown to you. Please appreciate, this is one lobule having small ductules. I hope you got it. You can see this is one of the ductules shown to you. These are normal cells of the ductule. Now please understand the difference. See the upper three diagrams, see the lower three diagram. The upper one, ductule, is shown to you. In this diagram, ductule is shown to you. And in the lower diagram, multiple ductule, two ductule are shown to you. It is a lobule. Multiple ductule is lobule. So you can understand this is all ductules and this is all lobules. Okay. Now this is a normal duct. See, normal duct, right? If the tumor cells are present only inside the duct, it's known as ductal carcinoma in situ, DCIS. See the full form? Ductal carcinoma in situ. It is ductal one. Duct is involved. Only one duct is involved. And it is in situ. It is present inside the duct. Okay. Once it penetrates out in the stroma, you can see it penetrating out in the stroma. It is invasive ductal carcinoma. It become invasive. From non-invasive, now it convert to invasive. But this is also ductal. This is also ductal. Both of them are ductal. Now coming on the lobular one. Please come on the lobular one. Here you can see a normal lobule. Here the tumor cells are present inside the lobule. They are not coming out. So it is lobular carcinoma in situ, LCIS. Lobular carcinoma in situ. Once they penetrate out, see, once they penetrate out, it is invasive lobular carcinoma. So please understand the four types of the breast cancer. They are in front of you. DCIS, LCIS. Ductal carcinoma in situ, lobular carcinoma in situ. Both of them are in situ. Invasive ductal carcinoma, invasive lobular carcinoma. These both are invasive one. Please appreciate, give me a thumbs up. You got the four types. So these are the four types of the breast cancer. The four types of the breast cancer. Ductal carcinoma in situ, lobular carcinoma in situ, both are in situ. In situ means carcinoma in situ are non-invasive. And ductal invasive carcinoma, lobular invasive carcinoma, both of them are invasive version. So I am going to give you four diagrams one by one. You got it? So basically breast cancer is of two types. Non-invasive one and invasive one. You got the meaning. Invasive means it is coming in the stroma, the yellow stroma. Okay. Non-invasive one also known as carcinoma in situ. Each of them is two type. Ductal, lobular, ductal, lobular. The duct is involved or lobule is involved. This is ductal carcinoma in situ. Okay. This is lobular carcinoma in situ. DCIS, LCIS. This is invasive ductal carcinoma. This is invasive lobular carcinoma. IDC, ILC. So we use these terminologies only. So if I say these terminologies, you must have an overview what I am talking about. If I say DCIS, LCIS, IDC, ILC, the first thing you should know their full form. Not knowing only their full form, you should understand the meaning of them. Let me show you the diagrams, the histopathological diagram for each of them. Let me start with in situ. First, let me show you the diagram of DCIS and LCIS. Then I will come on the invasive ones. So let's start the non-invasive ones. Let's start with this portion. The non-invasive carcinoma in situ. Non-invasive carcinoma in situ, the two type. DCIS, LCIS. So let's talk about DCIS. Can you see? See the first four diagram. First four. Don't see the last one. See the first four diagram. All of them are DCIS. The various types of DCIS. I mean to say the DCIS is of four types. Listen, listen. Can you see a duct here? 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 You can see the tumor cells inside them. None of them tumor cell is coming out. So all of them are ductal carcinoma in situ. In all of them tumor cells are concised. They are within the duct. They are not coming out. They are not penetrating out. So they all are carcinoma in situ. And they are all are involving one duct. That's why they are ductal. Now what is the difference between them then? What is the difference between them? The arrangement of the tumor cell is different. See the first one. Here the tumor cells is compactly present throughout the duct. It is known as solid. It is known as solid. In the second one, there is necrosis at the center and tumor cells are present at the periphery. It is known as comedo type. Comedo means tumor necrosis is present at the center. The third is the papillary. The tumor cells are arranged like finger-like projections. Can you see? The finger-like projections. The tumor cells are arranged like fingers. It is known as papillary type. And last one is the cribriform, in which the holes are there. I mean cribriform matlab sieve. है ना, छन्नी के जैसा arrangement है. It is sieve like arrangement, you know. So it is sieve like arrangement. So see the four arrangement, they all are DCIS. One thing is common in all of them. They are present, all the tumor cells are present within the duct. None of them is coming outside the duct. That's why they all are carcinoma in situ. And they all involve one duct. That's why they are ductal carcinoma in situ. So one thing is common in them, but the arrangement of the cells is different. So say what are the four types? Solid, comedo, papillary, cribriform. You understood the difference. In the solid, it is completely plugged with the tumor cells. In comedo, there is a central necrosis. Tumor cells are present at the periphery. In papillary, they are finger-like projections, papillary projections. And in cribriform, it is the fenestrations like sieve. Okay, I appreciate you got it. Now coming on lobular carcinoma in situ, it is only of one type, the last one, this one. It is only of one type. It is solid only. Here the lobule is involved. This is not duct. Here multiple ducts are involved. Multiple duct means one lobule. And here only one pattern is there like solid. You will say, ma'am, then what is the difference between this solid and this solid? Here one duct is involved. Here one lobule is involved. Here also it's in situ. It is not coming out. The tumor cells are within the duct. Here tumor cells are within the lobule. It is not coming out. Both are in situ. Okay. Here tumor cells are compactly placed with each other. Here tumor cells are loosely arranged with each other. So there is a difference in pattern. Here also solid, here also solid. But here tumor cells are compact and here tumor cells are loose. The word loose is indicating LCIS. So tumor cells are loosely cohesive with each other. You got it? Can we go ahead? So we have seen the two diagrams till now. DCIS, LCIS. What is DCIS? DCIS is of four types. Solid, comedo, papillary, cribriform. And LCIS is only one type, solid. Right? So here the duct is involved, here the lobule is involved. I hope you can draw the diagrams. Here you have to draw the four diagrams, here you have to draw one diagram. We are done with carcinoma in situ. Let's come on invasive carcinoma. So invasive is also of two types. Invasive ductal carcinoma, invasive lobular carcinoma. Here the duct is involved, here the lobule is involved. Both of them are invasive. So let's start with the invasive ductal carcinoma. Then we will come on invasive lobular one. This is invasive ductal carcinoma. See, okay, I will draw a diagram for you. I will draw a diagram, beautiful diagram for both of you, for both of them. So see, IDC, ILC. Okay, let me draw the ducts here. Okay, these are the ducts. Let me draw the lobules. These are the lobules. Multiple ducts are forming the lobules. These all are lobules here. Okay, let me draw the tumor cell. Here four types are possible. So here it can be solid. It can be central necrosis like comedo. Okay, it can be papillary. It can be cribriform, whatever. Okay, whatever. Here only one pattern is there. Here it's solid only. In lobular, it's only solid. Okay, the lobules are filled with the solid pattern of the tumor cell, loosely cohesive with each other. My point is that in both of them, the most important thing, the tumor cell will penetrate and come in the background. Let me penetrate the tumor cell and let me take them in the background. So let's take the tumor cell out, and please fill them in the background. In the background, please mind my words. They can be single, as I have drawn. They can be in small groups or clusters. They can be in chains. They can be in small nest. There is no fixed pattern in IDC. In IDC, they can be single also. They can be clusters also, groups also. Okay. In ILC, they are also coming out. They are coming in the background. That's why it's invasive. But here, they have a peculiar pattern. They are in a line. In the background, they are in a line. They come out and they are in a line, one behind the other, forming small train, one behind the other. Say yes. You got it? So this is the pattern. You can see, you can appreciate in front of you. So the most important point to understand here or to differentiate them, here also stromal invasion is there. Here also stroma is the background. The background is invaded in both of them. But here there is no fixed pattern. In IDC, they can be single, they can be groups, they can be clustered, they can be nest. But in ILC, they are in a row. They are in a row. They are in a row. This typical pattern is known as Indian file pattern. Indian file pattern. Let me show you the both in this diagram. See here. First IDC, you can see this is the diagram. Okay. Can you see a duct here? Can you see a duct here? So both of them, this is showing solid DCIS. This is showing comedo. I can see the central necrosis. From both of them, the tumor cells are coming out and infiltrating the background. See, here also tumor cells are, so here they are arranged in group, they are arranged singly, they are arranged in glands, they are arranged in cluster. So you can see the invasiveness is there, stromal invasion is there. In lobular carcinoma, invasive lobular carcinoma, this is the diagram. You can see this is a lobule. The lobule have only one pattern here. It's solid. You can see solid here also, here also. From here the tumor cells are coming, but they form a row. See the row, one behind the other. Appreciate one behind the other. Appreciate one behind the other. Appreciate one behind the other. They form a row in the stroma. It is known as Indian file pattern. What is Indian file pattern? This pattern, one behind the other, is known as Indian file pattern. It's very important IBQ. It's very important PYQ. Indian file pattern. Please appreciate. Got it? Everyone got it? Anyone who didn't got it? The Indian file pattern. So compare the two IDC. They are in front of you. Just a second. Can you please compare the two IDCs? They are in front of you. This is IDC. This is ILC. Invasive ductal carcinoma. Invasive lobular carcinoma. Appreciate in both of them, see the background. The background is important. In both of them, there is a background stromal invasiveness in both of them. But here there is no fixed pattern, and here there is a fixed pattern that is known as Indian file arrangement. Indian file arrangement. And here it can be groups, it can be clusters, it can be individual. Say yes. So this is the difference between them. We are done. We are done with DCIS, LCIS, IDC, ILC. Can you draw the four diagrams for me? In DCIS, can you draw the four diagrams? Let's draw the four diagrams. DCIS, DCIS, LCIS, IDC, ILC. Can you please help me? DCIS is of four types. I'm not drawing, I'm just writing. You can draw if you wish. Solid, comedo, papillary, cribriform. You know how to draw it. They are concised inside the duct. They will not come out. Tumor cells are concised inside. In LCIS, only solid pattern is there. They are concised inside the lobule. They will not come out, right? But in IDC and ILC, after filling the lumen, they infiltrate and they come in the background. So here they can come singly, they can come in groups, they can come in glands, circular glands, they can come in clusters or nest. There is no fixed pattern. But here when they come out, they are in a row. They are in a row. They are in a row, which is known as Indian file pattern. I cannot explain more easier than this. Please respond. Please respond. If you are sleeping, please awaken and please respond. So you got it. That is the four type of the breast cancer I simplified for you. One more thing I would like to highlight here in the breast cancer is the Paget disease of the nipple. You know what is Paget disease of the nipple? Paget disease of the nipple, it looks like this. So on the nipple of the breast in the female, around the nipple, there is an aximatoid scaly lesion. Aximatoid scaly lesion in which the female have pruritus, the female have itching, and it is bleeding, right? So it looks like a skin infection. It looks like some skin infection. Can you appreciate it? So it is always around the nipple, periareolar. This area is known as periareolar. Periareolar region, there is a lesion which is aximatoid, scaly, having pruritus, itchy, and it's bleeding. So it's highly itchy, and the lady can feel there is some skin infection. Usually they go to the dermatologist, but it can be a hidden malignancy. It can be a hidden malignancy. I have told you the diagram of the breast. Can we revise the diagram of the breast? This is the diagram of the breast. Okay, in the diagram of the breast, I told you multiple ductules are there, right? They all bind together and they form the terminal duct. Okay, multiple terminal duct open in the lactiferous duct. This is a lactiferous duct. And multiple terminal ducts open there. Have I told you this? Imagine if there is a cancer in one of the ductule or one of the lobule, a small cancer. So basically the tumor is very small, hardly 0.5 centimeter or 1 centimeter. It is not palpable. The female is unable to palpate the tumor in her breast. It is a lumpy breast and female is unable to palpate it. Okay, so tumor cells are traveling in the terminal duct. They are traveling in the lactiferous duct. They are coming out, and after coming out, they enter in the skin. What are the layers of the skin? In the skin, we have two layers, epidermis and dermis. So in the epidermis, there are 5 layers, stratum bacilli, stratum this, stratum that, you know the 5 layers of the epidermis. So basically, these tumor cells enter in the epidermis. Around the nipple, okay, and that's why the lady is presenting as an aximatoid lesion of the nipple. So it looks like the lady is having some skin infection, the scaly lesion, but it is indicating some underlying hidden malignancy. So if you are a dermatologist and such lady is coming to your clinic, doctor, I am having itchy lesion around the nipple of the breast, you should refer it to the oncologist. You should ask the lady to go for a mammography. It can be showing some hidden malignancy. You got my point? So that is known as Paget disease of nipple. Paget's disease of nipple. It is showing the hidden malignancy. Appreciate it? Got it? This is Paget disease. So it is the axamatoid lesion of the nipple associated with invasive or non-invasive underlying carcinoma, which is very small. It's a malignant lesion. So can you see the same diagram here? Can you see this is the tumor? This is a tumor, a small tumor. Appreciate the tumor cells are going in the lactiferous duct. From the lactiferous duct, it is entering around the nipple in the epidermis. They enter in the epidermis. So these cells are known as Paget cells. The cells in the epidermis are known as Paget cell. Okay, this is Paget disease. Grossly, you can identify this is the lesion around the nipple. It is crusted, fissured, ulcered, oozing with the blood. So this is a typical scenario. It can be a IBQs, typical spotter. It's an image based question. Okay, histologically you can see the Paget cell. Can you see it is all epidermis, skin. In the skin you can see the big tumor cells. These are the Paget cell. So that's all about the breast cancer. Before ending the breast cancer, I must tell you the molecular classification of the breast cancer. Shall I tell you the molecular classification of the breast cancer? Are you people there? Can I continue the molecular classification? What is molecular classification of the breast cancer? Now, all female breast, all female, healthy, all female breast. This is the breast of a healthy female. Okay, these are the cells. These are the breast cells. Multiple breast cells are present. I mean, these are the ductules. The ductules are made up of the cells. These are the cells lining the ductules. Okay, on all the cells, 3 types of receptors are present. Estrogen receptor known as ER, progesterone receptor PR, they are present together, ER, PR. And the third one, it can be together, it can be alone. So that is known as HER2 or CERB2. So 3 types of receptors are present on the cells. So let me show you the cell. Can you see a normal breast cell? Appreciate. On the surface of the cell, appreciate the receptor. This is ER and PR receptor. They are normally present, but in low amount. When this breast cancer converted, when this normal breast cancer converted into cancer cell, at that time, see the number of the receptors. ER, PR increases drastically. See, 100 times, 1 become 100. It is increasing drastically. So basically, ER and PR, estrogen and progesterone present in the blood, that is acting as a growth factor. When estrogen and progesterone come and bind here, the cell divide and there is uncontrolled growth. Yesterday I told you, how does neoplasia occur in general pathology, right? So whenever growth factor is coming, binding with the growth receptor, there is uncontrolled mitosis leading to a formation of a lump, a mass. It is known as breast cancer. So estrogen and progesterone bind with the estrogen and progesterone receptor and they cause the cell division. So this is a breast cell. This is a breast cell. So estrogen and progesterone receptors are present. They increases during cancer. So estrogen present in the blood come and bind here. Progesterone present in the blood come and bind here. And when estrogen progesterone bind with their corresponding receptor, this cell undergo uncontrolled mitosis leading to cancer. This is regarding estrogen progesterone. The same with HER2. HER2 also known as CERB2. See the normal breast. In the normal breast on the surface you can see few HER2 receptors. But during cancer, again abundant. So they increase 100 times. They increase 100 times. Abundant HER2 receptors. You can see many HER2 receptors on the surface, right? So this is a normal breast. This is a cancerous breast. So when HER2 from the blood is coming and binding with them, it is causing their abnormal growth. You got it? Now based on that, there are 4 types of breast cancer. Everyone here on the screen. So you look for ER-PR occurs together. Don't differentiate them. ER-PR is estrogen and progesterone receptor, and one is HER2 receptor. So either both of them are positive, either both of them are negative. Either one of them is positive, one is negative, other is positive, one is negative. So there are 4 types of breast cancer. The first type is luminal A type of breast cancer in which ER-PR is positive, HER2 is negative. The second is luminal B in which both are positive. The third is basal. It is both negative. It is also known as triple negative breast cancer, TNBC. Okay, and last one, only HER2 is positive, ER-PR negative, it is known as HER2 positive breast cancer. You will say, ma'am, how does it matter? Being a doctor, how does it matter what type of breast cancer the lady is having? It matters for you. Number 1, patient wants 2 things from you. Number 1, patient wants the treatment, the specific treatment, and patient want to know the prognosis of the disease, right? Both of them depends on the molecular classification, right? Now, if the patient is ER-PR positive, if the patient is ER-PR positive, for treatment you give ER-PR blocker. The ER-PR antibody or blocker, you can say there is a drug tamoxifen. You will give the tamoxifen. in treatment. That is a blocker of ER/PR receptor. If it is HER2 positive, you will give Herceptin or trastuzumab. It is a monoclonal antibody, the targeted therapy. Trastuzumab, right? It's very costly. So depending on the molecular classification, you will decide the hormonal therapy of your patient. If the patient is ER/PR positive, give this. If the patient is HER2 positive, give this. If the patient is both positive, give both. If the patient is negative for both, give none of them. Give none of them. The triple negative breast cancer are the worst breast cancer because we are not giving any treatment to them. I mean, we are not giving any hormonal treatment to them. We give only chemotherapy because we don't know what is the growth receptor for them. You got my point? Yes, luminal A is having the best prognosis. The prognosis here is nearly 95%, right? Luminal A. And the basal or triple negative having the worst prognosis. Say it out, everyone. So what are the 4 types of the breast cancer? Based on ER/PR status and based on HER2 status. Can you tell me what are the 4 possibilities? Everyone on the screen, tell me the possibilities, please. What are the possibilities? Say ER/PR positive, HER2 negative. This is the best one. The best one. Okay. The second is the both are positive. Right, second best one. And third is only HER2 positive, this one is negative. The worst are both negative. The both negative is triple negative. Okay, so this one is known as luminal A, luminal A type. This one is known as luminal B type. This one is known as HER2 rich, only HER2 is positive. And this one is known as basal, also known as triple negative breast cancer, right? Being a doctor, you must tell the patient prognosis and the treatment. You must give the exact treatment. So here for ER/PR positive, you give only tamoxifen. You don't give Herceptin. Here you give tamoxifen also, you give Herceptin also. Here you give only Herceptin but not the tamoxifen. Here you give nothing. You give nothing but the prognosis is worse now since you are giving no treatment. So the prognosis is worse, recurrence is very common, metastasis is very common. Herceptin is very costly drug. Unnecessarily never give it, never give it. It's very costly. One vial costs nearly around 1 lakh and in Indian market, and nearly for the entire treatment 17 vials are required. So total cost may be 75,000 to 1 lakh is the one vial. 12-13 lakhs is the cost of the treatment for one lady. So everyone cannot afford that cost. Of course, tamoxifen is a cheap drug. It is an oral drug. It's an oral drug, so tablets come. So patient has to take one tablet every day till 5 years or 10 years, whatever. So that is the treatment. So treatment part we have covered. We are done. Can we solve some questions on breast cancer? We are done with breast cancer also. Kindly respond. Will you? Yes. Very good, Debajan. Very good. So the question is in front of you. Okay. Let's skip this. Best prognosis of the breast cancer. Which one is having best prognosis? Is it luminal B? Is it luminal A? Is it HER2 positive? HER2 enriched or triple negative? The triple negative are the basal one. Okay, can you tell me what is the best prognosis? Which of the following have the best prognosis in the breast cancer? Yes. What is the correct answer? Which of the following is having the best prognosis of the breast cancer? What is the correct answer here? Yes. What is the correct answer? I'm asking. Yes, very good. Oh, you are saying C. The best is the B, no? The best is the B. The luminal is the best. Osama, C is not the answer. You're saying B is the correct answer. So luminal A is the best. If I ask the worst prognosis, answer will become triple negative. So learn the best, learn the worst. Okay. The next question is in front of you. Indian file pattern is seen in which type of breast cancer? Indian file pattern. Indian file pattern is one behind the other. One behind the other. Like this, like forming a rose. It is seen in which type of breast cancer? Is it DCIS? Is it LCIS? Is it IDC? Is it ILC? I guess you know the full form. Ductal carcinoma in situ, lobular carcinoma in situ, infiltrating ductal carcinoma, infiltrating lobular carcinoma. Yes, absolutely right, Shalini. The correct answer here is ILC. In ILC, typically we see Indian file pattern, right? So if I change the question, correct answer is this. If I change the question and I ask you, the Komedo pattern, Komedo or papillary pattern is seen in which type of breast cancer? What is your answer now? I told you 4 type of DCIS. One of them is Komedo. So correct answer in that scenario will become DCIS. So in this way, if you know the various variants, you can answer them very correctly. The next question is in front of you. Unilateral breast finding. Scaly skin lesion around the nipple with bleeding. What is your diagnosis? It's a spotter. It's a spotter. Scaly lesion around the nipple with bleeding, and it's unilateral. Take the clues. Tell me the answer. Of course, you all are right. The correct answer here is the Paget disease. The Paget disease is the correct answer. Let's move on the next system. We have covered 4 systems till now: CVS, blood vessels, CNS, and breast also. Coming on the next system, endocrine. In endocrine, I would like to tell you thyroid tumors and diabetes. 2 important, ultra important topics I will discuss here. So let's discuss thyroid tumors. How many type of thyroid tumors you know? There are 4 types of thyroid tumors: papillary carcinoma, follicular carcinoma, medullary carcinoma, anaplastic carcinoma. So these are the 4 types of thyroid tumor. We have to discuss their introduction, gross and microscopy for each of them. Let's start. So I will show you this table again in the end. I'm not reading it wrong. So these are the 4. Okay, have a look. So papillary, follicular, medullary, anaplastic, we will take them in this sequence only. We will take them in this sequence only. Yes, PDO orange is a sign, not always. PDO orange, tab bhi see, TBO orange, PDO orange. PDO orange occurs when lymphatics is involved. When the tumor cells enters in the lymphatics of the breast, the breast appears granular and reddish in appearance, that is like the skin of an orange fruit. That is known as PDO orange, and it is not always indicating malignancy, but yeah, it can be indicating the hidden malignancy. Okay. There are 4 types of thyroid cancer: papillary, follicular, medullary, anaplastic. We will be looking them in this sequence. The most common is the papillary. See, 80% is papillary. The second most common is follicular, that is the 10%. 80%, 10%. Medullary and anaplastic are only 5%. They are very rare, right? So that is the thing. They all are common in female. They all are more common. See, the ratio of female is to male. It is 3 times common. This one is 2.5 times common. This is 1.5 times common. Only one is equal in male and female. That is medullary. It's a PYQ. Which of the following thyroid cancer is equal in male and female incidence wise? So it's medullary. Rest all are more common in female than male. So please learn that. Learn the gene mutation of all of them, that I will tell you. Okay. So let's start one by one. Start with the papillary. Among them, papillary is most common. It is the 80%. The risk factor is radiation or the thyroglossal cyst. So if there is radiation in the thyroid, due to any reason, if the radiation is there in the thyroid, it can lead to papillary carcinoma, or thyroglossal cyst is also a risk factor. Grossly, you can see it's a cavity. The cavity have the papillary tumor. Grossly also I can see finger-like projections, that is the papilla. Grossly also papillas are seen, that is the finger-like projections, that is papilla. Histopathologically, this is the diagram of papillary carcinoma of thyroid. You can see. So what you can appreciate in any histo slide, let me give you general clues. In any histo slide, this is a histo slide now. So along with pink and purple, the first thing you have to notice is the pattern. Tell me the pattern in which tumor cells are arranged. Is it solid? Is it papillary? Is it cribriform? Is it what pattern? Is it glandular? Right? What is the pattern here? Tell me the pattern first. Number 2, after describing the pattern, describe the cells. Take individual cell and describe it. Describe the nucleus, describe the cytoplasm, and then any unique finding is present, describe that. This is a way we cover the histopathology. So look here, what is the pattern we are having? We can see this is the papillary pattern. You all can see the tumor cells are arranged in papillary pattern like this. The tumor cells are arranged in papillary pattern. Papillary is finger-like projection, right? So let me draw a papilla for you. Imagine this is the papilla. At the center of the papilla, there is a blood vessel. The tumor cells are like this. Just a second. The tumor cells are like this. They surround the papilla like this. The tumor cells. Okay. And in the center, there is a blood vessel with fibrosis. It is known as fibrovascular core. So at the center, there is a fibrovascular core. Here also you can see at the center, if you can appreciate, this is the blood vessel. Multiple blood vessels are present at the center along with the fibrosis. So fibrovascular core is there, and tumor cells, you can see these all are tumor cells. These all are tumor cells. The tumor cells are forming the border. They are forming the periphery and they are arranged around the papilla. Let me describe one tumor cell. Let me zoom one of the tumor cell for you. Let me zoom. Can you see here tumor cells? See the nucleus. See the nucleus, see the nucleus, see the nucleus. Nucleus is empty from inside. I'm using the word empty. Empty matlab khali. Nucleus andar se filled nahi hai. Nucleus is empty from inside. It is not filled nucleus like this. The nucleus is not filled from inside. The nucleus is empty from inside. It's like this, right? So it is looking like orphan Annie. Annie is a girl. Annie is a girl. Annie, she's a cartoon, huh? You may be knowing the Mickey Mouse, so it's like Annie only, right? So Annie, she's orphan. Is orphan Annie, and her eyes are empty like this. So we compare the nucleus of the papillary carcinoma with orphan Annie eye nucleus. What does we use the word? We use the word orphan Annie eye nucleus. Please learn this word. Or else it is ground glass or it is optically clear. So either say one and the same thing. Either you say it's orphan Annie or you say it is ground glass appearance. Ground glass, one and the same thing. Okay. Or you'll say it's optically clear. It's optically clear. Optically clear nucleus. This is equal to this is equal to this. So these all are synonyms. So So the nucleus of the papillary carcinoma is very unique. It's clear, it's optically clear, ground glass like orphan any eye. Appreciate it. You got it? This is the thing. Okay, so this is very unique finding. One more unique finding is there in the cell. Can you see all these tumor cells? So inside the tumor cells you can see the grooves. Let me show you. This is a tumor cell, this is the nucleus, this is the tumor cell, this is the nucleus. So inside the nucleus, appreciate the grooving. The grooves are there. Can you see the grooves? This is the nucleus, it is divided. So the nucleus, this is the tumor cell, this is the nucleus. Inside the nucleus, grooving is present. In most of the cell, grooving is present. Not only this, inclusion bodies are present in the cytoplasm as well as in nucleus. So grooving, inclusion body in the cytoplasm as well as nucleus. You can appreciate multiple inclusion bodies also. Here, can you see this is an intranuclear inclusion body? Appreciate it if you can. This is an intranuclear inclusion body. In the same way, intracytoplasmic, appreciate grooving. At many places you can see the grooving. So these are the important features. See the nucleus, see the inclusion body, see the grooving. So that is the papillary carcinoma. One more last thing is there. Sometimes you can get calcification. Can you see here the calcification? The calcification is known as Samoma body. P is silent here, Samoma body. So can you describe the papillary carcinoma of thyroid? Who will tell me papillary carcinoma thyroid? All important points. So in the introduction, it is the most common among all tumors in the thyroid. The risk factor is the radiation and thyroglossal cyst. Okay, now in the gross, the papillas are there, the papillary stalks are there. In the microscopy, tell me the important features. So tumor cells are arranged in papilla like this. Inside the papilla there is a fibrovascular stalk, right? Say papilla, say fibrovascular stalk. In the tumor cell, the nucleus is clear. It's optically clear, known as orphan any eye nuclei or optically clear ground glass appearance. Okay, there are inclusion bodies present in the cytoplasm also and nucleus also, and there is grooving present in the nucleus. So please enumerate all these points along with calcification known as Samoma body. You get many questions on papillary carcinoma of thyroid. The next one is the follicular carcinoma of thyroid. The follicular carcinoma is the second most carcinoma of the thyroid. Here gross is not important, but microscopically, the tumor cells have various follicles. Can you see this is tumor? Why it is known as follicular? What is the arrangement? Tell me the arrangement. वहाँ पे papilla थे, यहाँ पे papilla नहीं है. Here tumor cells are not arranged in papilla. Here the tumor cells are arranged in small circular follicles. Small circular follicles. Can you see? The tumor cells are arranged in small circular follicles. The tumor cells are arranged in small circular follicles everywhere. So this is the tumor cells ka arrangement. They are arranged in follicles. The nucleus is filled. It's not empty. If you appreciate, zoom it out, you can see the nucleus is filled. It is filled from inside. It's not empty. So nucleus is hyperchromatic in contrast to papillary carcinoma. That is, sometimes cytoplasm is too much. You can see abundant cytoplasm which is pink in color. These are known as Hurdle cells. So Hurdle cells having abundant pink eosinophilic cytoplasm, granular cytoplasm. The next one is the medullary carcinoma, the third one. So you can see here in the thyroid we are having, two types of cells, the follicular and parafollicular. Have you heard about parafollicular cells? See the diagram of a normal thyroid gland diagram. You can see these are the follicles. Follicles, they are lined by follicular cell. The follicles are lined by follicular cell. The follicles are lined by follicular cell. And in the stroma, you can see parafollicular cell. So medullary carcinoma is a carcinoma of parafollicular cell. The remaining three carcinoma are carcinoma of follicular cell. But this one is a carcinoma of parafollicular cell. Parafollicular cells secrete calcitonin in the blood. That's why whenever there is a tumor, medullary carcinoma of thyroid, abundant of parafollicular cells are there. And they all secrete calcitonin in the blood. So in the blood, there is hypercalcemia. Hypercalcitonin hormone. That will lead to hypocalcemia. You know what does calcitonin do? Calcitonin decreases calcium in the blood. That's why there is hypocalcemia. You got my point? And it is having familial occurrence. It is associated with man. It is associated with 2A, 2B, both man. See man 2A, man 2B. In both of them, medullary carcinoma of thyroid is there. Right? So it is associated, it is familial also. Histologically, this is the diagram. See the tumor cells. The first thing, they all are uniform. एक जैसे हैं, एकदम एक जैसे. What is the arrangement? पहले arrangement बोलो. The tumor cells are arranged in nest. Small nest है यहाँ पे. The tumor cells are arranged in nest. Papillary में वो papillary arrangement था. Follicular में follicular arrangement था. यहाँ पे nesting है. The tumor cells are uniform. Background में pink color notice करो. Please everyone notice the pink color in the background. See here the pink color. What is the pink color? What is the pink color? What is the background pink color? This background pink color is amyloid. So very unique tumor having amyloid in the background. The stroma contain amyloid. And sometimes calcification is also there. You can notice here. But don't call it psammoma body. It's simple calcification. So this is the diagram. This is the diagram. Yes, it causes osteoporosis. Yes. So this is the diagram. We can see the amyloid on Congo red also, right? Apple green birefringence can be seen. Okay. The last one is the anaplastic. It is the most malignant, most aggressive tumor among the four. It is very aggressive. It is rapidly growing and having the metastasis. Gross and microscopy is not important because it is not fixed. So we are done with the 4 types of thyroid cancer: papillary, follicular, medullary, anaplastic. Can you tell me the important points? Who will help me with the important points with each of them? Please, once, can we revise it quickly? Can we revise it quickly? I will not give you the questions now because it is taking time and I have to cover all the systems. So we will not solve the question. You can solve the questions by yourself or I can provide you the PDF. You can provide the questions by yourself. Okay. So can you give me the, we can revise it here. So papillary carcinoma, the tumor cells are arranged in papilla. Here the tube with a fibrovascular stalk at the center. Here the tumor cells are arranged in follicular pattern. Here the tumor cells are arranged in small nest. Right, here it's not important. This one is the most common. This one is most aggressive, most malignant, most lethal. Okay, this one is second most common. Learn the important points, right? Medullary is only one which is derived from parafollicular cell. These all derived from follicular cell. But this derived from parafollicular cell. That's why secrete calcitonin in the blood. Calcitonin decreases calcium. Patient have hypocalcemia. You got it? You got it? So this is the thing. Now, tell me the important points about the cells. Here the tumor cells have optically clear nucleus, orphan ani nucleus. In the nucleus there is grooving. There is grooving is there, and inclusion bodies are present in the nucleus and the cytoplasm along with psammoma bodies. Here the tumor cells are uniform and they have hyperchromatic nucleus. Here the tumor cells are uniform and they have amyloid stroma in the background, very unique, along with calcification. So please learn the important histological finding. Try to see the diagram of all of them. Try to see the important findings. Got it? All of them are more common in female except medullary, in which male is equal to female. It's a PYQ. Say yes. Got it? Can we go ahead? Can we go ahead? So we are done with thyroid tumors. I'm not giving you questions to solve because it is taking time. I'm waiting for your response. Is it done? Can we go ahead? Is it done? Can we go ahead? Say yes. Okay. So can we go ahead? So the next topic I am taking is the MAN. What is MAN? Multiple endocrine neoplasia. Multiple endocrine neoplasia. It is a syndrome in which multiple endocrine cancers are present in one patient. There are 3 types of MAN. MAN 1, MAN 2A and MAN 2B. Sometimes MAN 2B is known as MAN 3. MAN 3. So MAN 1, 2, 3. In some books it is written like that, or else MAN 1, 2A and 2B. When MAN 1 is known as Werner syndrome. MAN 2A is known as Sippel syndrome. MAN 2B, no specific name is given. So you can see the 3 MAN, the 3 type of syndrome in which multiple cancers are present in one patient. Let's start with MAN 1. Let's start with MAN 1. In MAN 1, it's triple P. 3P, triple P cancer is present. Start from the beginning, from the head. In the head, there is pituitary adenoma. Inside the pituitary, in the brain, there is a cancer in that. Come in the neck. In the neck, there is parathyroid gland, not thyroid. Inside the thyroid, there is parathyroid gland. The parathyroid hyperplasia is there. And come in the abdomen. In the abdomen, there is pancreas. So there is pancreatic tumor. Say triple P. Everyone say triple P. Triple P is MAN 1. It is known as Werner syndrome. Werner syndrome. Say yes. Okay. Coming on MAN 2A. In MAN 2A, again, it's parathyroid. Number 1, thyroid, parathyroid both are involved. Parathyroid में फिर से hyperplasia है, लेकिन thyroid में it's medullary carcinoma, right? And there is adrenal gland involvement having pheochromocytoma. Pheo. So you can see 2P are there and 1M is there. 2P and 1M is there. Okay. And in MAN 2B, in 2B there is mucosal neuromas, marfanoid body, medullary carcinoma and pheochromocytoma. So 1P and triple M is there. You can learn like that. So what we have learned? We have learned MAN 1 have triple P, MAN 2 have 1M and 2P, You can say P, pheochromocytoma, and man 3 have MMM along with pheochromocytoma. You can learn like that. I have explained you man 1, 2B. You get many MCQs on that. What is man 1, 2A, 2B? You want to revise or you got it? What is man 1? Start from the pituitary adenoma, come on the parathyroid hyperplasia, come in the pancreas, pancreatic tumor, pituitary adenoma, parathyroid hyperplasia, pancreatic tumor, triple P. Can we revise man 2A? Start directly from the parathyroid hyperplasia, and in the thyroid it's medullary carcinoma of the thyroid, and in the abdomen it's adrenal gland involvement having pheochromocytoma. Two things are common in man 2B. Out of them, two things are common. So pheo occurs here also and medullary carcinoma occurs here also, but two are additional. There is Marfanoid syndrome and mucosal tumors. So this is the thing. Yes, everyone is right. Can we go ahead? The next topic is the diabetes, so endocrine system will also be done. After that, we will move on the next system, the GIT and the liver, right? And after that, GIT, liver, respi. These are the three major systems are left after this, and kidney. Yes. So these four major system and MGT, FGT in the end. Two small systems. So let me try my best to give you more and more. Okay. So let's start with diabetes. The next topic we are covering here is the diabetes, the endocrine system, the diabetes. Can we go ahead with the diabetes? Say yes. So let's start with diabetes. The next is the diabetes. To understand diabetes, you should understand pancreas. We know humans have pancreas. Can you see here? The humans have pancreas. Pancreas is an organ. It's a dual organ. The pancreas is an organ. It's a dual organ. It is having a exocrine part and endocrine part. The exocrine part secrete enzyme and the endocrine part secrete hormone. Currently, I am interested in the endocrine part of the pancreas. The endocrine part of pancreas is in the form of a cluster of cells, which is known as islet of Langerhans. It is known as islet of Langerhans, the cluster of the cells, right? It is having four types of cells: the alpha cell, beta cell, delta cell, and PP cell. Alpha cell secrete glucagon, beta cell secrete insulin, delta cell secrete somatostatin, and PP cell secrete pancreatic polypeptide. The four type of hormones, they all are hormones. Glucagon and insulin are important for glucose metabolism. They are secreted from the pancreas and the blood. Okay, so let's start with diabetes. What is diabetes? I guess everyone knows diabetes is hyperglycemia. More glucose in the blood. Hyperglycemia is known as diabetes. So what is the normal level of glucose in the blood? The normal level of glucose in the blood is fasting level is 80 to 100 milligram. 80 to 100 milligram per deciliter. When it is more than that, it is hyperglycemia. When the blood glucose is high, it's known as diabetes mellitus. You got it? Now see this diagram. To understand what is diabetes, everyone have a look. Very important diagram. Please understand what is diabetes here. In this diagram, you can understand. Can you see the blood vessel? Yes, you all can see this is a blood vessel. You all can see this is a cell. Okay. So insulin is a hormone which transmit the glucose from blood to cell. Look at the arrow. From blood to cell, and glucagon and store in the cell in the form of the glycogen. Glucagon is a hormone which degrade the glycogen and take the glucose from cell to blood. You can see the two hormones. So talk about the blood level. Insulin decreases the glucose level of the blood and glucagon increases the glucose level of the blood. Am I right? So this is normal. This happens in all of us. In my body, in your body, we all have insulin as well as glucagon. So whenever our blood glucose level is high, after eating, insulin takes care of it. It decreases the glucose level. And during fasting, if I'm not eating anything, if I'm fasting, so my blood glucose level will fall. So at that time, glucagon will take care and it increases the blood glucose level. So because of the two hormones, the blood glucose level is maintained between 80 to 100 all the time. All the time, this is the basal level. Because of insulin and glucagon balance. Right, so the balance is very necessary. You got it. Now insulin is absent. Imagine if insulin is absent. Either it is absent or it is present and non-functional. Either the insulin is absent or the insulin is present but it is non-functional. You got it? Give me a minute. So what will happen in this case? In such scenario, what will happen? Can you tell me what will happen in such scenario? So in such scenario, the blood glucose level will rise. Right? The blood glucose, the hormone which is carrying the glucose from blood to the cell, it is non-functional. So blood glucose level will rise and cell glucose level will fall. So this is known as diabetes. In diabetes, there are two problems. The blood, there is more glucose. In the cell, there is less glucose. So cells are starving. Can I say? Cells are starving. Cells are not getting the glucose, right? Although having abundant of glucose at the doorstep, cells cannot utilize it. So there is a problem in utilization. Have you heard in Hindi, Diya tale andhera, you know, samundar tale pyasa. So the same proverb fits here. So the cell is starving of glucose, having abundant of glucose in the blood, the cell cannot take it. So that is the problem, the mystery in the diabetes. In the blood, there is abundant of glucose, but cell cannot take it, cell cannot utilize it. The cells are starving, they are dying of glucose, and in the blood, there is abundant of glucose. This is the problem in diabetes. And why the insulin is not functional? I mean, there are two problems. Either the insulin is absent or it is non-functional. So that is the two type of diabetes, type 1 and 2. In type 1, the insulin is absent. Because insulin is secreted by beta cell of the pancreas, the beta cells are destroyed. But destroyed by autoimmune phenomenon, in type 1, the insulin is absent. In type 2 diabetes, insulin is present, but it is non-functional. It is present but non-functional. You got it? Have you got it? Can you please tell me that whether you got it or not, didn't got it? So that is the normal physiology I told you. Now come on the classification. How many type of diabetes are there? There are two main type of diabetes, type 1 and type 2. Type 1 diabetes is 10%, type 2 diabetes is more common, it's 90%. Type 1 diabetes occurs in juvenile age. It is known as juvenile onset diabetes, GOD. Type 2 diabetes is maturity onset diabetes. Type 1, insulin is given as a treatment. That's why known as insulin dependent diabetes mellitus. And in type 2, insulin is given as a last resort. That's why known as non-insulin dependent diabetes mellitus. That is the classification. Now to understand the pathogenesis of the two type of diabetes along with the clinical feature, you have to understand the insulin regulation. You have to understand the insulin regulation. How does the insulin is synthesized, how it is released, how it is acting, what is the action of the insulin. So you have to understand that. Okay, now please see this diagram. Normally, I am telling you the insulin pathogenesis normally, then I will tell you the diabetes pathogenesis. Everyone see, it is a normal individual I have shown in this diagram. Imagine this normal individual is having the meal. Either the breakfast, lunch or dinner. The person is eating. So whatever the person is eating, it is going in the mouth, it is going in the stomach, it is going in the intestine. So whatever we eat contain glucose. Some or little amount or more amount, right? So the glucose will be absorbed, the glucose is going in the blood. In the blood, the red dots, these red dots are glucose, right? Whenever we eat, our glucose level rises in the blood. Normal glucose level is 80 to 100, but whenever we eat, it is more than 80. It is more than 80, of course, whenever we eat. After that, immediately after 5 to 10 minutes after that. So more than 80 glucose, whenever it is there, it is a trigger. The glucose will go to the pancreas. You can see this is pancreas. Inside the pancreas, 4 types of cells are present: alpha, beta, delta and pp. We are interested in beta. You can see this is the beta cell. This is a beta cell. So the glucose will go and knock the beta cell that I have arrived. So at that time, on receiving the signal, the beta cell will secrete insulin in the blood. So glucose is going, knocking and taking insulin out. Now in the blood, both are present. Glucose is also present and insulin is also present. In the blood, both are present. Initially, when we eat, only glucose is present. Glucose is knocking the pancreas, the beta cell of the pancreas, and taking insulin out. So whenever glucose go to the beta cell of the pancreas, it's a trigger. The beta cell secrete insulin in the blood. Now in the blood, both are present. Glucose and insulin. Glucose and insulin. So what it will do? Now they will go to the target organ. There are 3 target organs. You can see liver, skeletal muscle and adipose tissue. These are the 3 target organs. Now glucose want to get stored in these three target organs. In the liver, the glucose can be stored as glycogen. In the skeletal muscle also, liver can be stored as glycogen. But in adipose tissue, the glucose is stored in the form of the fats. Right? But glucose cannot. What is the problem then? You will say, ma'am, what is the problem? Why don't glucose is going inside these cells and getting stored? The problem is that glucose cannot enter directly in these cells. For the entry, a door is required. Darwaza chahiye. Door. Who is the door? The name of the door is GLUT4. What is the name of the door? The name of the door is GLUT4. You got my point? GLUT4. But GLUT4 is absent. So insulin is, the glucose is taking the insulin. Pehle insulin jayega. First insulin will go in these cells. It will transplant GLUT4 and it will call the glucose. You got my point? Hindi में कहूँ तो insulin इन तीनों पे जो दरवाजा है, लीवर, स्केलेटल मसल और एडिपोज टिश्यू पे जो दरवाजा है उस पर ताला लगा है, उस पर ताला लगा है तो ग्लूकोज एंटर नहीं कर सकता, नहीं कर सकता तो ताले की चाबी किसके पास है? ताले की चाबी इंसुलिन के पास है। तो ग्लूकोज आएगा पहले ब्लड में, जब भी हम खाना खाएंगे तो ग्लूकोज ब्लड में आएगा, ब्लड में आके वो पैंक्रियाज के पास जाएगा, पैंक्रियाज में से इंसुलिन को बाहर लाएगा, इंसुलिन को भेजेगा कि जा मेरे दरवाजे के ताले खोल उसका, फिर वो चाबी लेके उसका दरवाजे का ताला खोलेगा, दरवाजे को खोलेगा, तब ग्लूकोज इन तीनों में एंट्री करके स्टोर हो जाएगा। Have you got it? How many of you don't understand Hindi? Okay, tell me. So I will translate in the English also. You got it? You got it? So this is the thing. So glucose coming in the blood. After coming in the blood, it is going to the pancreas. In the pancreas, it is knocking and taking the insulin out in the blood. In the blood, both are present now. So first, insulin goes in the target organ and open the door for the glucose. The door for the glucose is GLUT4. GLUT4 come on the membrane only when insulin is coming. So once the GLUT4 is transplanted, glucose can enter in these cells and getting stored. Appreciate it. So this happens normally in all of us whenever we eat. We don't think about it. If you are eating anything, this automatically happens inside you. You got my point? Everyone got it? You can see. You can see this is the insulin. It goes in 3 target organs: the liver, the skeletal muscle, and adipose tissue. In all 3 of them, it is implanting the GLUT4. Right, now let's come on diabetes. The 2 type of the diabetes I told you, type 1 and type 2. In type 1, the body do not synthesize insulin. Insulin is 0. Insulin is absent. So you can see inside the pancreas, the beta cell of the pancreas are destroyed by autoimmune T lymphocytes. The T lymphocytes normally kill the foreign body, but here because of autoimmunity, the self-reactive T lymphocytes are there. Self-reactive T lymphocytes are there. They are killing body own cell, the beta cell. So beta cell is absent. So insulin is absent. No insulin is there. Imagine there is no insulin. So glucose cannot enter in these 3 cells. Glucose will remain in the blood only. Chabi nahi hai. Tala kaun kholega? Who will open the lock? There is no key. The key is the insulin. Insulin is absent. Key is absent. No one is opening the door. So glucose will remain in the blood only. That is leading to diabetes, hyperglycemia type 1. In type 2, so in type 1, the problem is in pancreas. The problematic organ is the pancreas. Because inside the pancreas, the beta cells are destroyed. They are absent. Say yes. What happens in type 2 diabetes? What happens in type 2 diabetes? In type 2 diabetes, there is no problem in the pancreas. The problem is in the 3 target organ. Here the insulin is normal in the blood. Rather more than normal. You will say, then what is the problem, ma'am? Insulin is normal, you are saying. The beta cell is normal. It is secreting the insulin in the blood. Insulin is normal. Insulin is going to these 3 target organ, but insulin receptor is defective. The door cannot be implanted. Insulin is non-functional. So insulin is present, but its quality is not good. It is non-functional. It cannot implant the door for the glucose. This is known as insulin resistance. So insulin is present, but it is non-functional. It is non-functional. It cannot go to the target organ and implant the door for glucose. So failure of the target organ to respond to insulin. The liver, skeletal muscle and adipose tissue. So in type 2 diabetes, the problem is in these 3 organs. So if I say type 1 diabetes, the problematic organ is the pancreas. In type 2 diabetes, the problematic organ are the target organs. In type 1 diabetes, insulin is 0. In type 2 diabetes, insulin is normal, but it is non-functional. I tried hard. You got my point? You got my point? So those who don't understand Hindi, it's okay. I translated in English also. No, I will concise myself to English only. Don't worry. Okay. So you got this concept. Those who don't understand Hindi, you also got this concept, or shall I repeat it? You got the 2 type of the diabetes. So the 2 type of the diabetes, in type 1, the problem is in the pancreas. And in type 2, the problem is in the target organs, not in pancreas. In type 1 diabetes, the beta cells are absent which secrete insulin. That's why insulin is 0. In type 2 diabetes, the problem is in the target organ. Beta cells are normal. So insulin is normal. But insulin which is present, it is non-functional. The receptor for insulin is defective. Right? So you have to check the blood level for insulin. Right? Type 1 diabetes occurs from childhood. You know, whenever the child is born, so beta cell are normal, 100% beta cell are there. Then the T cell become auto-reactive and they start killing beta cell. So at adolescent age, 15 to 20 years, all the beta cells are killed, 100% beta cells are killed, and at this age, the child manifests as diabetes. It is present since childhood, but manifestation occurs in adolescence. But type 2 diabetes occurs in old age, especially after 50s, 40s, 50s. That is, insulin resistance takes place. You got my point? So that is the meaning of the type 1, type 2 diabetes. You got my point? What are the clinical features? Triple P. All of us know there is a typical triad in diabetes. patient drinks so much, patient eats so much, patient urinates so much. Polyphagia means eating, polydipsia means thirsty, more and more drinking, and polyuria means urinating. See, the patient is shown to you, the patient is drinking too much, patient is eating too much, and patient is urinating too much, right? So you can see the triple P, now you will not forget. Polyuria, polydipsia, polyphagia, right? Patient eat too much, still patient lean and thin. The two paradox phenomenon occurs together. Imagine a patient is coming to you, doctor, I eat too much. Every time I feel hungry, I eat. Still I'm losing the weight. Oh, what a good thing. Huh? It occurs in diabetes. Hopefully it occurs in all of us, no? Right? We eat too much, but don't weight gain. Okay? Don't gain weight, I mean. So fortunately it occurs in all of us, but this occurs in diabetes. So in diabetes, two paradox things occurring together. The weight loss even on intense eating. So more eating but still losing weight. So that paradox occurs only in diabetes. You got it? Can we go ahead? Say yes. So what is the reason? You should ask me, ma'am, why? You explain why all these three things are happening. Why? Still weight loss is there. So why the three things happen? Let me explain you. Shall I have a diagram? I don't have a diagram for that. Okay. I will draw it for you. Imagine, let me draw the blood vessel. This is the blood vessel. Now it contains abundant of glucose. Whether it is type 1 diabetes or type 2 diabetes, glucose is abundant. In type 1 diabetes, the reason for abundant glucose is absence of insulin. In type 2 diabetes, the reasons for abundant of glucose in the blood is insulin resistance. Right? Ultimately, there is abundant of glucose in both the diabetes, whether type 1 or type 2. So you should ask me, ma'am, where does it go? Ye glucose jayega kahan? It is present in the blood. It cannot enter in the target organ. These are the three target organ: the liver, the skeletal muscle, and adipose tissue. The glucose cannot enter in them. No entry. Lock is there. And the key is the insulin. Insulin is non-functional. Key is defective. Okay. So insulin cannot enter inside them. What does the insulin will do? Glucose cannot enter inside them. What does the glucose will do? Glucose will go in the kidney and excreted in the urine. Okay. So this glucose will go in the kidney and excreted in the urine. Normal urine doesn't contain glucose. A healthy individual urine doesn't contain glucose. But urine contains glucose here in this patient. It is known as glycosuria. Glycosuria means glucose in the urine. Glucose in the urine. Glucose is an osmotic molecule. Please understand my words. Osmotic molecule drag water with it. So glucose will not go alone in urine. Glucose will take water also in the urine. So in the blood dehydration occur. You know, water is gone in the urine, right? Dehydration. This is the reason for polyuria. More and more patient is urinating, more and more water is coming because more and more glucose. The more glucose level, the more dragging is there and more urination is there and more dehydration is there. Because of dehydration, the thirst center in the brain is getting stimulated. Whenever we are dehydrated, we have thirst center in our brain that gets stimulated and we have a feeling like we have a desire we should drink water. We feel thirsty, right? And we drink some fluid or water, whatever. So when the thirst center is stimulated because of the dehydration, now patient is dehydrated, that's why the thirst center is in the brain is stimulated, and that's why there is polydipsia. Polydipsia means more and more drinking of the water. What I mean to say, please understand the two things. I am saying polyuria leads to polydipsia. Polydipsia is not leading to polyuria. Please understand, Hannah. The patient is urinating more. That's why patient is drinking more. It is not the thing, since the patient is drinking more, that's why it is urinating more. No, urinating more, that's why getting dehydrated and that's why drinking more. I hope you can understand what is leading what. Okay. And the third thing, I told you, since glucose cannot enter in all these cells, there is no storage of glucose. No, there is no storage of glucose, so there is a negative balance. There is a negative energy balance in the body. And that's why the patient is feeling hungry. So these organs feel like body mein glucose nahi hai. There is no glucose in the body. These organs feel like that. So hunger center is stimulated, so that patient eat more. That is polyphagia. And still there is weight loss. Whatever patient is eating, it is not going. You know, diya tale andhera, samundar tale pyasa. You got my point? So the cells are still hungry. The patient go on eating, but it is not reaching on the cells. It is excreting in the urine. It is not reaching in the blood. The glucose is not taken by the cell. That is the problem. Say yes if you got it. Okay. Okay, so Osama is asking if the patient is presenting at adolescent age, so how does the patient is surviving till that time? That is your question, Osama. Osama, at birth 100% beta cells are present. Now the T cell becomes self-reactive. T cells become self-reactive because of loss of tolerance. These T cells start killing the B cells, beta cells of the pancreas. When the beta cells fall beyond a critical level, at that point the patient presents. So it is not a one-day job that T cells are killing all the beta cells. So gradually the count falls. Maybe by the age of 5 years, there is a graph for that, age of 10 years, right? So beta cell go on reducing. So when the beta cell fall beyond 30%, 40%, at that time clinical manifestation is there. So this is the answer. Got it? So it is not key at birth only, it is zero beta cell. Beta cell are 100% at the birth. At birth it's normal. If you check the glucose level at birth, it's normal. But gradually at 5 years it is little bit more, or maybe it is within normal range only. So when the beta cell are fall too much, then the insulin level drops too much, and after some point it's zero insulin. All the beta cells are destroyed after 20 or 25 years, you know. So it's zero. You got my point? This is the answer. Can we go ahead? So we have done the clinical features also. We have understood the clinical features also. We have seen the two type of diabetes, type 1, type 2. Type 1, the main thing is the autoimmune destruction of the beta cell by the T lymphocytes. In type 2, it's the insulin resistance. Okay, both of them have a what do you say? Both of them have genetic predispositions. It is more in type 2 as compared to type 1. The genetic, like in the concordance rate in the twins, you can see. Okay, complication, you can read it, or it will be covered in the this thing also, medicine also. So here I am coming on the diagnosis of the diabetes. How to diagnose the diabetes? What are the ways? Imagine how you can diagnose the diabetes. You are suspecting diabetes in a patient. You can do urine test, blood test and others. First we will discuss the urine test. Collect the urine of the patient. In the urine, look for two things: the glucose, the ketone. So diabetic person have glucose and ketone in their urine. So look for glucose. For glucose, glucosuria, ketonuria. For glucose, there is a Benedict test. I guess everyone knows what is Benedict test and principle for that. So take 5 ml of Benedict reagent in a test tube, add few drops of urine, the patient's urine in that, and heat that. Heat on a Bunsen flame. Heat on a Bunsen flame, right? Okay, heat on a Bunsen flame and look for the color. So you can see the color change is there. If the glucose is there, the different colors are there. If it is negative, no glucose present in the urine, the color will not change, it will still blue. And if the color is changing to green, yellow, orange or red, it is known as GYOR, green, yellow, orange, red. It means the glucose is present in the urine and it is indicating the severity. Green means traces, yellow means moderate, orange means moderate, and red means severe glycosuria, right? So that is a semi-quantitative test, Benedict test. I guess everyone have performed in their laboratory. The test to test the glucose in the urine. Okay, for ketone, we have Rothera test. I'm not going in the detail, you know the principle, the purple ring is formed, that is Rothera test, right? In the blood test, these were the tests in the urine. Coming on the blood test. For blood test, I will give you, so collect the blood sample of the patient and look for the sugar. Look for the glucose level. Let me tell you the cutoff. I'm going to teach you 3 cutoff here. Look for the fasting blood glucose level known as FBS, fasting blood sugar level. Look for the postprandial blood sugar level known as PPBS. Postprandial means after eating. Fasting का मतलब होता है at least 8 hour fasting. 8 hours से कुछ नहीं खाया. दिन और रात से मतलब नहीं है. There is no sense of night or morning, right? Usually when we sleep in the night after dinner, we don't eat during the night, and in the morning the first sample is considered as fasting, because since the last 8 years patient have not eaten anything. During the daytime, if the patient is not eating anything for 8 hours, the sample collected is considered as fasting. That is the point. Okay, fasting is 8 hour fasting, standard. Postprandial is standard eating after eating 2 hours. 2 hours after that we look for the blood sugar levels. And third is random. Random is not associated with food. Anytime you can check. That is random. So let me give you the cutoff. When you consider a patient as diabetes. So the cutoffs are given by American Diabetes Association, ADA. ADA has given these cutoff values. We are following that in India. Okay. So what are the cutoff? The random is 200. 200, everything is milligram per deciliter. The unit is milligram per deciliter. So random is 200. If the blood glucose level is 200 any time along with the symptoms, consider it as positive for diabetes. Now fasting below 100 is normal. 100 to 125 is pre-diabetic, and more than 126 is diabetic. Okay, and 2 hours after food, actually we don't give food, we give 75 milligram of oral glucose load, standard. Ask the patient to drink 75 milligram of glucose. Now don't take anything, and just after 2 hours take the sample. So less than 140 is normal, 140 to 200 is pre-diabetic, and more than 200 is diabetic. So please, can you tell me the three values? Tell me what is random, what is fasting, and what is postprandial. Please tell me ADA, American Diabetic Association guidelines in the blood. So random is more than 200 milligram per deciliter at any point. Fasting less than 100, 100 to 125, more than 126. So there are three things. 100 is normal, 100 to 125 is pre-diabetic, and more than 136 is diabetic. Postprandial is less than 140, 140 to 200, and more than 200. So 140 is normal, 140 to 200 is pre-diabetic, and more than 200 is diabetic. Everyone give me a thumbs up. Please learn these guidelines. These are ADA, American Diabetic Association guidelines. You have to learn that, right? The three types of the blood glucose level. Okay, so this is the blood levels. The same thing is written in front of you. There is one more thing which is known as glycosylated hemoglobin. Have you heard about it? What is glycosylated hemoglobin? It is known as HbA1c. HbA1c, glycosylated hemoglobin. So what happens now? In the blood vessel, we all have RBCs. Of course, we have RBCs in the blood. The RBC contain hemoglobin. We know RBC contain hemoglobin. Okay. Now, when the blood glucose is excessive, the glucose is abundant in the blood, glucose. That glucose form bonds with the hemoglobin. That glucose, when it is abundant, it is forming the bond with the glucose, right? So this hemoglobin is known as glycosylated hemoglobin. This is not normal hemoglobin. So a percentage of total RBC is having glycosylated hemoglobin. It is known as HbA1c. It is acylated hemoglobin. That is glycosylated, acylated hemoglobin, hemoglobin AC. It's not normal hemoglobin. We can measure that hemoglobin. We know the lifespan of RBC is 120 days. 120 days is 3 to 4 months. Okay, 120 days is 3 to 4 months. So if you measure this value, it is giving you an average of last 3 to 4 months glucose. So if you want to see the average, you just measure the values. You can see this is hemoglobin, this is glucose. Glucose and hemoglobin glycosylatically form bond with each other. So this is hemoglobin, this is glucose, and this is glycosylated hemoglobin, HbA1c. You got my point? So for long-term assessment, for 90 to 120 days average, you measure this value. In normal individual, it is less than 6.5. In diabetes, it is more than 6.5. Right? So that is the thing. We are done. We are done. Give me a thumbs up. Everyone give me a thumbs up. We are done till now. The next chapter we will start is GIT and followed by hepatobiliary. These two chapters we will cover. After that, respi and kidney. So we have to cover, I guess, 4 more major systems along with 2 genital, the male and female genital. So 6 more to go. We have covered already, I guess, 5 or 6, but 5 or 6 still to go. We will take a small break. After that, we will continue. Okay. So let's say currently it's 1 o'clock. Let's start at 1:15. A 15-minute break. 15-minute break. Will it work? Okay. So I will be back at 1:15. Okay. And continue with GIT and hepatobiliary system. We'll try to cover the GIT and hepatobiliary in 1 hour. After that, I will move on kidney, the most important system. Kidney, that will again take 1 hour. Okay. So let's see after that if respi and genital is remaining, we can plan 1 more session. Instead of, you know, jumping ahead and filling all the topics together and clustering and not understanding them, better to go like at a moderate level. And if the time is shorted, I'm having time limit till 3. Okay. If I couldn't finish till that, I will ask the team to give me 1 more session. Don't worry, I will cover all, but 1 more session I will plan soon. You can also ask the team. So they will give you 1 more session and we will cover the remaining systems in that. So let's see till 3 o'clock what we can cover. I will try my best to give you the more and more. Okay. So, okay, let's take a break. 1:15 we will meet again. Hello everyone. Am I back? Let me check. Give me a minute. Hello everyone. Can you say something on the chat box? If I'm clearly visible, audible, I will start the session. I guess there is little bit lag is there. I'm waiting for confirmation still. I guess it's visible now. Can we go ahead? Can you write down in the chat box? Give me a minute. Can you... Yes, okay, got it. So can we continue? So till now what all systems we have covered? So we have covered the blood vessels, CVS, CNS, breast, endocrine till now, I guess. Right, we have already covered these 5. The next in the row is GIT followed by hepatobiliary. So let's cover these 2. Then after that there is renal and respi. Right, so this is the sequence I am going to follow. So let's start with GIT. Let's continue with GIT. Can I start GIT? Okay. Okay, so let's start GIT. In GIT, one of the most important topic is the Barrett esophagus. I guess everyone can understand. Let me tell you what is Barrett esophagus. Can you see the diagram? You see this is esophagus, and just in the continuity of the esophagus, you all can see this is stomach. So what is the lining of the esophagus? Esophagus is lined by squamous epithelia. And what is the lining of the stomach? The stomach is lined by the columnar epithelia. You can see I have used 2 different colors. The squamous epithelia is the red color you can see, and the columnar epithelia is the blue color you can see. You can see the blue color epithelia. So red and blue, you can see squamous and columnar, the 2 types of epithelia is there in continuity in the 2 organs. Why God has provided 2 different epithelia in the organs which are continuous to each other? Why it is not all squamous? Why it is not all columnar? Why? Have you ever thought it? Now the stomach contains the acid, the hydrochloric acid, HCl is present in the stomach. So that acid, the stress of that acid can be beared by the columnar epithelia but not by squamous epithelia. So that's why the stomach have the columnar epithelia. Now what is happening in Barrett esophagus now? In some people there is GERD. What is known as GERD? GERD is gastroesophageal reflux disease, GERD, in which the acid present in the stomach is reflux in the lower esophagus. So the lower esophagus, the acid is hitting the lower esophagus. But in esophagus we have squamous epithelia. So this acid, this GERD is acting as a stress for the squamous epithelia. So the squamous epithelia converted to columnar epithelia in the lower esophagus. So can you see this segment of the esophagus? In this segment of the esophagus, normally esophagus have squamous. So normally there was a squamous, but it converted to columnar. It converted to columnar. It is known as metaplasia. So it is a type of columnar metaplasia in which the squamous get converted to columnar. The stress is the GERD. Due to the GERD there is reflux, and due to the reflux the acid is putting the stress on the lower esophagus. So this segment of lower esophagus in which the epithelia has changed, it is known as Barrett esophagus. It is known as Barrett esophagus. Now you must ask me a question, ma'am, how does it matter? Now inside my esophagus, in my lower esophagus, what is my epithelia? Does it matter to me? Even the laymen don't know the 2 type of the epithelia. If you ask a non-doctor, any person, what are the epithelia, they don't know. Now what type of epithelia present in my esophagus, how does it matter? The point is that the lower esophagus, in which the Barrett esophagus, the segment in which the epithelia has changed from squamous to columnar, it is a pre-malignant lesion. Now it can convert in future. Currently it's metaplasia. The metaplasia convert into dysplasia. The dysplasia convert into anaplasia, and it leads to malignancy. It leads to adenocarcinoma of the stomach. So whenever there is a Barrett esophagus in any patient due to GERD, the first thing, fix the GERD. Give the the drugs to decrease the acidity and to decrease the GERD, so all the prazoles, omeprazole and all the prazoles you have studied in pharmacology, that can be given. So fix the GERD so that it do not increase, and whatever already metaplastic segment is there, do regular surveillance biopsy. Every 6 months you should do the biopsy. Just a second. Every 6 months you should do the biopsy to see whether it is converted into dysplasia or not. I'm sorry. So if it is converted into dysplasia, prophylactically you should remove it before it converts to malignancy. So that is Barrett esophagus. It's a pre-malignant lesion, and in pre-malignant it do not convert to squamous, it convert to adenocarcinoma. So Barrett esophagus, due to the reflux, the squamous epithelia in the lower esophagus, it is replaced by the columnar epithelia. So that segment is known as Barrett esophagus. You can appreciate this is squamous. It is converted to columnar epithelia. You can appreciate due to the GERD, due to the reflux. The reflux is acting as a stress. So you can see the lower portion of the esophagus is like stomach only, because stomach is columnar. So it is the continuity of the stomach. You got my point? Now you should know the squamous epithelia is white in color. It is pearly white in color, and the columnar epithelia is red in color. So when you do the endoscopy from the nose or mouth, if you are going inside the esophagus, normally you look like this. The lower segment of the esophagus, can you see? It is white in color, and you can see this is the opening, this is the junction, right? But in Barrett esophagus, this portion is looking like this. Can you see it is red in color? So in endoscopy, you can see the lower segment is like the stomach, and as I told you, it is a pre-malignant condition. In future, the 20% of the cases of the Barrett esophagus convert into invasive adenocarcinoma of the esophagus, not squamous one. So that's why surveillance biopsy every 6 months is required. Okay, so it's a pre-malignant condition. So we are done with that. Grossly, you can see this is GE junction. Appreciate the stomach red color, appreciate the esophagus white color. Here you see this is the GE junction. I can see esophagus is like stomach only. I cannot find the difference. Both are red in color. So the esophagus, the lower esophagus, the Barrett esophagus is red and velvety in color like the stomach. So that's all about it. Coming on the next topic, gastritis. You know what is gastritis? The next important topic in GIT to be covered is gastritis. In pathology, itis is the inflammation of that organ. You got it? So gastritis is the inflammation of the gastric mucosa. So in the stomach lining is by columnar epithelia. There are various types of cells present in the lining. So there is a peptic cell, so various types of cell, enterochromaffin cells, chief cells, various types of cells are present in the lining. It is columnar epithelia. So whenever there is inflammation of the gastric mucosa, it is known as gastritis. It is of two types, acute and chronic. Chronic is important. Chronic is of two types, type A and type B. So let me explain you chronic gastritis, which is of two types, type A, type B, and type AB mixed. Okay, what is type A? What is type B? Very important topic. A for autoimmune. A for autoimmune. Let me explain you. And what is B? B for bacteria. B for bacteria. So let me draw two stomach for you. This is a stomach. Let me draw one more stomach. This is a stomach. So here I told you various types of cells are present. Now, one of the cell is parietal cell. One of the cell is parietal cell. Parietal cell, chief cells, enterochromaffin cell. So parietal cells are there. So basically this is an autoimmune disease in which the body is forming auto-antibodies against the parietal cell. Body do not form antibodies against the own cell. Body form antibodies against the foreign cell. But it's an autoimmune disease in which the body is forming auto-antibodies against the parietal cell. So all the parietal cells are destroyed. What will happen? You will say, ma'am, what will happen? Parietal cells secrete two things. Parietal cells secrete HCl and parietal cells secrete intrinsic factor. You may be knowing this in the physiology. Now, if the parietal cells are destroyed by the autoantibodies, there is no HCl, no intrinsic factor. No HCl is known as achlorhydria. Achlorhydria. Right? So there is problem in digestion of the food, the protein degradation. Okay, achlorhydria. And intrinsic factor is required for vitamin B12 absorption. So no intrinsic factor, no vitamin B12 absorption. If there is no vitamin B12 absorption, the person will have pernicious anemia. So these are the two end result of type A gastritis. A for autoimmune, never forget. A for autoimmune, I repeat my words. Okay, so here autoimmune say, you must remember that it's the autoimmune disease in which the autoantibodies are formed against the parietal cell of the stomach. The parietal cells of the stomach lining, they are destroyed by the autoantibodies, right? So parietal cells are destroyed, no HCl, no intrinsic factor. No HCl means achlorhydria, no intrinsic factor means vitamin B12 is not absorbed and patient have pernicious anemia. Listen my point, if the HCl is less, gastrin is a hormone. Have you heard about gastrin? So in the blood, gastrin will be more. The gastrin in the blood will be more. Gastrin is a feedback hormone. If HCl is less, the gastrin is secreted by the enterochromaffin cell and it will be more. It will try to increase the HCl. So there is hypergastremia. So that is all about type A. Let me come on type B. Type B is bacteria. B stands for bacteria. You will say, ma'am, what do you mean by bacteria? Which bacteria you are talking? I'm talking about H. pylori. Okay, A K bacteria. Only one bacteria causes disease in stomach, H. pylori, stomach lining. What does this do? This bacteria will come and this bacteria will cause inflammation of the gastric mucosa. Inflammation of the gastric mucosa, it involves the gastric mucosa. So the gastric mucosa get irritated. If it get irritated, it secrete more and more HCl. So here HCl is more. It is not less. Here HCl was less or absent. Here HCl is more. HCl is more. More HCl, we know when acidity is more. What happens to the stomach when there is more acidity? It will lead to ulcer. Because of the acidity, there will be peptic ulcers. So here in type B, we will have peptic ulcers. In type A, we have pernicious anemia. Here we have peptic ulcers. And since there is more acid, so tell me about the gastrin. Gastrin will be less. Gastrin and acid are inversely proportional to each other, no? So here gastrin will be less. Say yes. Everyone give me a thumbs up. You got it? The two type of gastritis are in front of you. Type A, type B. Can I remove this diagram? Can you help me in writing the important findings of type A gastritis and type B gastritis? What is A? Osama, Shalini, Nitesh, Debajan, Shiri, Chan, all of you. What is type A? What is type B? A stands for what? A for autoimmune. Just a second. Give me a minute. Okay. A for autoimmune. And what is B? B for bacteria. Which bacteria? B for H. pylori. Okay. So A for autoimmune, B for bacteria. Learn this. Now what is the problem in A? In A, there is autoantibodies are formed. The autoantibodies are formed against the parietal cell. So parietal cell are destroyed. If the parietal cells are destroyed, it secretes two things. No HCl, no intrinsic factor. No HCl will lead to achlorhydria, or no intrinsic factor leads to pernicious anemia. And there is less HCl, so it will increase the gastrin. So there is hypergastrinemia in the blood. The gastrin will be more. Coming on type B. What is the problem in type B? In type B, H. pylori causes inflammation of the mucosa. Mucosa get irritated. So there is high HCl. High HCl leads to peptic ulcer. So here the end result will be the peptic ulcer. Compare the end result here, compare the end result here. यहाँ पे achlorhydria था, यहाँ पे hyperhydria. I mean more HCl is there. And if you talk about the gastrin, since HCl is more, the gastrin will be less. So you have to understand the two type of gastritis. Yes, very good. All of you, very good. So please understand the two type of gastritis crystal clear in your mind. So don't learn the end results. Students even don't understand why there is pernicious anemia, why there is peptic ulcer. They used to learn it. Why to learn? Come on, you can understand now. Learn only one thing. A stands for autoimmune, you can make it out. And B stands for bacteria, you can make it out. One more thing I would like to tell you, the parts of the stomach. Can you tell me the 5 parts of a stomach? Let me draw a stomach. So this is the stomach, the junction of the esophagus, and the stomach is known as cardia. This portion is known as cardia, C for cardia. This bulge is known as fundus. The bulge is known as fundus. The main portion is known as body, right? The main portion is known as body. The last portion is known as pylorus. And the junction of the stomach and the duodenum is known as antrum. It is known as antrum. You can see the 5 portions C, F, D, P, A. If I say one word, okay. Now in which portion type A gastritis occurs, in which portion type B occurs? Can you tell me type A, type B? Type A kahan hota hai? Out of the 5, where is type A occur? And where does type B gastritis occur? So it is opposite. A occur in B, B occur in A. What do you mean by that? A occur in body. In the body, type A gastritis occur. And B occur in A. So type B occur in antrum. Now you will never forget. A occur in B and B occur in A. Say yes if you got it. A occur in B, B occur in A. So you will not forget. So type A gastritis, type B gastritis. A occur in B, B for body. B occur in A for antrum. Okay, it's a way to learn. A stands for autoimmune. Autoantibodies are formed against the parietal cell. B stands for bacteria. Which bacteria? H. pylori. And results, you already know. Here HCl is less, here HCl is more. Here gastrin is more, here gastrin is less. Here end result is pernicious anemia. Here end result is peptic ulcer. I hope I am crystal clear in my concepts. We are done with gastritis. I'm not giving you the questions to solve, but believe me, you can solve every question. Please try it out by yourself. I don't have time to give you questions also. Okay, so type A gastritis is autoimmune gastritis. It is associated with other autoimmune disease, okay, like Addison's disease, Hashimoto thyroiditis. It occurs in body. A occurs in B, I told you. So it occurs in body here, okay. The pathogenesis here, antiparietal antibodies are formed. Antibodies are formed against the parietal cell, The antibodies are formed against the parietal cells are destroyed. So no intrinsic factor leading to pernicious anemia. HCl will not come, leading to hypochlorhydria or achlorhydria, right? And it will lead to hypergastrinemia. We have already understood. Now, patient have pernicious anemia, hypergastrinemia and less HCl. See the end results. Right? In type B, B for bacteria. Which bacteria? H. pylori. Here the intestine, here the gastric mucosa get irritated. Since it get irritated, it become hyper secretory. So it secrete more and more HCl. So HCl is more. More HCl leads to peptic ulcer. It is not autoimmune disease, right? B occur in A for antrum, right? A for antrum. And here the pathogenesis is H. pylori. So I hope no need to read this description again. You can understand. I have already explained you the type A, type B. A for autoimmune, this one is type A. And B for bacteria associated, H. pylori associated, this is type B. You can see their site, you can see their pathogenesis, you can see their end result. So we are done with type A, type B, the two types of gastritis, A for autoimmune, B for H. pylori. Okay, so this one occurs in corpus. By corpus I mean body. A occur in B and B occur in A. Okay, here the bow and maw are less. I mean to say the acid is less, and here the acid is more. Here gastrin is more, here gastrin is less. And here the end result is pernicious anemia, here the end result is peptic ulcer. You all can understand. Coming on the next topic quickly. So next topic is peptic ulcer. We have seen Barrett's esophagus, we have seen gastritis, now I'm coming on peptic ulcer. I wish I was having 80-100 hours, I can teach you entire pathology like this. But unfortunately, I'm having only 12-15 hours in which I have to compact the important topics of the pathology, the high yielding pathology. So I cannot take all the topics, but the most high yielding topics I'm covering in this course. Okay, so coming on the peptic ulcer. The next topic is the peptic ulcer. What is peptic ulcer? What is the ulcer, by the way, in pathology? Can you define ulcer? Okay, tell me the lining of the stomach. What is the lining of the stomach or lining of entire GIT? In entire GIT, there are 4 layers. The innermost layer is the mucosa. Imagine this is the mucosa. Just below the mucosa, we have submucosa. We have submucosa. This is the submucosa having the glands. Okay. After that, we have muscularis propria. So this one is muscularis propria, and outermost to that is the serosa. So outermost to that, this is serosa. So these are the 4 layers you all know. We all know mucosa, submucosa, muscularis propria, and serosa. Entire GIT have. I'm teaching you ulcer. What is ulcer? What is the definition of ulcer? Ulcer is breach in mucosa. Please see, ulcer is breach in mucosa. If the mucosa is missing, imagine this portion of the mucosa is missing. So I will say this is a ulcer. Now ulcer go deeper, deeper, deeper. So ulcer can involve submucosa also by going deep. It can involve muscularis propria also by going deep. Sometimes it can be penetrating also throughout the burst ulcer. Okay, but the definition of the ulcer says it's a mucosa. The breach in mucosa, the discontinuity in mucosa, the discontinuous portion is known as ulcer. So that is the definition of the ulcer. Now, who will cause the breach in the mucosa? The ulcer is the breach in the mucosa, and that extends deeper. Okay. So where does the ulcer occur? What do you mean by peptic ulcer? Peptic ulcer can occur in 2 locations. If it occurs in stomach, it is known as gastric ulcer. And if it occurs in duodenum, it occurs in duodenal ulcer. So the 2 ulcers are known as peptic ulcer. In the entire GIT, where is HCl? HCl is present in which organ? In the entire GIT. GIT starts from the esophagus. Where it is present? HCl. I'm asking you, acid is present where? Acid is present, of course, in the stomach, but acid is present in the duodenum also. After that, in the jejunum, it is neutralized. So 2 organs are exposed to acid. Which 2 organs? Stomach and duodenum. That's why peptic ulcer is the ulcer which is due to acid. So that's why peptic ulcer occurs in 2 organs, the gastric ulcer and duodenal ulcer. So I mean to say peptic ulcer are the ulcer which occurs due to acid, and acid exposure occurs in 2 organs. So gastric ulcer and duodenal ulcer are the 2 types of the peptic ulcer. So please understand, peptic ulcer occurs in 2 organs, the gastric and the duodenal. Please understand, duodenum also have acid. After that, it is neutralized. You got my point? Now let me ask you a question. Let me see who can answer. Let me ask you a question. So this is the stomach. How many of you eat non-veg, non-vegetarian? Okay, if any human is non-vegetarian, listen, my question, listen. So if any of you is non-vegetarian or any human being who eat non-veg, so do you think non-veg is digested? The non-veg piece, the meat piece is digested in the stomach? Of course it is digested. That's why human can eat it, of course. So this is the acid present in the stomach. Let me draw the acid. Okay, this is the HCl. The acid is present in the stomach. The acid can digest the meat. The acid can digest the non-vegetarian meat. So my question to you, why does this acid is not digesting its own mucosa? It's also a meat, no? It is a piece of meat, right? Non-veg. So why not this acid? This acid is as strong that it can digest the meat. Why does this acid is not able to digest the own mucosa? My question to you. My question to you. Okay, my question to you. So can you give me the answer first? What's the correct answer? Because there is a protective covering. There is a protective covering. The entire mucosa is covered by a protective covering. This protective covering is made up of mucus. Mucus along with bicarbonate. Mucus and bicarbonate layer is there, which is covering the entire mucosa. It is acting like a shield between the acid and the mucosa. So acid do not come in direct contact with the mucosa. So there is a covering, there is a shield between the acid and the mucosa. This is the reason. This is the reason. So can I say If acid comes in direct contact with the mucosa, it will produce ulcer. Yes, it will produce the ulcer there, because it will cause degeneration of the mucosa, go deeper, 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 and it can produce deep, deep ulcers. So acid is not in direct contact with the mucosa. So can you tell me two type of factors? The aggressive factors and defensive factors. What is aggressive factors? What is defensive factor? Aggressive factor that causes ulcer. Aggressive factor is HCl. HCl causes ulcer. Aggressive factor is H. pylori. Why? What does H. pylori causes? H. pylori causes irritation, and because of irritation there is more and more acid. So it's also aggressive factor. Whenever H. pylori is present, we know the chances of peptic ulcer are more. I told you, because of more HCl there is peptic ulcer in type B gastritis. Okay, in defensive factor there is bicarbonate layer is there, and mucus layer is there, and prostaglandins increases the blood supply. They are also defensive. So normally there is a balance between aggressive and defensive. You can see there is a balance between them. Due to any reason, if aggressive is more and defensive is less, it leads to imbalance, and that can lead to ulcer. So give me a minute, why I cannot see the video. Am I live? Just a second. I guess I am. Yes. So you can see, due to any reason, if aggressive are more and defensive is less, and there is an imbalance between them, it can lead to ulcer. So for ulcer, what are the reason? Either acid is more, or H. pylori is more, H. pylori infection is there. These are the aggressive factor. Or else acid is normal, still patient can have ulcer, peptic ulcer, if the bicarbonate, mucus or prostaglandin is less. So either there is aggressive factors are more or defensive are less. You can see. So what are the aggressive factors? Can you tell me? The aggressive and the defensive factors. What are aggressive factors? Aggressive factor is the HCl. Aggressive factor is the pepsin. You know pepsin. Pepsin is a enzyme that digests the protein. H. pylori. Defensive is bicarbonate, mucus, prostaglandin. So you can see there is an imbalance. These are more, these are less. In a weighing machine, you can see this one is more, this one is less. And this imbalance can lead to ulcer. Now what are the risk factors? When this imbalance will occur? Whenever we have stress. Whenever we have too much stress, either the psychological stress, sometimes we take too much of stress, we have acidity. Do you feel like that? Sometimes I feel I'm having too many classes or too busy schedule. Sometimes I'm very stressed and I feel like acidity. So more acid is there, the secretion is there due to psychological stress or before exams or due to any stress. Okay, there is physiological stress also in the body. Sometimes the shock, trauma, septicemia. So during this condition, the body don't have psychological stress, but in physiological stress also there is acidity. Now two more important causes you have to learn. Listen, let me explain you. Whenever there is extensive burns, it causes stimulation of the vagus nerve, and it causes secretion of more and more acid in the stomach, and because of which the ulcers occurs in the stomach, and it causes curling ulcer. It is known as curling ulcer. I'm sorry, not due to vagus stimulation. During burns, it is the most painful condition. During burns, patients have severe pain, and during pain there is acidity. You know, whenever we have severe pain anywhere on the body, there is severe acidity. So during extensive burns, due to the severe pain, there is acidity and it leads to ulcers. Such ulcers are known as curling ulcer. Curling ulcers are seen in burns. And whenever there is intracranial lesion in human body, any intracranial lesion, there is trauma, there is surgery of the brain, trauma in the brain, during which the vagus nerve gets stimulated. The vagus nerve gets stimulated, it is causing hyperacid secretion. The ulcers produced are known as Cushing. Now both are C and C. You can get confused between curling and Cushing, and both are PYQ. Curling and Cushing. Both are peptic ulcer. This is also peptic ulcer. This is also peptic ulcer. So curling is seen in burn, and Cushing is seen in intracranial injury. Intracranial injury. So how to learn that? How I learn, let me tell you. I take R. Curling में R आता है, burn में R आता है. So curling is for burn. I never forget like that. You can make your own way. So curling is seen in burn. Okay. Cushing is seen in intracranial injury. If you have some better way, you can tell me. I can share with other students also. So I learned like that. Curling occurs in burn patient and Cushing occurs in intracranial. Both of them are peptic ulcers. We have given these names. Say yes if you got it. Right? Cushing is pillow. So pillow से कैसे याद करें देवजन? How we can learn with pillow? Cushing is pillow. Cushing, yeah, cushion means cushion, cushion means pillow, but how I correlate pillow with the intracranial? Okay, we keep pillow on the brain while sleeping, like on the head, you mean to say? Yeah, that's a good way, you can say. So Cushing se kya yaad aata hai? With the Cushing, we can remember cushion. Cushion is the pillow, okay? And pillow, we sleep like this. So it's intracranial portion, you can learn like that. Better, good one, thank you. So can we go ahead? Okay, so these are the risk factors. Etiology we have already seen. Now there are two types I have already told you. The gastric ulcer occurs in the stomach and duodenal ulcer occurs in the duodenum. These are the two types of the peptic ulcer. Okay, some of them are benign, sometimes rarely it can be malignant. Okay, now coming on the site. So tell me the exact site in the duodenum and tell me the exact site in the stomach. Exact site in the duodenum, exact site in the stomach. Can you tell me which is more common, duodenal or stomach? Let me draw both. You can see this is stomach, this is duodenum. Please draw both. Which is more common? The duodenal are 4 times more common than gastric. Duodenal are more common. Both are peptic, but duodenal are much more common as compared to gastric. Let me draw both of them. In the duodenum, we have 3 portions. First part of duodenum, second part, third part. You may have read all this in anatomy. So in which part the peptic ulcer most common? Peptic ulcer most common in the first part of the duodenum. The first part of the duodenum on the anterior wall. On the anterior wall, in the first part of the duodenum, it's common, number 1. Coming on the gastric. In the gastric, there are 5 portions. I already told you: cardia, fundus, body, pylorus, antrum. So in which portion it occurs? The first thing, it occurs in pylorus and antrum. The peptic ulcer occurs in last 2 portions. Pyloric antral canal, we call it. So it occurs in pylorus and antrum. So it occurs in pylorus antrum. In stomach, we have 2 curvature. This is lesser curvature. This is greater curvature. Greater curvature, lesser curvature. So it occurs on lesser curvature. Let me check. But yeah, it occurs on lesser curvature in the pyloric antral canal. So this is the exact location. You got it? Say yes. So what is the exact location? In the duodenum, in the first part on the anterior wall, and in the stomach, it occurs in the pyloric antral canal on the lesser curvature. You got it? Yes. So to be exact, this is the site. So what, Osama, you are asking? In the jejunum, they do not occur. They do occur only at 2 sites, the stomach and the duodenum, because after duodenum the acid is neutralized, so ulcers do not occur. Ulcers can occur in jejunum, Osama, but due to other reason, not due to acid. So I will not call them peptic ulcer. In jejunum, peptic ulcer will not occur, but you will say TB ulcer, typhoid ulcer, that can occur anywhere in the intestine, so that can occur, but peptic ulcer will not occur. Peptic ulcer are the ulcers due to the acid. They are limited to stomach and duodenum. My point is that. Can we go ahead? You can see the most common location. So in duodenum, it's the first location in the duodenum. In the first part of the duodenum, it is the most common location. The second most common location in the stomach. This is the second most common location in the stomach, in the pyloric antral canal on the lesser curvature. You can see on the lesser curvature. This is the second most common. Third most common location is cardia. Third most common location is the cardia. Fourth most common location, you can see gastrojejunostomy. Stoma is there. And fifth is Meckel's diverticulum. Don't learn the 5. First 2 are more than sufficient. Are you people still there? Can we go ahead? Grossly, the peptic ulcer is of 2 types. Now I told you it is of 2 types, the benign and malignant. See the margin. This is also ulcer. This is also ulcer. See the margin of the ulcer. Here the margin is punched out. The margin is punched out. It's very sharp. It's punched out. And here the margin is rolled out. Here you can see the margin is rolled out. Completely rolled out everywhere. The margin is rolled out everywhere. So here it is punched out. Here it is rolled out. That is gross. Coming on the microscopy. What happens if I cut and see under microscope? This is ulcer. See in the microscopy, let me tell you the 4 zones quickly. Everyone here on the screen. Can you see here? This is mucosa. Everyone appreciate the mucosa, 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 mucosa. Here it is discontinuous. And here it is again continuous. So can I say this portion is ulcer? Yes, this portion is ulcer, a breach in mucosa. See, it is the breach, discontinuity in the mucosa. Now let's have a look on the ulcer. Can you see the uppermost portion of this? Can you see the uppermost portion? This is necrotic zone in which necrosis is there. This is known as necrotic zone. In having the necrosis, the uppermost zone. After that, the second zone is there. Let me show you the second zone. The second zone is known as exudative zone. Exudative zone having inflammation. You can see the neutrophils, lymphocyte, plasma cell. This is exudative zone, having abundant of inflammation. After that, the third zone is there. The third zone is known as granulation tissue zone, in which along with inflammation, vascularity is also there. You can notice the blood vessel. This is known as granulation tissue zone, in which along with inflammation, the vascularity is there. And last one, you can see here which color I should select. It is the fibrosis. The last one is the fibrosis. This zone is known as cicatrization. Cicatrization is fibrosis. I cannot simplify more than this. You can see my color coding. The 4 zones are in front of you. Don't learn. The meaning is in front of you. The first one is the necrotic. You can see the necrosis. The second one is the inflammatory. You can see the inflammation. Third one is the granulation tissue. You can see the granulation tissue. The last one is cicatrization, is the fibrosis. See the 4 zones. What are the 4 zones? Necrotic, exudative, granulation tissue, cicatrization, one behind the other. This is a histology of an ulcer, the peptic ulcer. We have seen the types of the peptic ulcer. Let me tell you the differences between them. Imagine a patient is coming to your clinic. Doctor, I'm having epigastric pain. You know epigastric region, just below the diaphragm, right? There is pain in epigastric region. Let me draw a rough sketch diagram of a patient in front of you. Imagine the patient is coming to you, doctor, I'm having epigastric pain. Whenever I eat, I'm feeling fullness, I'm having pain. You are having doubt. This patient is having peptic ulcer, right? Now, it can be stomach, it can be duodenum, it can be gastric ulcer, it can be duodenal ulcer, right? The best thing to distinguish between them, do an endoscopy. Do an endoscopy, take the camera inside and see where is the ulcer. Is it present in stomach? Is it present in duodenum? The best is the endoscopy. But based on clinical feature, can we differentiate them? Yes, we can differentiate them, and based on clinical feature also, this is just a guess. But final call is the endoscopy only. The finally we can see on the endoscopy. Okay, but how we can judge based on the clinical features and history of the patient? Ask patient 9 questions. Your answer will be in front of you. First question, imagine patient is sitting in front of me. First question, I will ask the patient, on eating food, pain increases or decreases? On eating food, pain increases or decreases? If the patient is saying on eating food, pain decreases, relief of pain, it's duodenal ulcer. And on eating food, the pain increases, it's gastric ulcer. The first question you should ask always, being a doctor, whenever you are suspecting any of the peptic ulcer, you want to differentiate whether it is duodenal or gastric. Hardly it matters, because treatment for both of them is same. The medical treatment for both of them is same, right? Some differences are there that will be dealt in pharmacology. Okay, so if on eating food the pain decreases, it's duodenal. If pain increases, it's gastric. Okay, ask the second question, do you have night pain? Night pain, whenever you go to the bed, you are sleeping, and in the middle of the night at 2 a.m., at 3 a.m., you just wake up, I'm having severe pain. Does it happen sometime? If it is night pain is common, yes, the patient said frequently it occurs, doctor. So it is duodenal ulcer. And if it is uncommon, it is gastric ulcer. It is not occurring, it is gastric ulcer. So second question is night pain. Ask the first question, pain. Second question, night. First question is food and pain pattern. On eating food, pain decreases or increases, that pattern. The second question is the night pain. The third thing, let me explain you here. Very easy. All ulcers bleed. There is a rule, all ulcers bleed. Gastric ulcer, it will also bleed. Duodenal ulcer, it will also bleed. Listen, bleeding is a common thing. Gastric ulcer, the bleeding will come more commonly in vomiting. Bleeding in vomiting is known as hematemesis. Hematemesis. You know, emesis ka matlab hota hai vomiting. Emetic drug, anti-emetic drug. Hematemesis. Hemat means RBCs in the vomit. Hematemesis. Split the term. Right? And if the bleeding occurs from the duodenal ulcer, it will go in stools. It will go in stools. Bleeding in stool is known as melena. It is known as melena. So ask the patient in which form you have bleeding. You have bleeding in the vomiting or you have bleeding in the stools. Right? Here it is dark brown color. It is not fresh bleeding. It is coming from upper side, upper GIT. It is a dark brown color. So coffee, and here also it will be coffee color. So either the vomiting is coffee color vomitus is there, or the stools are coffee or brown color, right? So ask the patient, do you have melena or hematemesis? Based on that, you can differentiate the two. Say yes. Yes, you got it. So say Here there is no vomiting. In gastric ulcer, vomiting is common. Vomiting and blood and vomiting, that is hematemesis, is also common. Vomiting and the blood and vomiting, both are common in gastric ulcer, right? But melena is common in the duodenal ulcer. Melena is common in duodenal ulcer, right? Now, what happens to pain of food? Food pain pattern kya tha? What was the food pain pattern? So I told you here, on eating food, the pain decreases. So patient eat more and more. Whenever patient eat like pain, he will eat. Whenever patient have pain, patient will eat, so that pain will subside. So there is no weight loss here. But here on eating food, the patient have pain, so patient stop eating the food. Patient have a apprehension, if I eat the food I will have pain, so patient eat very less or no food, he skip the meals. So here significant weight loss is there. So everything is conceptual. If you understand, no need to learn, no need to learn. Got it? Can we go ahead? Can we go ahead? Okay. Here patient don't have any particular choice of food. Patient eat everything. But here patient eat bland food. No spicy food. Whenever the patient eats spicy food, more pain is there. That's why patient choose bland diet. Right? Here, you know, the abdomen is divided in 9 quadrants. The abdomen is divided, everyone knows, I guess. In physiology, you may have seen the 9 quadrants of the abdomen. Okay. This is the diaphragm. Let me divide the abdomen in 9 quadrants. I guess everyone knows that. Now you tell me, where is the stomach and where is the duodenum? So this is the esophagus. Just here we have the stomach, and on the right side here we have the duodenum. You tell me, the epigastric ulcer occurs in this quadrant, the gastric ulcer occurs in this quadrant, and duodenal ulcer occur in this quadrant. You can see they are falling in different quadrants. So ask the patient to lie down, supine, and palpate all 9 quadrants. Ask where the patient is having exact pain. If the patient is saying, I am having pain in the epigastric central quadrant, epigastric central quadrant, it's gastric ulcer. And if the patient is saying, I am having pain in right hypochondrial quadrant, this is right hypochondrial quadrant, so it is, the patient is having duodenal ulcer. So palpate. Being a doctor, you should be able to palpate all 9 quadrants very sincerely. Ask the patient to lie down and palpate it very sincerely, and ask the patient where he feel the tenderness, let you know. So based on the tenderness, you can tell deep tenderness is which quadrant. So if it is right hypochondrium quadrant, it is duodenal ulcer, and if it is midline epigastric quadrant, it is gastric ulcer. Here there is no seasonal variation, and here seasonal variation is there. Here duodenal ulcer occurs more commonly the people who take stress, and here type A personality like, and gastric ulcer is more common in the people who take weight, the laboring class, right? So that is the differences between them. Say yes, you got the differences. There are many important MCQs based on that. Everyone say yes, the differences between duodenal and gastric ulcer. Can we go ahead? So coming on the complications of the peptic ulcer, there are 3 complications. Most common is bleeding. I told you all ulcer bleed. Please learn this golden rule. All ulcer bleed. Okay, it is the most common complication. Duodenal ulcer bleed from the posterior wall, usually from the posterior wall, and it leads to iron deficiency anemia. From the ulcer, patient go on bleeding. So bleeding either in the melena or in the hematemesis. Bleeding either in the vomiting or in the stool. In the vomiting, it's hematemesis. In melena, it's in stool, it's known as melena. You know, gastric ulcer results in vomiting bleeding, and duodenal ulcer results in stool bleeding. So anyway, patient will have iron deficiency anemia, coffee ground appearance vomiting, and melena. So that is the first complication. The second complication is perforation. Can I come on the second complication? The second complication is perforation. So sometimes there can be perfo. You can see the perfo. The perfo, it is the second most complication. Perfo can be there. It is the most common cause of death. It is a severe medical emergency. Most commonly perforation occurs in the duodenal ulcer, but from anterior wall. So posterior wall bleeding, anterior wall perforation. Please learn. Both are in duodenal ulcer. The third are the malignant transformation. Sometimes ulcer convert into malignancy. Duodenal ulcer never convert into malignant. Only 1% of gastric ulcer can convert into malignancy. So duodenal ulcer, gastric ulcer. What we have learned, these one are more common, these one are less common. These one occurs at the first part of the duodenum. These one occur at the pyloric antral canal on the lesser curvature, right? Here pain get decreased on eating food. Here pain get increased on eating the food. Here no loss of weight. Here loss of weight is there. Okay, what else we have learned? Here melena is common. Here hematemesis is common. What else we have learned? Tell me more points, right? Bleeding occurs in both of them. Perfo can occur in both of them, but both are more common in duodenal ulcer. Bleeding occurs from posterior wall. The perfo occurs from anterior wall. But malignancy occurs only in gastric ulcer. Malignancy never occurs in duodenal ulcer. In gastric ulcer also only 1% can convert into malignancy. Got it? Say yes. Got it? Can we go ahead? Say yes. Okay. So Subina is asking a very good question. She is asking the reason for the pain pattern, like foot pain pattern. She is asking the reason. Let me try, Subina. I cannot guarantee, but I will try. Okay. So listen, this is the GIT I am drawing. So this is the acid. Acid is more present in the stomach and lesser amount in the duodenum, because acid is synthesized in the stomach only, right? So whenever a basal acid is always present, that is known as BAW. Have you heard about BAW? So basal acid is always present. We eat or we don't eat, a small amount of acid is always present. But whenever we eat the food, at that time more and more acid is secreted. More and more acid is secreted, that is known as MAO. You have heard that, right? So whenever you eat food, at that time the acid secretion will increase. It's a physiological phenomenon. Whenever we eat, we have acid secretion in our stomach now. So more and more acid will secrete. Imagine here is the ulcer. Here is the ulcer, the gastric ulcer. So more and more acid will secrete now. That will irritate the ulcer. That will irritate the ulcer and causing more pain. So gastric ulcer, on eating food, the pain increases. This is the reason, Subina. You got it? This is the reason. Now you may ask the second question. I know that. Why in duodenal ulcer it is decreasing, right? So in duodenal ulcer, again there is a reason. The same reason I will continue. Imagine this is the duodenal ulcer. Okay. This is the duodenal ulcer. So BAW is always present now. So BAW is always present. A little bit BAW is always present. But on eating food, this food will go ahead, but you know this acid will be neutralized by the alkaline secretions ahead. You know, it is gradually secreted. So whenever we eat food, two things happen simultaneously. One, the acid secretion occurs in the stomach, and intestinal secretion also starts simultaneously. So the intestinal secretion is neutralizing the BAW, and that's why on eating food here the pain decreases. So this is the reasons given in the book. You can understand like that. So gastric ulcer, the pain increases, and duodenal ulcer, the pain decreases due to the neutralization of the acid in duodenum. But neutralization do not take place in stomach. In stomach, synthesis take place. You got it? Give me a thumbs up. You got it? Can we go ahead? Subina. Others, you got it? Okay. So this is the reason. So I explained you. Now let me tell you two more complications. Beautiful complication of the ulcers. One is teapot. Have you seen a teapot? We all drink tea in a pot. See the shape of teapot. A cup of a tea. So sometimes after ulcer, the stomach shape is like a teapot. See this shape and compare it with this. It is teapot. Okay, compare it. Why the stomach shape is like this? What is the end result of ulcer? In ulcer, if there is healing, what is healing? You know the steps in the healing. In healing, contraction occurs. Contractures are formed. In healing, the contraction occurs. So imagine this is the ulcer. Here is the ulcer in the stomach. And longitudinal, I'm using the word longitudinal, the ulcer is longitudinal, and longitudinal contraction occurs. So what will happen? Imagine, due to the longitudinal contraction, this portion becomes smaller. It will become contracted. So this portion is like this. It becomes contracted, and greater curvature is bigger. So the shape of the stomach is like teapot. You got my point? It is the longitudinal contraction. Let's do transverse contraction. Have you seen hourglass? This glass is known as hourglass. Can you see the shape? See the shape of the glass. I guess everyone knows what is hourglass. This glass is known as hourglass. Now you see, if there is transverse contraction, it is hourglass shape. Compare the shape of the stomach here. It is looking like hourglass. So let me draw the two things for you. If you are not getting confused, let me try. Okay. So there can be longitudinal contraction and there can be transverse contraction. Which contraction is taking place? If the longitudinal contraction taking place, the shape of the stomach will become like this. Okay, the shape of the stomach become like this because this portion is contracted. Imagine this portion is contracted. Okay, if the transverse contraction taking place, the shape of the stomach will be like this. You can imagine, and this is known as hourglass. I tried hard here. Come on, this is teapot and this is hourglass. This is hourglass. You can compare. So you can say this is longitudinal contraction and you can say this is transverse contraction. So depending which is the ulcer is longitudinal or transverse. Depending on that, you can have the shape of the stomach different. The two type of shapes are described as a complication, the teapot and the hourglass. You got it? Can we go ahead? So please learn the two types of the shape. This I have already taught you, so I'm not repeating again. You know what is Cushing ulcer, you know what is curling ulcer. I told you to learn R for R. Curling is seen in burns, and Cushing like a pillow, like cushion, it's pillow. So intracranial injury. So we have seen that. We are done with the two types of the ulcer. What investigations you will do? What investigation? What is the screening test for ulcer? Imagine there is a patient in my clinic and I assume I am having suspicion that the patient is having peptic ulcer. One of the peptic ulcer, either gastric ulcer or duodenal ulcer. What screening test I can apply? Non-invasive. You will say my best is to do the biopsy. Do an endoscopy and take the chunk of the ulcer out. Take the tissue, the chunk of the ulcer out and make a biopsy. On the biopsy, we can see the four zones, the necrotizing zone, exudative zone, granulation tissue zone, cicatrization zone. It's a typical ulcer. So best is to do a biopsy, but biopsy is invasive. It is invasive. Patients are not very convenient for biopsy. So do a non-invasive test, a screening test. It is known as urea breath test. What it is known as, say again, urea breath test. What is the principle for that? Yes, endoscopy is the best, Osama, but it is invasive, no? You have to give the anesthesia, you have to give local anesthesia although, but patients are not very comfortable. No one will agree for the endoscopy. You have to convince the patient. So if there is a non-invasive way, it's better. Okay, so urea breath test is a screening test which is a non-invasive test. So it is as good as biopsy. The results are as equivalent as biopsy and it is a non-invasive method. Let me draw the principle. So imagine this is the GIT of my patient. This is the GIT of my patient and the patient is having an ulcer. I want to know the ulcer. Okay, imagine this is the ulcer. The patient is having ulcer anywhere. Now the ulcer, 90% of the gastric ulcers are associated with H. pylori. So H. pylori bacteria is present. This blue color I am drawing H. pylori. 90% of them are associated with H. pylori, the ulcers, right? The peptic ulcers, I mean. So H. pylori is present here. We ask the patient to drink urea. Yes, we will give the patient urea. I don't know the chemical formula of urea. Do you remember? We have read in chemistry, no? I don't remember, but it contains carbon. I know that, right? I will give radioactive urea, C13. Normal carbon is C14. I will give C13 carbon urea, the radioactive urea, to drink. The patient will drink that. It's non-invasive. I will ask, it's a medicine. You have to drink that. After that, we will do the test. The patient will drink that. The patient will drink the urea which contain radioactive carbon. Now there are two possibilities, either H. pylori is present or it isn't present. If it is present, H. pylori secrete an enzyme known as urease. Urease is secreted by H. pylori. Human stomach don't have urease. H. pylori secrete urease. Urease will split the urea into two things, into ammonia and carbon dioxide. Ammonia will go in the blood. Okay, there is no problem in that. What about carbon dioxide? Carbon dioxide contains carbon, that is C13 carbon. This carbon dioxide will also go in the blood. Let me draw the blood vessel. So this carbon dioxide, the radioactive carbon CO2, C13 CO2, it will go in the blood. From the blood, it will go in the lungs. This will go in the lungs, and from the lungs, it will be expired out. Inhalation, expiration. So in expiration, this carbon will come out, right? So we will give the patient a breath analyzer. Have you heard about breath analyzer? When you drive, when you drive late night, sometime the police give you a breath analyzer just to check you are not drunken while driving. So what the police ask you, it's like a small instrument. They ask you to exhale your breath inside that. So it is the same instrument, the breath analyzer, but it do not detect alcohol, it detects radioactivity. If the breath contains the radioactivity, it will give the signal and you come to know the radioactive carbon is present. The radioactive carbon is in the form of carbon dioxide. It will come only if the H. pylori is present, because urease have splitted it. If urease is not present, the urea will not split and urea will remain urea only, and carbon dioxide will not come in the breath. So it is a way. You got my point? So that is urea breath test. So same test is shown to you, the urea breath test. So you are asking the patient to drink the radioactive urea. The urea is going inside. The urease is splitting the urea into CO2 and ammonia. The CO2 coming in the blood, it is going in the lungs. From the lungs, it is exhaled out. Come on, give me a thumbs up. So Shri, this is the formula for urea, but I will not remember it. Now it's out of scope. You just remember it. Whatever it contains carbon, that matters. Okay, but it's good. Thank you. So this is urea breath test. Can we go ahead? Can we go ahead? So this is urea breath test. The second, but the gold standard, do a biopsy. This is a biopsy. You can see on the biopsy, apply a special stain to highlight the H. pylori. What is the name of that special stain? The name of the special stain is Warden-Starry. It's a brown color stain. Warden-Starry. Please learn, it's a PYQ. Warden-Starry stain. You can see Warden-Starry stain is highlighting the H. pylori. These rods. Can you see these rods? These all rods are the H. pylori that get highlighted on Warden-Starry. So Warden-Starry stain is there, right? So we are done. We are done with the GIT. I'm not taking the carcinoma. If you wish, I can launch an oncology series. If you want, I'm not insisting. In the oncology series, I will take all tumors, the pathology point of view, all tumors together at one place, right? Tumors of entire human body. Starting from the brain, I will start with brain tumor, the retinoblastoma of the eye. In the nose, there is the whatever tumors, nasopharyngeal carcinoma. I will go in the tonsillar tumors. Then I will come on the lung tumor, then the GIT tumor, stomach tumor, intestinal tumor, large intestine, appendix tumor, then the liver tumor, the kidney tumors, the thyroid tumors, the genital tumors. We can launch that. It's a good idea. So sometime we can, some or other time we can launch the oncology series, in which I should tell you the histopathology of all tumors at one place from pathology point of view. Oncology is something, it is an integrated branch. It is medicine also, treatment also, chemotherapy also, radiotherapy also. But from pathology point of view, the oncology, the histopathology slide of all tumors at one place, the various classification, we can do it, right? So I'm skipping the tumor. Yeah, it's much needed. I know that. So I will ask the team if the hours are remaining, and if they allow me, I will do that. Okay, I'm not sure, but I will try. Okay, so I will try to launch the oncology series, in which I will take the tumors together. So currently I'm skipping the tumors. Okay, let me come on the next disease. The next disease I'm teaching you is inflammatory bowel disease. Can I continue? Inflammatory bowel disease, right? So let's start inflammatory bowel disease. There are two inflammatory bowel disease, Crohn's disease and ulcerative colitis, CD and UC. Let me differentiate the two. Crohn's disease and ulcerative colitis, the two type of inflammatory bowel disease. Let me explain what do you mean by that. So let's start with Crohn's. In both of them, the bowel get inflamed, but the gross is different, the microscopy is different. Let me start with the Crohn's disease. So see the two diagrams. Can you see the two diagrams? Everyone on the screen, please here. Please see on your gadgets. See the two diagrams. You can see here, this is Crohn's disease and this is ulcerative colitis. You can see. So please tell me from where the Crohn's disease is starting. The Crohn's disease starts from the terminal ileum. You can see the terminal ileum. The ileum is ending here. It starts from here, right? And it can involve the ileum also and colon also. You can see it is starting from terminal ileum. The start point is terminal ileum. And the start point for ulcerative colitis is the rectum. It is starting from the rectum. Learn the starting point. It's terminal ileum in Crohn's disease. It's rectum in ulcerative colitis. Very clear. Now see where is the disease. Here this is the disease, then normal, then again disease, then again normal, then again disease. So this is known as skip areas. Skip areas are present in Crohn's disease. But in ulcerative colitis, it's continuous involvement. The skip is absent. Here skip lesions are absent. It's continuous involvement. You got my point? So learn the starting point in both of them. See, skip lesions are present in Crohn's disease. They are absent in ulcerative colitis. I hope you got the skip lesion. Disease present, disease absent. Disease present, disease. So there is a segment which is healthy, then a segment which is diseased. Then again a segment healthy, then again a segment which is diseased. It's like that in Crohn's disease. But in ulcerative colitis, it's continuous. So by continuity, the ulcerative colitis can involve the entire colon, and after that it can involve the ileum also. If the ulcerative colitis is reaching up to ileum, it is known as backwash ileitis. Backwash ileitis. It's a term you have to learn because it is coming from backward. पीछे से आ रहा है. It is coming from backward and involving the ileum. It is known as backwash ileitis. Can we go ahead? Can we go ahead? Okay. So you can compare the Crohn's disease and ulcerative colitis. You can see. So Crohn's disease start from the terminal ileum, extend in the cecum and skip areas. So let me tell you 7 important points in the Crohn's disease. Then I will come on ulcerative colitis. Let's start Crohn's disease. Okay. Crohn's disease skip areas present. Say yes or no. One more thing. Here, due to the disease, the wall become thick. The wall, intestinal wall, the 4 layers become thick. So if you see the lumen become narrow. In Crohn's disease, the lumen, if you see the lumen here, it is narrow. and here the wall thinned out, so lumen become wide. So here lumen is narrow, here lumen is wide. So two types of pipes are there. You know, pipes are available in the market: narrow lumen pipe, wide lumen pipe. This is CD, this is UC. In CD the wall is thickened, that's why lumen is narrow. Here wall is thinned out, that's why lumen is wide. It is known as hose pipe. It is a type of pipe with narrow lumen, and this is known as garden pipe. Garden pipe, it is a type of pipe with wide lumen. We use these terminologies. You got my point? So hose pipe and garden pipe. You got my point? Can we go ahead? So hose pipe and garden pipe, you can understand. So let me tell you the 7 important points of the Crohn's disease. Number 1, skip areas present, everyone can understand. Number 2, hose pipe, because the bowel is thick and lumen get narrow. So now you can understand that also. See again, beautiful diagram, Crohn's disease and ulcerative colitis. Compare. See, it is starting from terminal ileum, skip areas are present, and it is starting from rectum, it's continuous. Here the lumen become narrow, here the lumen become wide. Okay, please compare. The same you can compare here also. The same thing, skip areas you want to highlight and the continuous involvement you want to highlight. Can we go ahead? The next, coming on the ulcers. Now you can see the ulcers. Multiple ulcers are present. Now there is a diseased area, there is a healthy area. There is a diseased area, there is a healthy. We got that. But what is there in the diseased area? In the diseased area, multiple ulcers are there. The shape of the ulcer is snake-like. Can you see? It is known as serpentiginous ulcer. The snake-like, multiple small ulcers are there. They are snake-like. They are small snake-like ulcers known as serpentiginous ulcers, right? Now if you no, this is an ulcer. Okay, let me draw the mucosa. This is an ulcer, this is an ulcer, this is an ulcer, this is an ulcer. Between the ulcer, whatever mucosa is present, let me highlight. This is the mucosa, this is the mucosa. So between the ulcer, mucosa swells up. So there is an ulcer, then swelled mucosa, then ulcer, then a swelled mucosa. It gives cobalt stone appearance. See, this is known as cobalt stone. Have you seen cobalt stone? This is known as cobalt stone. See, and on endoscopy the mucosa looks like this. In Crohn's disease we are talking. You can see this is ulcer, this is ulcer, this is a, these all are serpentiginous ulcer, and between them the mucosa swells up. The healthy mucosa between them swells up. This appearance is known as cobalt stone appearance. The stones are there. You see, so this is the normal intestine. This is the intestine in Crohn's disease. Appreciate the cobalt stone appearance. Appreciate these all are ulcers, and between the ulcers the mucosa swells up. Say yes. Say yes. Okay. What you are asking? ABC, please don't distract. I don't know. If there's some query is there, please write down. Okay. So can we go ahead? Can we go ahead? So this is cobalt stone appearance. The next is adhesions are very common here in Crohn's disease. Fistula, fissures are common, sinus is common. Fistula, fissures, sinus, adhesions and strictures. You can see stricture. Can you see a stricture? The narrowing of the lumen. These all are common in Crohn's disease. Right, granulomas are also very common. You can see multiple granulomas in Crohn's disease. So that is the Crohn's disease. The gross, I will come on the microscopy also, then I will revise it completely. We have seen the important points here. Now coming on the histology, this is the histology. I would like to show you that diagram again. Give me a minute. See this diagram again. Everyone on the screen, please here. See. Now see, here also we have ulcers. Here also we have ulcers. See the biopsy, the lower diagram of both of them, histopathology. Appreciate here the ulcers are deep. Deep ulcers are known as fissures. Deep ulcers. Deep ulcers. You can see the depth is more as compared to length and width. Okay. And see the ulcers here in ulcerative colitis. You can see they are wide. They are wide, but they are superficial. They are not deep. You can see the GIT have 4 layers. Here also, mucosa, submucosa, musculus propria and serosa. So here in Crohn's disease, the ulcers are deep, reaching up to serosa. They are very deep. They are not known as ulcers. They are known as fissure. Itna deep ulcer hai ki we call it as a fissure, right? And here ulcers are very superficial. In ulcerative colitis, they are superficial. They are superficial, involving only mucosa and submucosa. They don't involve musculus propria. It is visible here. Now let me come on one more important point here only. You can see here between two ulcers the mucosa swells up. The mucosa swells up. The mucosa swells up. It is giving cobalt stone appearance. I told you. Here also between two ulcers the mucosa swells up. Mucosa swells up. The swelled mucosa in ulcerative colitis is known as pseudopolyp. It is not a polyp, but it looks like a polyp. That's why known as pseudopolyp. So here we have cobalt stone appearance and here we have pseudopolyp. Here in Crohn's disease the ulcers are deep, like a fissure, like a sinus. Here the ulcers are superficial, wide. Here between two ulcers the mucosa swells, it is cobblestone appearance. And here between two ulcers the mucosa swells, it gives the pseudopolyp appearance. Say yes. Got it? Say yes. So Crohn's disease, ulcerative colitis. What we have learned, the Crohn's disease start from the terminal ileum and skip lesions are present. The ulcerative colitis start from the rectum and it's continuous. No skip lesion are present. And in the microscopy also you can see, in the Crohn's disease, fissures are common, sinuses are common, fistula is common, granuloma is common. These all are absent here. Here cobblestone appearance is there, here pseudopolyp is there. We have learned this till now. Jalaram, many students are here who don't understand Hindi, so there will be a separate series on Hindi. Don't worry for that. But currently I am using a very basic English. I guess you also can understand that, and images are there for understanding. So I will try to concise myself in English only, because most of the students here are from abroad and they understand English language only. But English is very basic. You don't have to make trouble to understand that. Anyways, let's come ahead. So let me tell you the histology now of Crohn's disease. You can see this is the microscopy of Crohn's disease. Can you make out the 4 layers, please? Where is mucosa? So see the continuity of the mucosa. Tell me where is the ulcer. Tell me where is the ulcer. Can you see? This is mucosa. It is continuous, 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 continuous. There is a discontinuity here. Again it's continuous, 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 continuous. Again there is a discontinuity here. So a breach in mucosa is known as ulcer. Let me highlight the ulcer with a highlighter. So I guess this is an ulcer. It's going deep, 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 deep. This is also ulcer. It's going deep. I can see the deep ulcers. Very good. Yes. So I can see deep fissures. The deep fissures involving mucosa, submucosa, muscularis propria even. Right, number 1. Number 2, in the submucosa, what is the structure? In the submucosa, see the structure. What is it? What is it? See the structure. What is it? You can see the giant cells are there. It's a granuloma. So granulomas are common. The non-quisiting granulomas can be seen in the submucosa. Number 2, right? And number 3, see the inflammatory cells. Where are the lymphocytes? Can you see the inflammatory cell? We can see the inflammatory cell in the submucosa also, in the muscularis propria also, in the serosa also, in the mucosa. So inflammation present transmural. You can make it out everywhere the lymphocytes are present. Lymphocytes, it's mononuclear inflammation which is transmural. The word to be picked here is the transmural throughout. All 4 layers have inflammation. That's it. Can we go ahead? The next is the ulcerative colitis. I already told you it start from rectum. And there is continuous involvement. There is no skip lesion, and by continuous involvement it will involve the entire colon and come in the ileum. It is known as backwash ileitis. I told you after pancolitis it caused backwash ileitis. Say yes. So you can see the Crohn's disease, ulcerative colitis. Now coming on the gross of ulcerative colitis, I told you continuous involvement, right? Here the garden pipe appearance is there. Here I told you the wall is thickened, so lumen is narrow. Here the wall is the wall is thinned out, so lumen is wide. So here the name of the pipe is horseshoe, and here the name of the pipe is garden pipe, right? That is the meaning. Here ulcers are very superficial. Between 2 ulcers there is a swelling of the mucosa known as pseudopolyp. The pseudopolyps are there. Here also you can see the ulcers are there, and between the ulcers you can see multiple. So this is an ulcer. See, between the 2 ulcers, this is an ulcer. The mucosa swells up, and the swelled mucosa is looking like a polyp, but it's not a polyp. It is a pseudopolyp, and you can see hundreds of pseudopolyp in ulcerative colitis. This is the endoscopic picture. Please notice. Okay, please take in consideration. Okay, can we go ahead? Can we go ahead? This is known as toxic megacolon. It is completely studded with the pseudopolyps. Toxic megacolon. In severe cases of UC, completely the mucosa is studded with millions of polyps, the pseudopolyps I mean. It is toxic megacolon, and it can progress to carcinoma also. Rarely 1% of the UC leads to carcinoma. CD can never lead to carcinoma, right? Let's see the histology. See the histology. Let me make out the mucosa. Where is the mucosa? It's continuous, 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 continuous. Here there is a breach. Here is a breach. So I can see 1 ulcer, but that too superficial. Where is the ulcer? This one is the ulcer. That's it. It's very superficial. It's not going deep. No, it's superficial. Just in the submucosa, I can see the inflammation only in 1 layer. In submucosa, I cannot see inflammation in muscularis propria and serosa. So inflammation is superficial. Inflammation is also superficial, and it is neutrophilic. So here inflammation is also superficial. Their inflammation transmural. Yahan pe inflammation is superficial. You got it? And you can see one more thing. This one. Can you see a collection of neutrophil? You know, this is villi. The elevation is the villi, the depression is the crypt. The elevation is the villi. The elevation is the villi, the depression is the crypt. The elevation is the villi, the depression is the crypt. So at the crypt, you see a collection of the neutrophils. A collection of neutrophil is known as abscess. It is known as crypt abscess. Crypt abscess. Crypt abscess are very common in UC. You can see one of the crypt abscess. Say yes. Got it? So crypt abscess are common here. Please compare the gross of both of them. Please compare the microscopy of both of them. We will see this difference table. We are done. Compare the gross. Everyone with me? Can we do it? Crohn's disease, ulcerative colitis. Starting point is terminal ileum. Starting point is terminal ileum. Here, starting point is rectum. It goes backward. Starting point is rectum. Okay. Starting point terminal ileum. Starting point rectum. Here, skip lesions are present. Here, skip lesions are absent. We have seen that. Okay. Here, the lumen become narrow. It become narrow, looking like hose pipe. Here, lumen become wide because the wall is thinned out. It is known as garden pipe. Okay. Here, granulomas, fissure, fistula, sinuses, adhesions, they all are very common here. They all are very common. They all are absent here. Here we have pseudo polyps. Here we have pseudo polyps. So let's come, and here we have cobalt stone appearance. I've told you the meaning of both of them. See the microscopy of both of them. This is CD, this is UC. You can highlight, you can make the differences between them. This is CD, this is UC. See the ulcer here, it's deep, it's known as fissure or fistula. See the ulcer here. See the ulcer here, it's superficial. So make it out, make the difference. The deep ulcer, the superficial ulcer, they are in front of you. One unique finding in both of them. Let me tell you, one unique finding. Here we have granuloma in the submucosa. Appreciate. Here we have crypt abscess. It is in the crypt. It is an abscess, crypt abscess in the submucosa. So appreciate, this is granuloma, this is crypt abscess. See the inflammation. See the inflammation. Here inflammatory cells present throughout. It's transmural. Here inflammation present only in submucosa, that is superficial. So this is the thing we have to learn. The two type of inflammatory bowel disease. Say yes. Got it? Everyone got it? Everyone got it? Can we go ahead? Malignant potential only in UC. 1% of the UC can convert into malignancy. CD never convert into malignancy. I hope most of the points I have covered. Anyone having any doubt? Can we solve some questions on that? We are done with IBD, inflammatory bowel disease. Right. So, okay. Can you tell me the next question? This one. Skip granulomatous lesions are seen in. So two clues are given to you. The lesions are skip and lesions have granuloma. What is the correct answer? Is it UC? Is it CD? Is it Whipple's disease? Is it Retter's disease? Currently the question looks very simple to you. Currently the question looks very simple to you because just now I taught you. So what is the correct answer here? Yes, you all know skip granulomatous lesion. The correct answer here is Crohn's disease, because skipping and granuloma both are there, right? You all are right. Pseudo polyps are a feature of. I told you pseudo polyps. Is it Crohn's disease or UC or celiac screw or Whipple's disease? What do you say? What is the correct answer? What is the correct answer? Yes, you all are right. So what is the correct answer? The correct answer here, the pseudo polyps are seen in UC. What are pseudo polyps? Between two ulcers, the mucosa swells up. It is giving like appearance of a polyp, but it's not a polyp. It's known as, it's seen in ulcerative colitis. The next question, the skin involvement along with collar stud ulceration. Collar stud ulceration of the intestine on radiography. It is seen in UC. The collar stud ulceration is important, and sometimes skin involvement is also there. So let's come on the next system. Can I start liver? Are you people there? So the last system I am taking here is the liver. After that, 4 more systems are there. Renal, respi, MGT and FGT. I mean the genital. We can take together genital. So 3 more systems are left after liver. I have covered CVS, I have covered blood vessel, we have covered endocrine, we have covered CNS, we have covered GIT, we have covered breast, and now we are covering liver. Right? So these many will be done today, but 3 still are pending. So I will ask the team to arrange a session for them. If they allow me, I will take these 3 systems also. Okay. So because I cannot compact it now, just for the sake of completion, I skip everything and just touch every topic. It is not my way of teaching. If I teach you anything, it should be in depth, it should be conceptual, although it takes time, but it will build permanent concepts in you. I should not take one-liners, and I cannot take that, like just reading and just telling you the topic. It's not my way of teaching. So I take time, but it is worth giving time, I guess. So we will take 1 more session, maybe 3 hours, not long. In the 3 hours, I can complete the 3 more systems, but some other day, not today. Is it good for you? Is it good? So I will ask the team to give me 3 more hours soon. I will cover renal, respi and genital in that. Okay, let me finish liver. So these many systems are covered in this session. Okay, no problem. Can we go ahead? Okay, let's start with liver. In the liver, I'm going to cover two important topics, hepatitis, cirrhosis, that you cannot miss. The most important and most difficult topics you must say. Give me a minute. Okay. So two most important topics. So let's start with hepatitis. But before understanding hepatitis and cirrhosis, you must know the normal histology of the liver. If you don't understand what is the dual blood supply, what is portal triad, you cannot understand hepatitis and you cannot understand cirrhosis. Okay. So you can see this is the liver. Liver is the largest organ, solid organ in human body. You can see the liver is having two lobes. The right lobe is larger, the left lobe is smaller. You can see this is right lobe, this is left lobe. Right lobe is 4 times larger as compared to left lobe, and the ligament separating the two is falciparum ligament. It is anatomy part, but you should learn the falciparum ligament also. Let me explain you the dual blood supply. Everyone here, now please, it's a difficult topic. Understand the dual blood supply. Can you see this diagram? Can you see? Everyone see this diagram. Now in this diagram, all the organ of human body, I'm talking about liver. All the organ of human body, they have one artery, they have one vein. Artery supply the pure blood and vein carry away the impure blood, right? So liver also have one artery that comes from the aorta. All the organ have the artery that comes from the aorta, no? So you see this is the aorta. Let me highlight the artery with yellow highlighter. Let me change the color. You can see this is aorta. Aorta is carrying pure blood, pure blood. From the aorta, hepatic artery is coming, and hepatic artery is supplying one of the blood supply. So out of the dual, one is normal hepatic artery carrying pure blood to the liver. Like all organs, liver also get pure blood from aorta. The name of the artery is hepatic artery. You can understand. You will say, okay, we got it. Now the entire GIT. Can you see this is entire GIT? The esophagus, the stomach, the intestines. From the entire GIT, the blood is collected and they go in a vein known as portal vein. Portal vein also drains in liver. So the second blood supply is the portal vein. It is not pure, it carries impure blood. So you can see the two yellow. One is hepatic artery carrying pure blood to the liver. One is portal vein carrying impure blood to the liver. Got it? You can see the dual blood supply. This is the meaning of the dual blood supply. Not all organs have dual blood supply. Liver have dual blood supply. One is pure coming from the aorta in the form of hepatic artery. One is impure coming from the GIT in the form of the portal vein. That is dual blood supply. So there is two entry. See the arrow, two entry point. Okay. Now coming on the exit. Both the blood come, both will mix and they exit from one point. The exit point is only one. The exit is only one, that is hepatic vein. Hepatic vein is also known as central vein. The reason I will let you know. This is also known as central vein. So there is only one exit. You can see the hepatic vein or central vein is the exit. So from here it is going out. Just a second. You can see this is hepatic vein or central vein. The impure blood, the mixing of the two blood takes place and it goes out via hepatic vein. This is one of the exit. Why God has given us liver? What is the function of the liver? I am asking. What is liver? So God has provided liver with the cells hepatocytes. You can see these are hepatocytes. Hepatocytes synthesize bile. All the bile collected from all the hepatocytes, it leaves the liver and go in the intestine. It opens in the intestine with ampulla of Vater, the bile duct. So the next exit is the bile duct. Can you see? This is the bile duct. Just a second. Let me highlight the bile duct for you. You can see this is the bile duct. This is the bile duct. See the two entries, see the two exits. The two entry are the two blood supply. One is hepatic artery, one is portal vein. And the two exit, one is blood, one is bile. Blood is hepatic vein and bile is bile duct. Everyone give me a thumbs up. See, this is liver. See the four supply of the liver. Two entry, two exit. Everyone got it? If everyone got it, give me a thumbs up. Give me a thumbs up. So let me cut this liver. If I cut this liver and make a slide of the liver have a hexagonal lobular model. This is hexagon. This is hexagon. So in the entire liver, multiple hexagons are there. The entire liver have millions of hexagon. It's a hexagonal model. Now listen, the two artery and the vein and the central, this bile duct, they all have branches inside. So there is branches of hepatic artery, branches of portal vein, branches of hepatic vein, branches of bile duct inside this. Now at the periphery, at the corner of this hexagonal module, the three out of these four, three are best friend. Who three are best friend? They always travel together. Their branches travel together. Which three are best friend? Let me highlight the best friends for you. The three best friend. The two blood supply, hepatic artery, portal vein and bile duct. These three are best friends. They always travel together. Their branches travel together and they constitute the portal triad. But central vein travels separate from them. After going inside, they separates, right? So central vein is present at the center. At the center of the lobule, this is hepatic vein. Since it is present at center, that's why it is known as central vein. Now you got the reason why central vein is known as central. Hepatic vein is known as central vein because it is present at the center of the lobule. And the three best friends, the triad, the trio, the triplet, they never separate. See, one of them is artery, the hepatic artery. One of them is vein, the portal vein. And one of them is duct, the bile duct. See the triad. At the six corners, see the portal triad. So each of them is known as portal triad. Say yes. Now if you got it, understanding hepatitis and cirrhosis is fun for you. You got this model. So inside this liver, not only this. Now see, God has given the hepatocytes. Can you see the hepatocytes? Hepatocytes are arranged one behind the other like a train, like the bogies of a train. Can you see bogies one behind the other, bogies one behind the other? So they connect the central vein with the portal triad. They connect the central vein with the portal triad. I repeat my words. Central vein is connected with the portal triad with like the bogies. This arrangement is known as trabecular arrangement. Trabecular arrangement is like a train, one behind the other. Okay. Now what is the use? Now between the two adjacent cells, there is a hole, there is a defect, there is a small channel, you can say. Like, have you ever traveled in train? Of course, I guess everyone have traveled. Maybe some of you have not traveled, but I have traveled multiple times in train. In the train, in the broad line of the train, they are connected. The bogies are connected with each other. So in the same way, you can compare. These are the bogies and they are connected from inside with each other, right? Like the train only. So the connections are there. You should ask me, ma'am, what is the reason for this connection? All these cells are synthesizing bile. Imagine this cell is synthesizing bile. This is also, this is also, this is also. These all cells are synthesizing bile. So bile from the first cell is transmitted to the next. It is transmitted to the next. It is next. Finally, all the bile is collected here. Finally, all the bile of all these collected and they will form the bile duct. This is reason for the holes. Imagine if these holes are destroyed by autoantibodies. It happens in primary biliary cirrhosis. PBC is a disease in which autoantibodies are formed against these canaliculi. These are small holes known as canaliculi. So they become blocked. So bile will be synthesized inside the cell, but it cannot be transmitted. So cell will burst. The cell will burst. All the hepatocytes will burst and it will lead to cirrhosis. Such a cirrhosis is known as primary biliary cirrhosis because bile is causing the cirrhosis. Everything have a concept, you know, there is no rectification. If you understand the concept, pathology is fun. Imagine pathology is a beautiful subject, the colorful subject. Images talk with us, they speak with us. The only thing we have to understand their language. Okay, pathology is a language per se. As a subject, you have to understand it as a language. It's very easy. It's like a fun. It's very interesting if someone may taught you like this. Okay, so that is the thing. So you understood the histology of the liver. Not only this, we will not stop here. Between the two trains, there is a capillary. The capillary is known as sinusoid. Let me draw two trains separately. By train, I mean the hepatocyte. This is one row of hepatocyte. I mean to say one trabecular of hepatocyte. This is another row of hepatocyte, another trabecule of hepatocyte. They are interconnected with each other. As I told you, canaliculi are there between the adjacent hepatocytes. Okay, this is trabecular arrangement. Between two adjacent trabeculi, there is a sinusoid. The capillary is known as sinusoid. The capillary or the sinusoid is lined by the endothelial cell. This is endothelial cell, right? In between, intermittent macrophages are known as, which are known as Kupffer cell. You know, macrophages of liver are known as Kupffer cell. So intermittent Kupffer cells are present. Not continuously, intermittent Kupffer cells are present in the capillary or sinusoid lining only. There is a space. There is a space. Just a second. Between the hepatocyte and the sinusoid. Between the row of hepatocyte, that is trabeculi, and the sinusoid. This space is known as space of Disse. This space is known as space of Disse. What does it known as? This space is known as space of Disse. Space of Disse. It also contains a cell. It also contains a cell. Which cell can you name it? Eto cell. It contains few cells which are known as Eto cell. Eto cell. What is the function of Eto cell normally? Eto cell normal function is vitamin A storage. They store vitamin A. But at the time of the liver injury, if these hepatocytes are injured, can you see these hepatocytes? If anything is causing injury to these hepatocytes, now the Eto cell which are present in space of Disse, they get stimulated and they convert into myofibroblast. The myofibroblast synthesize collagen. It synthesizes collagen. The collagen causes fibrosis and it leads to cirrhosis. You cannot understand cirrhosis if you don't know Eto cell. Come on. Okay. So if you understand Eto cell, then only you can understand cirrhosis. So understanding histology is very important if you want to understand pathology. You cannot understand pathology without understanding the histology of liver. If I directly jump on the hepatitis, you know, bridging fibrosis, the fancy terms, you will say, what does it mean if you don't know the basics? Come on, it takes time, but it will build your concepts permanently. Can we go ahead? Can we go ahead? Okay, thanks for the compliment. Thank you so much. Can we go ahead? Okay. So this is the normal histology I have covered completely. You know all the cells now. Now we are ready to start with hepatitis. Let's start hepatitis. Okay. So there are 5 types of hepatitis caused by 5 types of viruses. This topic is important in microbiology also. This topic is important in medicine also. So we are covering from all the aspects. Okay, there are 5 types of hepatitis. Hepatitis A, B, C, D, E. Make it C. By mistake it's G. So A, B, C, D, E. 5 types of hepatitis caused by 5 different types of viruses. Hepatitis A caused by hepatitis A virus. B is caused by B virus. C is by C virus. D is by D and E is by E. The family of all these viruses is different. Only B of them is a DNA virus. Rest all of them is RNA viruses. I hope you know the classification of the viruses in microbiology. If you don't know, you must read it. Okay. So the classification of the viruses, you can see the hepatitis B virus is a DNA virus, rest all are RNA virus. First thing you have to learn that. Okay. A hepatitis A virus is the enterovirus, B is the hepadnavirus, C is flavivirus, D is viroid or delta virus, and E is calci. This is C, calcivirus. So you have to learn the name of the family. Number 1. Learn the incubation period for all of them. The next point I would like to tell you, I would like to draw a diagram. Imagine this is a human and imagine this is a human. Okay, I want to give you a concept here. Imagine this person having A or E, hepatitis A or hepatitis E. A and E both are excreted in feces. They are excreted in stools. So A and E are excreted in stool. So the stools will contaminate the food and water, and via contaminated food and water it can be transmitted to other person. So other person can also have A or E. So the route of transmission for A and E is said to be feco-oral route, right? Via contaminated food and water. A and E transmit by feco-oral route. Say yes. Got it? Now let me draw the same individuals again. What about BCD? What about BCD? Hepatitis B, C, D viruses are not shed in stools. They do not shed in the stool. So feco-oral route is not in them. It is not possible in them. So how does they transmit from one individual to another? So B, C, D transmit either by sexual route between the two individuals. The sexual route is there, or most common, even common than the sexual route, it's parenteral route. Parenteral route. You know, by parenteral route, by sharing the common syringes, the common needles, that is the parenteral route. So it can be sexual route, it can be parenteral route, or it can be perinatal. By perinatal, I mean this individual is inside this individual. I mean this is the fetus and this is the mother. So by perinatal route or vertical route, it is through the placenta. It is through the placenta from the mother to fetus it can spread. So there are 3 routes. You got it? Can we go ahead? You got it? So please learn the route of transmission. For A and E, it's feco-oral. The remaining all either sexual or perinatal or percutaneous. Percutaneous is parenteral. So you can see. You got it? Say yes if you got it. So you can see the 5 types of hepatitis A, B, C, D, E. You can see the viruses causing them. Hepatitis A virus, B virus, C virus, D virus, E virus. Okay. You can see this one is DNA, rest all are RNA. You can see that. Okay, this one is feco-oral, this one is feco-oral, rest all are either parenteral or close contact means sexual or perinatal. As I have told you, learn the incubation period by yourself. It is rectification. I am not telling you, please learn the incubation period of all of them. Now, the most important thing which I would like to tell you here in hepatitis A, B, C, D, E. The 5 types of hepatitis. What I would like to tell you here, let me tell you. The 5 types of hepatitis. What about acute and chronic hepatitis? Have you heard the 3 types of hepatitis? Acute, chronic, fulminant. What does it mean? Acute can be caused by all 5. I will tell you the histopathology. Acute hepatitis caused by all 5. Most importantly, acute hepatitis 99% time it recovers. Sometimes self-recovery or sometimes with treatment. But it recovers. It recovers. Acute se dar nahi lagta. It is recovering. Okay, 99% time. 1% time acute become more severe and death occurs. It is known as fulminant. Fulminant is very fatal. It's very fatal. The fulminant hepatitis is the most severe form of acute. So in all 5 acute possible. In all 5, 1% of the acute is fulminant. Okay, what about chronic? AE never leads to chronicity. A and E never leads to chronic hepatitis. BCD can lead to chronic hepatitis. Please learn. BCD can lead. Chronic is never curable. Once occur, there is no cure. There is no cure. There are two fates. Either it will result in hepatocellular carcinoma or it will result in cirrhosis in each of them. So there is no treatment. Okay. And it leads to carrier state also. So chronicity, HCC, carrier state, cirrhosis is seen in BCD, but these all are absent in A and E. In A and E, no chronicity, no HCC, no cirrhosis, no carrier. In A as well as E. But in BCD, it's possible. Say yes. You got it. You got it. So that is the thing. You can see the carrier state. You can see the chronic. Chronic is none here and here. And in between, it is possible. So please learn the basics. Now among them, A, B, C, D, E. I wish if I can teach you all 5, but the most important among them is B. So I will give the discussion of the B only, and after that I will come on the histopathology of acute and chronic hepatitis. Okay, so B. Can you see the diagram here? This is hepatitis B virus. It's known as Dane particle because it is discovered by the scientist, the person Dane. That's why it is known as Dane particle. Can you see this one is DNA virus? Only B is DNA, rest all are RNA. Please interact. Come on, give me a thumbs up. You got it. Say something in between here. Come on. Okay, so you can see this is hepatitis B virus. It is a double-stranded DNA virus. Appreciate it. On the surface of the virus, 3 antigens are present. The first antigen you can see S. S for surface. S for surface antigen. S for surface. Okay, the first word. The second is E. E for envelope. It is present on envelope. That's why E. Right? And C for core. The third one is the core. C for core. So you can see the 3 type of antigen. S, E and E. You can see this virus enters human body. Imagine this virus is entering human blood vessel. Let me draw a human blood vessel. Once it go in blood vessel, now out of the 3 antigen, 2 leak out and come in the blood. So which 2 leak out? This one will leak out in the blood, hepatitis S antigen, and E will also leak out in the blood along with the DNA. DNA will also leak out in the blood. C never leaks out. C never come in blood. It is present in core, na? It is deeper. It will never leak out. So in the blood you will get 2 antigen. S you will get and E you will get. C you will not get in blood. Please mind my words. Now bodies start forming antibodies against all 3. So against the S, body form anti-S. Against the E, body form anti-E. Right? C is not coming in the blood, so he is feeling bad. It's a mnemonic, huh? The C is feeling bad, you know. So body is giving 2 antibodies to that, just to learn. Okay, 2 antibodies, anti-C. The 2 types of anti-C, IgM and IgG. So total 4 antibodies are present. So if you check the blood, 2 antigen and 4 antibody, total 6 markers. These are known as serological markers of hepatitis B. You got it? So you can see what are the 2 antigen. Can you tell me? What is their sequence of arising? The 2 antigen is S and E. And the antibodies are anti-S, anti-E, anti-C. The 2 types of anti-C, IgM and IgG. Say yes. Got it. Got it. Can we go ahead? Huh? So what is the sequence of their arrival and what is their significance? What is the sequence? Of course, first antigen will come, then antibody will come. Common sense. First antigen will leak and come. So first antigen coming is S followed by E. Antigen is over. Okay, along with E, DNA also leaks out. They come together in the blood, E and DNA. What about the antibodies? C is not coming now, so C is feeling bad. Why I'm not coming in the blood? So first antibody will come of C, just to learn. It's a mnemonic. Okay, so C antibody, anti-C will come. But there are 2 type of anti-C. So first IgM is coming. Then anti-E is coming. Then again C is coming. C ka IgG is coming this time. And now last is S. So my point is that the first antigen is S, the last antibody is of S. Say yes. Say yes. Got it. Got it. These are the concepts. This is how you have to study. Conceptual. Okay. So see the antigen. The first antigen is S followed by E. The 2 antigens are over. C antigen, antigen. Coming on antibodies. Antibody. C antibody, 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 antibody. So anti-C followed by E followed by again C and followed by S. Okay, and this time the C is IgM and this time C is IgG. You got it? If you want to learn the mnemonic, SE is the mnemonic for antigen and for antibody CECS. This is the mnemonic. You have to learn the sequence SECECS if you want to learn at all. So this is IgM and this is IgG. You will say, ma'am, okay, we got there are 2 antigen, we got there are 4 antibody, total 6 markers are there, you got everything. I know you got everything. Okay, now the point is that what's the relevance of each of them? What is the relevance of each of them? Why it is necessary to understand? Being a doctor for me, why it is necessary? Let me tell you the relevance. First, so let's take pair by pair. Let me talk about the first pair, this pair, S ka pair. S का pair. Now S का pair, the antigen and antibody never present together. In one person, either the antigen will be there or antibody, they never present together. Okay, because the antigen represent infection. The person is having infection and the antibody present recovery. One person either can be infected or can be recovered. Both things cannot happen simultaneously, obviously. So either the antigen is present or the antibody is present. Say yes. The antibody also represent vaccination. Are you vaccinated for hepatitis B? I am vaccinated. If you're not vaccinated, you should vaccinate it. Okay. So if you are vaccinated, so your body will have anti-S antibody. These are the protective antibodies. Okay. So that is S. That is the relevance of S. Coming on the next pair, E. E. Okay. E ka antigen, E ka antibody. Again, they never present together. One of them will be present. Right. E ka antigen represent high infectivity. What is infectivity? And E K antibody represent low infectivity. So it is not infection, it is infectivity. Infectivity is a tendency to infect others. You know, the communicability to infect others, right? So E is related to infectivity, high or low, antigen and antibody. The third is last C. C ka antigen to no, it doesn't come in the blood. No, wo to aata hi nahi hai. The antigen of the C don't come in the blood. What about the antibodies? We have two antibodies. So IgM indicate acute or recent infection and IgG indicate chronic or past infection. Say yes. Got it? Got it? So this is the relevance of all of them. The relevance is written. You can read the relevance of all of them. You can notice the graphs. This is this year NEET PG question. Right now the NEET PG was there a few days back. So I'm sorry, INI-CT. So this year INI-CT question is there. The question was based on this graph, right? So you can make it out. The first antigen is coming is HBS, followed by HBE along with the DNA. So this is the graph. Okay. After that, in the antibodies, first antibody is anti-HBC, which is IgM. After that, anti-HBE. After that, anti-HBC, which is IgG. Okay. And the last to come is HBS. You can see the sequence. Now, if you know the sequence, if anything is missing in the graph, they can frame, the examiner can frame an image-based question. If anything is missing, you can answer that. If anything is missing, say yes. Come on. You got it or didn't got it? Can we go ahead? Okay. So please learn the sequence. Now, the most important thing here, which I would like to tell you, is the, how to interpret the serological markers, the report. Don't see the answer. I'm having 6 patients. Patient 1, 2, 3, 4, 5, 6. 6 subjects in front of you. The reports you have to see. See HBS antigen positive or negative, anti-HBS antibody positive or negative. These two are related to S. Okay. These two are related to E. E ka antigen, E ka antibody. Okay. And last is HBC. Anti-HBC, I mean IgM or IgG. Now read the report. Imagine first patient. This is first patient. Read the first patient. S ka antigen is positive, antibody is negative. What does it? It gives the conclusion. What does you interpret? So patient have infection, no recovery. Infection is present, recovery is not there. E ka antigen is positive, antibody is negative. So it is of high infectivity and it is IgM. So it is acute. So answer is acute infection of high infectivity. This is my answer. So from this point now you can cover all medicine MCQs also, not only pathology. You got my point? So you should know the importance. You will get a big clinical question. There is a 47-year-old man. A big clinical scenario will be there. Presented with jaundice, presented with loss of appetite. On palpation, there is right hypochondrium tenderness. I mean, they want to say you hepatomegaly, right? So hepatomegaly is there. Hepatomegaly is there. Like it will be a big question. Now they will give you the serological markers. The hepatitis S antigen positive or negative. The antibody is positive or negative. The E is positive or negative. Antibody is positive or negative. And among the C, which one is positive? And they will ask you. They will ask you for the conclusion. In conclusion, these will be the option. If you know the interpretation, you can make it out. If you know the interpretation, you can make it out. Okay, you got it? I cannot see your chat. Okay. Can we go ahead? Yes. In the same way, you can do the interpretation. The second case, third case, you can see IgM, IgG will decide acute or chronic. And last, you must see immunization. If you check my blood, everything is negative apart from anti-HBS. Anti-HBS is positive, rest all is negative. Can we go ahead? The next is the acute, chronic and fulminant hepatitis, the histopathology. Let's talk about acute hepatitis. I told you all 5 can cause acute. A, B, C, D, E. All 5 can cause acute. This is a diagram of acute. Let me explain. The diagram is same for all. The diagram is same for all hepatitis, whether it is A, B, C, D, E. What is this diagram about? Have I explained you this diagram? Have I explained you this diagram? I guess I have explained. This is the central vein in the center, and at the 6 corners you can see portal triad. What does the portal triad contain? Hepatic artery, portal vein and bile duct. Okay, this is portal triad. Now I cannot say all 6 portal triad here in this diagram. So I will draw one central vein and one portal triad in this diagram. I have drawn one. So see diagonals. You can choose any diagonal. At this diagonal, this is the central vein. At this diagonal, this is the portal triad. You can see. And connecting them is the row of hepatocytes. Can you see the row of hepatocytes are connecting them? Okay, I am teaching you acute hepatitis. Okay, in acute hepatitis, 4 types of injury occurs to these hepatocytes. The first injury which is occurring is the balloon degeneration. Can you see some of the hepatocytes I am marking with green color? They all are swelled up. They all are swelled up, right? These are known as balloon degeneration. Can you see these type of hepatocytes I am marking here with red color? Some of the hepatocytes have intense eosinophilia and the nucleus disappear. This one is known as Conselman body. Some of the hepatocytes shows Conselman body. The third type of hepatocytes, the necrosis is there. Can you see the necrosis? The hepatocyte disappear. There is no center, only periphery is present. So it is known as dropout necrosis. Some of them are showing dropout necrosis. The third thing, sometimes it is not shown here, the complete row of the hepatocyte is showing necrosis. It is known as bridging necrosis. So 4 types of injury are there. What are the 4 types of injury? Can you please enumerate? So it's balloon degeneration, Conselman body is also known as acidophilic body, dropout necrosis and bridging necrosis. What does it mean? I have shown all of you. Some of them swells up. It is balloon degeneration. Some of them, the cytoplasm become intense pink and nucleus disappear. It's Conselman body. Some of them, hepatocyte undergo lysis. It's dropout necrosis and the complete row is necrosed. It is known as bridging necrosis. Please learn these 4 findings in acute. Please learn. Along with that, see the portal triad. In the portal triad, where is the artery? I guess you all can make it out. This one is the artery. This one is the vein and this one is the bile duct. Okay, we got that. But I can see a number of lymphocytes in the portal triad. It is known as inflammation in the portal triad, triaditis. It is known as triaditis. So triaditis is also a finding. So that is about the acute. You got my point? Shall I come on the chronic? In the acute hepatitis, what are the findings? The 4 types of the injury. Can you please enumerate the 4 types of injury? Say balloon degeneration. The second was Conselman bodies or acidophilic bodies. The third one was dropout necrosis, only one hepatocyte necrosed, and the complete row is necrosed, it's bridging necrosis. These are the 4 findings upon along with triaditis. That is acute. Please learn that. Coming on the chronic hepatitis. The next is the chronic hepatitis caused by B, C, D. A and E never cause chronicity. I told you. This is the diagram. This is normal. This is normal and this is chronic hepatitis. You can compare. In the normal, you can see this is central vein, this is portal triad. And you can see the row of hepatocytes beautifully connecting them. It is a lobular model. You can understand the lobular model. Okay. Now please learn the first hepatocyte of all the trabeculae. Like you can say the engines of the train. All the engines of the train. It is known as limiting plate. It is forming a plate known as limiting plate. Now compare it on the chronic hepatitis. So compare, where is the limiting plate? The limiting plate is gone. I cannot see the limiting plate. It is known as piecemeal necrosis. What does it known as? The first thing is the piecemeal necrosis. Why it is not going? Just a second. Why this drawing is not going? Yeah, it's piecemeal necrosis in which the limiting plate is necrosed. So I cannot find the limiting plate here. The limiting plate is gone. The limiting plane is gone. So it is known as piecemeal necrosis, number 1. And triaditis is there. Here also there is triaditis. Compare here. Here we have only artery, vein and duct. But here along with artery, vein and duct we find multiple lymphocytes also. So triaditis is here also. So piecemeal necrosis is there. Triaditis is there. Apart from that, you can compare the hepatocytes. Here all the hepatocytes are healthy. No injury. Here in the hepatocytes, we can see acidophilic bodies. Here also we have bridging necrosis, dropout necrosis. Here also we have. Here we have one unique finding which is not present in acute, which is present on only chronic. The complete row of the hepatocyte undergo fibrosis. It is known as bridging fibrosis. There we have bridging necrosis. Here we have bridging fibrosis. So that's all about the chronic. Bridging fibrosis is a unique thing. So that is the chronic. So in acute, in chronic. Can you enumerate the features, please? What we have learned? In acute, we have learned 4 findings. Balloon degeneration. What is the next one? Conselman bodies or acidophilic bodies. The next one is dropout necrosis, and here we have bridging necrosis. Here we don't have balloon degeneration, we don't have bridging necrosis. These two are common. Here also we have Conselman bodies. Here also we have dropout necrosis, but instead of bridging necrosis, we have bridging fibrosis, which is unique here. That is my point. Along with that, we have piecemeal necrosis here, piecemeal necrosis, and we have triditis both the ways, in both of them. Give me a thumbs up. Come on, I'm trying hard here. Come on. Please take these catchy words, which is present in acute, which is present in chronic. That's it. We are done with hepatitis also. We are done with hepatitis also. So do you find this session useful? So I would like to end it here. It's already 3 o'clock. So at 3 o'clock, I have to finish the session because I'm having some other commitments. Okay. So I have to finish the session right now. But whatever is pending, kindly enumerate. I will cover all of this in one more session. So till now, let me enumerate. The renal system is pending. Respiratory system is pending. And genital system. The male and female genital system both are pending. So these 3 systems I will cover in one more session. If you wish, we can plan oncology also separately, in which I can cover the oncology of complete pathology together at one place, the histopathology of all of them. So we can plan more sessions. Don't worry, we will meet again. Hopefully we will meet you soon, and thank you so much. Don't forget to give your feedback. So do you find this class useful? The pathology, yesterday I taught you general pathology and few important topics of hematology. Today we have taken many important systems of systemic pathology. I guess from the morning 7 to 8 systems are covered. 3 or 4 are still pending. Okay, total 12 systems we are having. Thank you so much for being with me, and that's all. See you again. Bye-bye. Wishing you all the best for your exams. Bye-bye.